Good morning. It's a true pleasure and an honor to have everyone here today. Welcome to the first annual Cardioinflammatory Symposium, Management of Cardiometabolic Risk, Inflammatory Conditions, Improving Treatment for Psoriasis, Inflammatory Arthritis, Lupus, and HIV. I'm Michael Garshick, part of the Center for the Prevention of Cardiovascular Disease at NYU, within the Division of Cardiology, and I run a cardiorheumatology risk reduction clinic. With me is my co-course director, Dr. Nehal Mehta, really a leader in this field, who is a last year senior investigator and chief of inflammation, cardiometabolic disease at the NHLBI. Throughout the day, if posting a comment on Twitter, I would really please invite you to tag us. We have provided helpful links below, NYU CVD Prevent, at Garshick, at the Bethesda Labs, or at Nehal Mehta, MD. So thank you for joining us virtually. We have almost 300 people registered. And one of the benefits of the virtual meeting, it really allows from people across the world to join us, including those from Turkey, South America, Central America, Australia, Canada, Alaska, and Hawaii. And this symposium is sponsored by the Center for the Prevention of Cardiovascular Disease. We provided links to both the center and our cardiorheumatology program. And if you like what you see here, I'd encourage you to sign up for our newsletter and events calendar. You can email us at hearthealth@nyulangone.org. And the symposium, I would also like to highlight some other upcoming CMEs. We have our Dietary and Lifestyle Strategies course on October 15th. And we also have another symposium, this is running away from me, on Thursday, December 2nd, 2021, our Cardiovascular Risk Reduction Symposium. I would encourage you to check out our exhibitors during our scheduled breaks. And finally, I'd like to give you a huge thank you to Anya Coates, one of our senior administrators, who's really been a driving force behind this conference. So we believe that chronic inflammation and the resulting mortality is at the forefront of medicine. And our goal is not just to make people aware of the links between chronic inflammation and cardiovascular disease, but also to move the dial forward in terms of aggressive prevention management strategies. To that end, our symposium is divided into 4 sections. The first is inflammation and cardiovascular disease, related talks by Dr. Paul Ritka, myself, Dr. Mehta. Please, we have question and answer sessions at the end. Please ask your questions, and we have saved about 15 to 20 minutes to get to those. So section 2 is meant to be more clinically focused, management of cardiovascular risk and 4 inflammatory conditions, with talks from Dr. Solomon, Dr. Kaplan, Dr. Gelfand, and Dr. Hugh. We have a brief break, and then during our lunchtime hour, we have a really exciting talk by one of our nurse practitioners, actually Monica Ricky, who's subbing in for Jillian Rose, who's going to be giving a talk on barriers to implementing dietary and lifestyle modifications in pro-inflammatory conditions. We'll move to a little more preclinical in section 3 with a discussion on playlists from Dr. Berger, the microbiome with Dr. Scher, and a section on vascular inflammation with Dr. Hoffman. And I know it's a really long day, but I really hope you'll stick around to the end. We'll discuss clinical pearls and the approach to cardiovascular risk in these inflammatory conditions. And really what I think will be a wonderful highlight talk by Dr. Leahy Eater, who runs a really robust cardiorheumatology research program and clinical program up in Toronto. And I know before we begin, I know my co-director, Dr. Mehta, would like to say a few words.
Michael, thank you. It is such a great pleasure to be here and run this course with you and the Prevention Center at NYU. The NHLBI has energetically coordinated a lot of these symposia talks based on evidence and literature, as well as clinical practice guidelines. To each of the speakers out there, on behalf of Michael, NYU, NHLBI, and myself, I would like to just say thank you. We know that you are busy and it is difficult because everyone is asking for your time virtually, which means you have 30 hours in a 24-hour day. So thank you. I appreciate that very much. Michael and I have put together a journey through what we would consider to be some inflammation sciences, hearing from world leaders in disease states, moving to pathophysiology to get your science minds thinking. And as Michael said, I cannot stress enough the importance of trying to make it out to the end of the day at that last session where we're putting it all together from 3:40 to 5 o'clock. It promises to be really exciting to say, hey, what can we do to move the dial forward? So with that, I would like to introduce Dr. Jeffrey Berger, who's going to moderate our first session on Section 1, Inflammation and Cardiovascular Disease. Jeffrey, thank you. And I know that most know that you're the director of the Center of Prevention for Cardiovascular Diseases at NYU. So thank you for hosting this wonderful event.
Thank you so much, Nehal and Michael. You guys really have done a tremendous job putting this CME together. I'm excited to be here. I'm excited to be moderating the first session, and the first section is titled Inflammation and Cardiovascular Disease. There are 3 phenomenal speakers, so I'm going to get started and introduce our first speaker. Our first speaker is Dr. Paul Ritker, who will be talking about inflammation and atherosclerosis in 2021. Where do we stand? Dr. Ritker really needs no introduction. He is very well known for all of his pioneering work on inflammation, biomarkers in this area. He really has just emphasized and shown us all how important inflammation is in cardiovascular disease. He serves as the Eugene Brumwald Professor of Medicine at the Harvard Medical School and directs the Center for Cardiovascular Disease Prevention at Brigham and Women's Hospital. So I'm going to let Dr. Ritker take over and give us his first talk. Thank you very much for coming, Dr. Ritker.
Well, Jeff, thank you enormously for the honor of being able to open up this conference. Big thanks to Nehal and Michael for asking me to do so. I'm delighted to be here for a variety of reasons. As Jeff points out, this is the work we've done for the last 30 years, and the fact that it's expanding into other areas has been incredibly gratifying. What I'm going to try to do in this opening talk is really just give an overview of inflammation in 2021. Where have we been? Where are we going? I will try to show a little bit of new data at the end. But I think for any young folks in training listening to this, I also want to make another analogy I've made to our own folks at the Brigham. I remember about 15 years ago when cardio-oncology became a new subspecialty of cardiology, and a couple of very smart young people said, aha, I can see a future there. I will predict to you that cardio-rheumatology, what this conference is all about, is also an area within the cardiovascular community that's going to explode. And those of you who can think of this as a career path, I think will do just fine down the road. So let's see if I can, there we go, great. I've got a variety of conflicts shown here. Okay, so this is a slide that I have used for almost 25 years when I open up the cardiovascular pathophys course at Harvard Medical School. Where we talk about inflammation, atherosclerosis. That's a course where when I sat in those seats as a student, trust me, we did not talk about inflammation at all. We were just trying to figure out that atherosclerosis was a disorder of lipid accumulation. But you know, the descending aorta on the left filled with atherosclerosis shares an enormous commonality with the patient with RA and the patient with psoriasis. And we have real experts in the lineup today who know a lot about the diseases on the right. I know a little bit about the disease on the left, and the core question that has really driven our work for this 30 years is, can anti-inflammatory therapy actually reduce cardiovascular event rates? I'm going to start with a clinical concept of residual inflammatory risk. This is a term that we coined a couple of years ago because we were struggling to get our clinical cardiology community to wrap their heads around why inflammation really mattered. So I have a standard atherosclerosis clinic. It's filled with individuals who have both hyperlipidemia and elevated levels of high sensitivity CRP. Like any good cardiology clinic anywhere, and certainly true at NYU, they're all going to get a high intensity statin along with diet, exercise, smoking cessation, and what we'll hear about in terms of lifestyle interventions later today. And then we have this term residual cholesterol risk, which has been used very effectively to say, hey, if the LDL is still too high, to me that means above 100 despite being on the statin, there's other things you could do. You could give ezetimibe, you could give a PCSK9 inhibitor, you could think about other ways of getting the LDL to come down. But the numbers you see on the screen are crucial to this audience. There are 3 patients with residual inflammatory risk, the patient on the right, for every 1 patient with residual cholesterol risk. And residual inflammatory risk is defined here as, well, the LDL is taken care of. It's down around 65, 70, 75, or 80. But the CRP, which was at 4.5, it does come down with a statin. That's what we showed 25 years ago, but it's still quite elevated. It's at 3.8. And what we have today is an extraordinary set of clinical trials saying you can attack that biology. And I'm going to argue, I think that's the biology you should attack if your patient has residual inflammatory risk, particularly if their cholesterol is already well taken care of. But how do we get there? So in the early 2000s, 2000, 2001, 2002, we published a series of papers that you see here arguing that you could measure inflammation the same way that we were measuring blood pressure or LDL cholesterol, and you could do a very good job predicting future vascular risk. The data on the left are graphs of lipid levels plotted against CRP, serum amyloid A, another pentraxin, interleukin 6, and ICAM1, trying to define this idea that a variety of markers of innate immune function could augment lipid screening. And the data on the right came from a study of nearly 35,000 healthy middle-aged women followed for 15, 20 years, showing that CRP levels were just as predictive as were LDL cholesterol levels. But the critical observation was they have very little to do with each other. Now, biologically, we'll hear later in the symposium, there's a tremendous interaction between hyperlipidemia and inflammation. But from a screening perspective, you can't predict A from B. And this was just to demonstrate that we thought people really ought to be thinking about inflammation as a way of understanding who's at future risk. So that's the early 2000s. Later on, we would publish some data about statins. I'm not going to go through that here in any detail. Statins are drugs that we would show were both lipid lowering, but also had anti-inflammatory properties. And that concept, again, was incredibly radical at the time. The data came out in 1998, and it would take 15 years for the clinical community to sort of say, well, might be the case. The data on the left come from the Prove It trial, showing that when you gave a statin, clinical outcomes were clearly superior if you achieved what we called at the time the dual goals of reducing LDL to a target below 70, reducing CRP to a target below 2. That's the red survival curve. On the right-hand side is data from the Improve It trial from Aaron Bahula a decade later, showing the exact same thing, that the combination of ezetimibe and a statin, patients just did a lot better if they got the inflammation down as well as getting the LDL down. Now, our national guidelines still don't reflect this, but this is where I think those of you thinking about the intersection of inflammation and hyperlipidemia understand the world to be. In 2008, we published results of our Jupiter trial, which I'm going to summarize in a single slide here today. This was, again, a somewhat radical trial at the time. We in 2001, when we began, the guidelines said, you should consider a statin if your LDL in primary prevention was greater than 160, and you should lower it all the way down to 130. That was the guidelines in 2001. Well, we said that really doesn't make sense. Most patients suffering myocardial infarction in primary prevention have LDL levels below that. We knew about the CRP phenomena, that these people had high risk. So we designed a clinical trial where nobody would ever get a statin under any guideline, because the average LDL cholesterol when you entered Jupiter was only 100, but the CRP was above 2, and we had a 44% risk in the primary endpoint of MACE+, a 63% reduction in myocardial infarction, a 48% reduction in stroke, 46% reduction in coronary revascularization, and it's the only statin trial to ever show a reduction in all-cause mortality that was statistically significant. Now, Jupiter was important from a intellectual point of view for changing guidelines, and what the guidelines did is they said, okay, we now recognize that many, many people have vascular events who do not have hyperlipidemia. We will therefore expand our guidelines worldwide, which was terrific, to include far more patients. And that's a very good thing. But Jupiter obviously was not a test of the inflammation hypothesis of atherosclerosis, because we used a drug that, yes, had anti-inflammatory properties, but also had, obvious lipid-lowering properties. So the question that would evolve is, how can we directly test this notion that targeting inflammation itself would fundamentally alter clinical outcomes? You're going to see later today, particularly in the more basic sections, various descriptions of the NLRP3 inflammasome, which sits central to this process of activating interleukin-1 beta and also interleukin-18, which has direct vascular effects, also upregulates interleukin-6, the central cytokine that we think is driving most of this issue. And again, we're talking today to a group that has broad experience in rheumatologic diseases, so they know this pathway quite well. IL-6 obviously also upregulates CRP production in the liver, and that's just our biomarker, a very useful clinical biomarker. But other acute phase reactants that come out of the liver have real functional issues. That would be plasminogen activator inhibitor type 1, PI1, and fibrinogen, very involved in thrombosis, which Jeff Berger is really truly expert about. Now, we knew that this pathway existed, and we knew there were drugs already available that could target this, and we thought this would be the way to go. So when we designed our Cantos trial in roughly 2010, just after Jupiter ended, we were trying to figure out how could we directly test the inflammation hypothesis of atherosclerosis. And the idea was to pick a drug that we knew would target this central interleukin 1 to interleukin 6 to CRP pathway, but would not have any effects on LDL, HDL, triglyceride, blood pressure, etc. It was like a large experiment. Can we isolate a true anti-inflammatory property? Anyway, 10,000 patients in 39 countries. The trial ran from 2011 to 2017. Now, this was secondary prevention, unlike the Jupiter trial, which is primary prevention. Everybody here had this residual inflammatory risk concept. So despite being on very aggressive care, 2/3 of these people are already revascularized. Everybody's on a high-intensity statin. They're on ACE, ARBs, beta blockers, and aspirin. They're well-treated patients. They then got randomized because they still had a CRP above 2 to one of 3 doses of an interleukin-1 beta monoclonal antibody known as canakinumab or placebo. And this is a drug that had been used to treat Muckle-Wells syndrome and was an orphan drug that Novartis had. And so Peter Libby and I would fly to Basel and try to pitch this trial to Novartis back in 2010. This is sort of the punchline of the scientific experiment. We observed, as expected, dose-dependent reductions in CRP, dose-dependent reductions in IL-6. But the crucial issue for my cardiovascular colleagues at the time was no change in LDL, HDL, triglycerides, and not shown on this slide, no change in hemoglobin A1C that mattered, and no change in blood pressure. So a pure targeted anti-inflammatory response. And the excitement from the trial was we got a 15 to 17% reduction in MACE and MACE plus at the middle and higher dose of the trial. And this was, for my community, quite revolutionary because we have the first proof of principle that you can target directly inflammation to lower vascular event rates. And what was so interesting about 2017, the year this came out, is this was also the same year that Fourier, the first big PCSK9 trial, reported out, and the curves are identical. So if Fourier said we can get a 15 to 17% reduction by taking LDL cholesterol down to 15 or 20, we were saying we can get the same 15 to 70% event reduction without budging LDL cholesterol at all. And I would argue, but I do see the world through inflammation-colored glasses, that tells you what the upside is here, that we have an enormous upside to think about in this arena. Now, my colleague Brendan Everett was able to show that we also had a reduction in hospitalization for heart failure. This conference today is about cardiometabolic complications associated with inflammation, so I wanted you to be aware of that. And again, this was the first time that the idea, which had been around for 20 years, that we might be able to modify inflammation for heart failure. This is the data that now finally supports that. Now, I think most in this audience are well aware that you cannot use canakinumab in an atherosclerosis setting, not because the FDA did not want to approve it, but because the sponsor, Novartis, had a change in their priorities with this drug, because simultaneously within Cantos, we discovered something that may in the long run prove even more important. And that was that in this trial designed for atherosclerosis prevention, we knew about a literature related to inflammation in the tumor microenvironment in the lungs that might lead to certain cancers, in particular non-small cell lung cancer. And this finding, published simultaneously with Cantos, has radically changed where this drug is being developed for, because you see here placebo on top and then low dose, middle dose, and high dose. This is incident lung cancer. We're talking here about a 67% reduction in lung cancer. We had very similar data for fatal lung cancer. And so this drug is now being developed extremely aggressively for the purposes of oncology. Now, later in this symposium, you're going to hear from Dan Solomon. He worked with us within Cantos to show how this IL-1 blockade would improve incident gout. I'll let him talk about that. We worked with Monica Valluparali at the Brigham to show that we could alter incident anemia, another chronic inflammatory disease. We worked with Matthias Schurker and others to show enormous effects on osteoarthritis, the incidence of hip and knee replacement. And I show these data simply to remind you that when we're talking here about chronic changes in inflammation, we're talking about a host of potential benefits for patients that really, when one thinks about it, are addressing long-term issues of aging. And so no surprise, the National Institute of Aging is very interested in this whole direction. Now, this audience is uniquely aware that when we designed Cantos, we worked with the NHLBI to simultaneously design our cardiovascular inflammation reduction trial, or CIRT. That trial, we elected to use low-dose methotrexate, obviously a primary drug for treating rheumatoid arthritis, but it was a neutral study. To our surprise, and I think to many people within the rheumatology community surprise, in a non-RA population, people with atherosclerosis, we did not get a reduction in IL-1 beta, IL-6, or CRP, and nor did we get a reduction in vascular event rates, nor did we get a reduction in lung cancer. That's incredibly informative because, as many in this audience are well aware, the pathway by which methotrexate lowers inflammation is very different than the pathway that we were interested in. So between Cantos and CIRT, one positive, one neutral, we jumped a big distance down the road to understand that maybe we have to target that central IL-1 to IL-6 pathway. And if we don't target it, other effective drugs may or may not be beneficial, but at least that one pathway did work. So actually a very useful neutral trial from the perspective of scientific discovery. So much of the rest of today is going to be talking about other ways of getting there. This is a roadmap that we actually put out for our pharmaceutical colleagues, because between the NLRP3, IL-18, IL-1, and IL-6, and ultimately the liver, are a host of available drugs. I've talked about IL-1 inhibitors. I'm not going to cover IL-18 inhibitors or direct oral NLRP3 inhibitors, but this is the future of the field. I do want to talk briefly about colchicine and briefly about interleukin 6 inhibitors. So the colchicine story is quite interesting and complicated because of the potential for a drug that inhibits polymerization of microtubules to indirectly alter inflammasome function. And as you're well aware, two very important, very exciting clinical trials, each about 5,000 patients, Colcott, patients who had a recent myocardial infarction, and Ledoco-2, patients with stable coronary disease, clear evidence that this approach, inexpensive, generic colchicine, that I as a cardiologist had previously only used to treat pericarditis occasionally, could replicate the data from Cantos. So we have two things here. We have an external replication that's very important, and we have an inexpensive generic drug that can be used for quite a few patients. And I'm encouraging my colleagues to think about this when they have patients with residual inflammatory risk, with one important exception, is that patients with renal disease, I think you have to be quite cautious, and I'll come back to why in a few minutes. But very important data for the future of this field. Now, I want to talk a little about interleukin 6 for a variety of reasons. I'll ask you to focus on the right-hand side of this slide. We showed in Cantos that all the baseline characteristics didn't really matter. Everybody who had residual inflammatory risk just benefited. But what you see on the right-hand side of this slide is that those who had an on-treatment reduction of IL-6 greater than the median had a very large benefit, a 36% reduction in risk, whereas those who received the drug but only got a modest reduction in IL-6 didn't look that much different than placebo. So why so much interest then in IL-6? Well, we had shown back in 1999 that IL-6 levels were, if anything, a more powerful predictor of future vascular risk than were CRP levels, but you can't measure IL-6 in a clinical setting, so we didn't emphasize that data very much. But what you see here is a lovely meta-analysis done from our colleagues in Cambridge showing many, many studies over the years, consistent data that IL-6 levels predict CHD and all-cause vascular events. There are FEWAS data, GWAS data, Mendelian randomization data, all supporting the likelihood of a genetic component here that's quite important for the IL-6 regulatory receptor and signaling pathways. And I won't go through the details of this, but they all, again, provide likelihood of causal intervention. There are murine models that are being developed right now to look at IL-6 classic and trans signaling drugs. And I just want you to focus briefly on the right-hand side. These are very interesting data using LDL knockout mice, where they've now been treated with a drug called MR16-1, which is a murine anti-IL-6 receptor antibody. And I think you can see even across the room that there's just less atherosclerosis on the two right-hand slides, photo micrographs, as compared to the two on the left. And again, I think we recognize that mouse models for atherosclerosis have been complicated over the years, but this is certainly encouraging in terms of drug development. I will be presenting data at the American College of Cardiology in a week or two. Originally, I thought I could present at this meeting until the meeting got delayed, so I apologize for having to pull the actual data out. We're going to present data from a phase 2 study that'll come out in the Lancet. The study is called Rescue. It's about 260 odd patients looking at a novel IL-6 ligand inhibitor called ziltivekimab that's specifically being developed for atherosclerosis. It's not a drug being developed for RA or Crohn's or IBD. It's strictly being developed for atherosclerosis. And at the ACC, I'll describe the outcome of this phase 2 trial, where we looked at the primary endpoint. These are atherosclerosis patients with chronic kidney disease and an elevated CRP being given an IL-6 inhibitor, and we measured a variety of biomarkers. The reason we are doing that, and what I will announce today, because I checked with the sponsor, I can do this, the data that we will show there is the fundamental reason for launching this very new large-scale cardiovascular outcomes trial, something that's called Zeus, the ziltivekimab cardiovascular outcome study that I will chair. It'll be roughly 6,000 patients worldwide with atherosclerotic cardiovascular disease, CKD stages 3 to 4, and an elevated CRP. That's a population you don't want to give colchicine to because of their kidney disease, and it's a population at extremely high unmet need. And many of you are aware that in the setting of CKD, the inflammatory response is much more prominent than the hyperlipidemic response. In fact, that's one of the very few places where we still give statins, but in severe CKD, statins have actually been relatively ineffective. So it's a very high risk, and that trial will begin sometime later this summer, which will be very exciting to sort of take this to another step down that CRP, IL-6, IL-1 pathway. Now, a couple of quick things clinically. If we gave everybody a PCSK9 inhibitor, if we could get past the cost issues, I don't think we would have solved the puzzle, because these are data from Fourier on the left, from our SPIRE-1 and SPIRE-2 trials on the right, showing that even if you took the LDL on a high-dose statin and a PCSK9 inhibitor down, the relationships for CRP and subsequent risk is not changing. So there's more here than just taking LDL to 20. We're going to have to deal with the inflammatory cascade, and that's relevant for your patients who may have lupus or RA and the like. I also want to emphasize, and you're going to get an entire talk on this later, so just as a heads up, non-pharmacologic approaches really do matter here, and I'm excited to hear that 1:30 talk today. This is just one of many, many papers telling us that dietary effects matter, that intake of red meat and processed meats are driving increased levels of IL-6, ICAM, TNF, TNF2, CRP, and leptin, and that increased intake of green leafy vegetables and healthy fruits and diets do the opposite, and that this all tracks with risk. So good news for the prevention community. And as you're well aware, Predimed told us several years ago that a diet on top of a Mediterranean diet augmented with extra virgin olive oil or nuts clearly reduced event rates. Annette, Chris, and Ike Lotz, who are basic scientists, I just like their quote for this trial. The Western diet appears to be mistakenly recognized by the immune system as a threat to the organism. And I think it's a very nice summary of that entire literature. I want to point out, however, and this is sort of where my optimism hits a little bit of a concern. We started talking about this 30 years ago. These data are concurrent data from the CERT trial, the methotrexate trial. LDL levels plotted against IL-6 on the left, LDL plotted against CRP on the right. There's been no shift in these relationships at all in these 30 years. Despite everything that we're doing and all the work that's been done, the clinical community's response has been slow. And so I'm excited by today's discussions because we have to make some progress here. Some new data that Nehal is aware of because he's a co-author on this. One of our Brigham residents, Nico Adamstein, was interested in whether we could find an easier marker than IL-6 or CRP. This is simply the neutrophil to lymphocyte ratio that Nico could calculate. Very strong predictor of MACE, MACE plus, cardiovascular events, all-cause mortality. Nico was able to look at this in 5 of our big large-scale trials: Cantos, Jupiter, Spire 1, Spire 2, the PCSK9 trials, and CERT. Highly consistent data. So something that clinicians are already getting every time they get a CBC. It's just as easy to calculate as a total HDL cholesterol ratio is sitting right there. It's a very nice surrogate and a very nice tie-in to bone marrow function and all that's going on with clonal hematopoiesis simultaneously. Finally, much of this conversation later today will be about cardiometabolic issues. So I just want to remind you of these data. This is from Aruna Prada and our group going back over 20 years. CRP on the right, IL-6 on the left, powerful predictors for developing type 2 diabetes. And our data, again, over almost 20 years ago, that the whole concept of metabolic syndrome is radically altered by measuring the inflammatory component. These are patients who all have what was then the ATP3 definition of metabolic syndrome, but when we stratify by low, middle, or high CRP levels, vastly different risk. So again, as we get into later today, the cardiometabolic properties, this is just introduction to that part of that discussion. Also, diabetes, we'll hear about this later, is, from many perspectives, an inflammatory disorder responsive to the same NLRP3 inflammasome. The review on the left from Anini is very concurrent and very important. The data on the right are describing these. And Mark Denath has been one of the real leaders in this field and a colleague as we move through this in the Cantos trial. I will point out, however, that in Cantos, it was interesting. And again, Brendan Everett is the author of this paper. As you see on the left, we had similar risk reductions among those with diabetes, those with pre-diabetes, and those with normal glycemia. And the development of incident type 2 diabetes was not really altered by use of the drug. So at least in that one experimental setting, we did not see the benefit that we'd hoped for. On the other hand, the drug just worked for everybody, and that was very encouraging in terms of cardiovascular event reduction, even if we did not alter the hypoglycemic part of the story. So let me try to wrap this up. I started with the slide on the left, pointing out that there are 3 patients with residual inflammatory risk for every 1 patient with residual cholesterol risk. The data for that is in the upper right. You see these pie charts trying to make that clinical point. That's important. And it's why this symposium really exists, because these patients, I think, are not being targeted for the particular biology, and getting that message out is very important. The lower right-hand corner of this slide is one that I use in cardiology audiences all the time. We have a canonical background slide there of the percent reduction LDL cholesterol on the x-axis plotted against the relative risk reduction on the y-axis, and all the major lipid-lowering trials fall on a line that we see here. What you see on the far left, however, is with 0% reduction LDL. You see Cantos, you see Colcott, you see the Ledoco-2, major event reductions in the absence of LDL cholesterol reduction. That's not to say you don't want to lower LDL. Of course you do. But what it's saying is we have a new biology we have to consider. So let me conclude just by going through this quickly for you. In 2021, I think we know the following 7 things. Atherosclerosis is a disorder driven by lipid accumulation and by inflammation, and the CRP itself is a stronger risk marker for heart disease, as is LDL and blood pressure, similar variability over time, and as you'll hear later, diet, exercise, and smoking cessation all lower CRP and obviously all lower cardiovascular risk. Number 2, in primary prevention, Jupiter, published 12 years ago, proved that patients with an elevated CRP greatly benefit from statin therapy, even if lipid levels are low. We're going to hear from many of you later. I've been telling my rheumatology colleagues for a decade, just give your patients a statin. They all would have qualified for Jupiter because they all would have had an elevated CRP. In secondary prevention, Cantos was proof of principle that inflammation inhibition in the absence of lipid lowering improves atherosclerotic outcomes. This is the first hard evidence in 40 years of an effective therapy for atherosclerosis that's not directly related to cholesterol reduction, blood pressure, or coagulation. And as I pointed out, the positive Cantos data in the setting of the neutral CERT data from methotrexate really advanced the field by defining at least this one central IL-1 to IL-6 pathway as crucial. Number 4, Colcott and Ledoco-2 not only provide independent confirmation of this, because these drugs do have some impact on that pathway, but it's an inexpensive drug. Unlike a monoclonal antibody, this is something you could give now. And I am encouraging my cardiology colleagues to use colchicine in the people I think have residual inflammatory risk, what I call our frequent flyers, the patients who just keep coming back. Despite aggressive lipid lowering, who are having more angioplasties, more events, they're now getting colchicine. Number 5 is probably the intellectual issue. Quality cardiovascular care, I think, requires us to recognize a distinction between residual cholesterol risk and residual inflammatory risk. It's what our oncology colleagues have so long done. I have to know what the underlying biologic defect in my patient is to treat them properly, rather than just treating everybody with everything. Number 6, the pharmaceutical component. There's multiple promising anti-inflammatory agents out there. Many of the speakers on today's panel are far better versed than I am about these drugs, but they range from oral NLRP3 inhibitors to downstream targeting of IL-6. And again, in 2 weeks at the ACC, you'll see data about this IL-6 inhibitor, ziltivekimab. And number 7, what I really believe, I think in the future, we're going to be treating all atherosclerosis patients with very aggressive lipid lowering and very aggressive anti-inflammatory therapies. And I think that's what the future is going to be. And a combination of those two approaches will be given to all of our patients. So I want to end exactly where I started. This meeting is exciting to me. It's about cardiorheumatology. I've spoken briefly about cardiovascular disease, about a little bit about lung cancer, a trivial amount about anemia, gout, and OA. But you're now going to hear from a whole host of experts about models of psoriasis, models of RA, lupus, HIV. I'm looking forward to hearing Jeff talk about platelet function. Looking forward to talk to microbiome and risk stratification. And I just want to thank the sponsors, the NIH, NYU. This is a terrific meeting, and I really look forward to the rest of today's talks. So thank you. I'm very honored to have this opening, and look forward to the day.
Thank you so much, Paul. That was outstanding. It was really, really impressive to see all of the work you have done in this area and just how far the field has come. And this was a perfect way to start our day. I'm just going to remind everyone to put your questions with the chat box. We are going to have a question and answer session at the end of the session at approximately 9:40. So please continue to keep them coming. I am collating them. We are going to move on to our second speaker now, which is Dr. Garshick. Let me start by saying that in one of my roles, I direct the Center for the Prevention of Cardiovascular Disease at NYU. And Michael is an exceptional scientist, physician, who really has just moved this field at our institution in an incredible way. It's really exciting for me to be able to introduce him. Michael is currently an assistant professor of medicine at NYU Langone Health. He not only does he run, he actually created the cardiorheumatology program at our center in our cardiology division. He is really excited about this idea and about this program. He has been working alongside Dr. Nehal Mehta at the NIH, who is actually a very good friend of mine, who I will talk about after Michael's talk. But it's really exciting to see what he has done to date. And Michael will be talking now about vascular endothelial disturbances in pro-inflammatory conditions. And Michael, I think we are all excited to hear your talk.
Thank you, Jeff, for that really kind and wonderful introduction. And thank you all again for attending this course today. It's really a pleasure to have you all here, hopefully next year in person. But I'll be discussing vascular endothelial disturbances in pro-inflammatory conditions and actually trying to bridge a connection between Dr. Ricker's talk, which was fantastic, inflammatory diseases, and atherosclerosis. I have no disclosures. So again, a brief outline. We'll discuss the endothelium and health and disease and why it's so important, why I care about it, and why you should care about it. I'll talk about vascular endothelial inflammation and autoimmunity, predominantly using psoriasis as a model to study endothelial inflammation and autoimmunity. And then you just heard about how anti-inflammatory therapies are beneficial in cardiovascular disease prevention. So I wanted to discuss new insights into how aspirins and statins could be beneficial to reduce vascular endothelial inflammation, and also briefly talk about biologics in this arena as well. So a brief reminder of how atherosclerosis starts, and a theme that we'll be discussing for most of the day. So you need lipids translocating through a damaged endothelium. And there's a strong contribution of the immune system with T cell activation, macrophages, modified lipid uptake by macrophages into the intimal space. And this really encompasses the first stages of atherosclerosis damage, of which development, of which endothelial damage is very important. And so they go to the endothelium more in depth. The endothelium plays a strong role in modulating a variety of processes. So a healthy endothelium inhibits platelets, allows for venous relaxation, inhibits immune system activation, prevents lipids from translocating through. And so the flip side of this, when the endothelium becomes damaged, it becomes implicated in atherosclerosis, atherothrombosis, and arterial sclerosis. And in general, I think the cardiology community has really caught on that there's a strong contribution and a balance between chronic inflammation, inflammation resolution, and atherosclerosis. So if you tip towards pro-inflammatory mediators, and I point out a few of these that are going to come up over and over again, some of which I already have, like IL-1 beta, IL-6, and you tip this balance towards a chronic inflammatory disease state, you damage the endothelium, and you also develop clinical cardiovascular disease. And what you'll notice across much of this discussion today, again, is that these underlying inflammatory disease processes that produce these cytokines are associated or correlated with vascular arterial inflammation as assessed by FDG PET. This has been shown in psoriasis that Dr. Mehta will talk about more in depth, where you have FDG PET uptake of the vasculature, the liver, the skin, and the joints, and rheumatoid arthritis, where we can see the entire arterial tree lighting up on PET imaging, and in systemic lupus erythematosus. In addition to these FDG PET studies and evaluation of vascular arterial inflammation, imaging studies have also started to identify that it's not just macrovascular disease, but it's also microvascular dysfunction, which is present in these autoimmune conditions. So for example, studies have used PET stress imaging, which, as a little reminder, measures the flow through the myocardium at rest, and then after the vasodilator infusion at stress. The difference between these two is a coronary flow reserve. And if you have a reduced coronary flow reserve, and then if you rule out epicardial or obstructive atherosclerotic disease, that indicates microvascular dysfunction. So what have these studies shown? This is these newer metrics of cardiovascular risk can be useful in the autoimmune and autoinflammatory population. So this is work by Catley Operating Women's Hospital. It included 73 patients with rheumatoid arthritis and 440 patients with diabetes. So first of all, you'll note that the rheumatoid arthritis patients had the same prevalence of microvascular disease as those with diabetes. And as we would expect, but really important to show, is that a reduced coronary flow reserve, so a biomarker, an indicator of microvascular dysfunction, had the same prognostic implications as those with diabetes, with decreased survival if you followed them out to a total of 10 years. And this finding is not limited to just those with rheumatoid arthritis. This is really exciting work done by Brittany Weber and her colleagues. And while retrospective, they also looked at autoimmune autoinflammatory diagnoses in those who had undergone PET stress imaging for chest pain syndrome and had no imaging evidence of obstructive coronary artery disease. And it was somewhat evenly split between SLE, RA, and psoriasis. They noted that those with reduced myocardial or coronary flow reserve had the lowest rates of survival over a total follow-up of 10 years, confirming that microvascular, in addition to macrovascular or epicardial atherosclerosis within these autoimmune conditions, is serious and confers significant mortality and is potentially a good biomarker of cardiovascular risk. So these studies on micro and vascular damage and autoimmunity are really exciting, but they don't necessarily get at in-depth mechanisms of endothelial damage, which could be contributing to cardiovascular disease. So at NYU, what we've done is use a variety of techniques to look at these mechanisms of vascular endothelial inflammation, which again is a key step in atherosclerosis. And we've done this in the purpose of understanding an autoimmunity of discovering not just additional biomarkers of cardiovascular risk, but also discover and evaluate potential therapeutic targets. So I wanted to focus today on the impact of inflammation in cardiovascular disease through a discussion on psoriasis. You'll hear much more on this topic throughout the day, but as a brief reminder, psoriasis is associated with a 50% increased risk in cardiovascular disease, and we're not quite sure why. And of course, the question is, could the endothelium be involved as a first step towards atherosclerotic development? Of course, actually, interestingly, early pathologists wondered the same thing, if the endothelium was involved in psoriasis. And in the 1960s into the early 70s, there were case series exploring the relationship. This is one such study where on electron microscopy, the pathologist noted the damaged and flattened endothelium. You had gaps in these endothelium, and you actually had neutrophils translocating through the endothelium as well. So what's old is actually new again. We also wanted to explore the endothelium in psoriasis and the connection with cardiovascular disease. And so we, similar to these pathologists, started at the site of the injury, which was the skin. So on the left, this is a healthy control individual. The green indicates a blood value. This is just subcutaneous. This is just immunofluorescent staining of the subcutaneous layer. The red is inflammation. And we see very little inflammation present in the control individual. So this is a psoriasis patient, but this is a biopsy of the skin, but not at the site of the lesion. This is distal to a lesion. The blood vessel is bigger in this case. That's indicated in the green. There's much more red surrounding the green, and now we see yellow or colocalization, indicating vascular inflammation in the subcutaneous skin. And just for comparison, this is lesional psoriatic skin biopsy. We see dense inflammatory infiltrates, a dilated and plump blood vessel, which is one of the pathognomonic features of a psoriatic lesion, and again, a lot of yellow. And this really provided evidence to us that there's inflammation not just at the sites of the psoriatic lesion, but in the non-lesional areas as well. So we wanted to translate these findings into the systemic vasculature. Are what we're seeing in the skin also happening in the large blood vessels as well? To do this, we performed a technique called direct endothelial cell analysis, where we actually biopsy part of the brachial vein to obtain endothelial cells. It's fairly straightforward. We place a sterile angiocatheter into the brachial vein, guide wires insert through the vein. We then take the wire, scrape out the endothelial cells, wash it in a buffer, and isolate and analyze the endothelial cells using different techniques. So with these endothelial cells, we first wanted to validate our subcutaneous staining data. And for example, here we have a control subject in the top. The bottom is a psoriasis patient. The green indicates that it's an endothelial cell. The red is the inflammation. The blue is the nucleus. You can see much more red going into the blue, much more nuclear translocation of this inflammatory marker, NF-kappa beta, indicating that there's vascular inflammation in the large blood endothelial inflammation in the large blood vessels of the psoriasis patient. So, but moving beyond this non-specific inflammation, we wanted to directly assess mechanisms responsible for accelerated rates of atherosclerosis. So we evaluated a variety of transcripts that are involved in vascular adhesion, chemotaxis. On the left are control subjects, middle, mild to moderate psoriasis. On the right are those with severe psoriasis. What we saw was that a variety of the transcripts were significantly upregulated in the psoriatic individuals compared to controls. And taken another way and expand even further, we saw a strong linear relationship between many of these transcripts. And this is just one example here on the relationship between psoriasis skin activity, as noted by this PASI score, goes from 0 all the way up to 80 to 100. And the higher numbers indicate more psoriatic involvement and vascular endothelial inflammation of a variety of transcripts, such as VCAM1 and CXCL10, indicating that the skin could potentially be a biomarker for endothelial inflammation. So now that we've identified that vascular endothelial inflammation is present in psoriasis, the next question is how. And to do this, there's one way to look at it. We looked at platelets, which are felt to be causal in atherosclerosis. So Dr. Berger is going to go much more in depth in platelets across a variety of autoimmunity. But as a first pass, I just want to give you a brief understanding of what we've done here, specifically in psoriasis, and how that may impact the endothelium. What we noted was that we took platelets from psoriasis patients and we looked at them both that are resting and an activated state, so we gave them thrombin. We noted that platelets were more activated in psoriasis. These platelets also had the psoriasis platelets had greater numbers of neutrophil platelet aggregates, lymphocyte platelet aggregates. And then we looked at the connection between platelet activity and different biomarkers of inflammation in these psoriasis patients, such as IL-17A. We saw a strong linear relationship between IL-17A and platelet activation. So we've shown that platelets are activated, but we don't really show what that means. So to do that, we've noted that in other diseases, when you take platelets and put them on cultured endothelial cells, the endothelium becomes very angry, very activated, very damaged. The question is, does that happen in psoriasis? So when we took these platelets from controls and from psoriasis, put them on cultured endothelial cells, both in resting and thrombin simulated forms, we saw that it really angered the endothelial cells with production of different inflammatory cytokines, IL-8, IL-1 beta, which we'll hear about over and over again today, and such transcripts as COX-2. So in summary, thus far, we've shown that endothelial damage is present in psoriasis. Platelets may be playing a role to damage the endothelium. And of course, the question is why? So we performed RNA sequencing on these platelets. So platelets have RNA. They do not have a nucleus, but they have RNA and they have organelles to produce proteins. So we did platelet RNA sequencing, unbiased, in 6 psoriasis patients and 6 controls. And we found something very interesting as a potential mechanism of platelet activation. COX-1, which again, as we think of as traditionally inhibited by aspirin, was significantly elevated in the patients with moderate to severe psoriasis over the controls. And shown another way, when we look at, again, psoriasis activity, whether through the skin severity or different circulating biomarkers such as IL-17A, we saw a strong linear relationship between the skin and IL-17A and COX-1 expression. So far what we've shown is that platelet activation can drive endothelial damage, and that COX-1 expression is elevated in the psoriasis platelets. And that, of course, begs a very logical question. Can we improve endothelial vascular inflammation by giving a common platelet inhibitor of COX-1, such as aspirin? So we conducted a randomized clinical trial. We took 30 psoriasis patients. They were overall relatively young, low cardiovascular risk, overweight to obese, with at least mild to moderate psoriasis severity. We did endothelial vein harvesting. We did platelet measures, and then we randomized to aspirin or no treatment for 2 weeks, and then we repeated these measures. And we looked at endothelial vascular inflammation after 2 weeks. So what we saw, very interestingly, was that the composite vascular endothelial transcriptome, all these transcripts that we showed were activated in psoriasis, was significantly reduced after giving aspirin as a platelet inhibitor. And showed another way, we measured thromboxane B2. Now, thromboxane B2 is a downstream inactive metabolite of thromboxane A2. And the less thromboxane B2 you have, the more platelet inhibition you have. So what we show is that there was a relationship between degree of thromboxane B2 reduction and reduction in vascular endothelial inflammation, again suggesting to us that platelet inhibition with aspirin may be beneficial in the psoriatic individual. But of course, platelets are not the only cells implicated in atherosclerosis. Immune system activation is present as well. So we also did some other investigations. We did a deep sequencing omics approach to evaluate the blood transcriptome, the proteome signature in psoriasis versus controls, again, to help understand these inflammatory conditions. What is potentially driving endothelial damage, and can that be reversed? So whole blood RNA sequencing in psoriasis showed that inflammasome signaling, that same pathway that Dr. Ricker spent so much time talking about that was inhibited by canakinumab, was the #1 differentially expressed pathway in psoriasis with upregulation of IL-1 beta, TNF, another molecule, Cas5, which is an inflammasome-mediated molecule. And then we did targeted proteomics. We looked at 288 proteins. IL-6 was the second highest differentially expressed pathway. And again, we should be very familiar with this IL-1 beta to IL-6 to endothelial damage atherosclerosis within inflamed populations, within psoriasis, and potentially other autoimmune populations as well. So furthermore, it's not just immune system overactivation in psoriasis as a potential mechanism of cardiovascular risk, but it's also dyslipidemia. So this is analysis in comparing psoriasis to healthy controls. This is by Dr. Mehta's group by Alexander Sorkin. And what they saw in healthy controls, which is on the right, psoriasis, which is on the left, sorry, it's not labeled. There's a higher level of lipoprotein A, ApoB, a trend towards higher oxidized LDL, and a relationship between oxidized LDL and non-calcified coronary plaque. So far in psoriasis, using it as a model of vascular endothelial damage and trying to figure out why, we first had to show and did that endothelial damage is present. In this case, we're showing that inflammasome signaling is highly upregulated. And this is pretty well known and shown by many other groups that dyslipidemia is highly prevalent in the psoriatic individual. And now, similar to our aspirin question, this begs the question, could we give another medication, such as atorvastatin, that's been shown to reduce cholesterol and also potentially be anti-inflammatory? So we conducted a clinical trial. We took psoriasis patients. We took a total of 30 of them, 20 on atorvastatin, 10 on no treatment. These were low cardiovascular risk, really just mild to moderate psoriasis severity, mildly inflamed, and overall overweight to obese, similar to the other population. And we randomized them to 2 weeks of 40 milligrams of atorvastatin or no treatment. Then we looked at how the brachial vein endothelial transcriptome changed after 2 weeks of therapy. So first off, even 2 weeks of atorvastatin worked. You got almost a 40% reduction in LDL. You got a 35 to 40% reduction in non-HDL. And after 2 weeks, we got very little change in high sensitivity CRP, really no significant difference between the two groups, although maybe a slight difference. With this, we again saw significant downregulation or reduction in vascular endothelial inflammation, the composite, again, all these transcripts that were upregulated in the psoriatic individuals after 2 weeks of Lipitor therapy. So similar to our platelet studies, we want to understand the association between the connection between what atorvastatin was doing in the vascular transcriptome. So this regression plot on the left is a change in LDL. The y-axis is the reduction or the change in vascular inflammation. And what you can see here is that the lower your LDL, the greater the negative change in LDL, the greater the reduction in vascular endothelial inflammation. And then we also looked at CRP, and there didn't really seem to be a relationship between changes in CRP and changes in vascular endothelial inflammation. And shown one more way, we wanted to look at the degree of reduction. We're all trying to figure out what's the optimal lipid lowering therapy, or what's the optimal LDL goal potentially for these autoimmune, autoinflammatory populations. And in our population, in the statin-treated individuals, those who obtained an LDL less than 70 seem to be driving the majority of reduction in vascular endothelial inflammation. But it's not just aspirins and statins, which may modulate or impact the endothelium. It's also anti-inflammatories. So this is a clinical trial done in psoriasis that came out about 2 years ago, Karima. It was a randomized placebo-controlled trial of an IL-17 inhibitor, secukinumab, in patients with moderate to severe psoriasis. The main outcome was actually change over only 12 weeks. And they looked at brachial artery flow-mediated dilatation, so how well that brachial artery dilated after occlusion at baseline and then after 12 weeks of a biologic, 2 doses of a biologic, or a placebo. Then after that, they had an active crossover from week 12 to week 52. So week 12, this is in this graph, this is the red all the way to the left and the purple just on the left side of the middle. There's really no statistically significant improvement in brachial artery reactivity after 12 weeks of an IL-17 inhibitor. However, if you follow these groups out to the 1-year point, endothelial dysfunction did improve, suggesting that perhaps improvement in endothelial dysfunction in psoriasis lags behind changes to the endothelium in these pro-inflammatory conditions, and also suggesting just because you have durable skin disease control does not necessarily mean you have reduced metrics of cardiovascular risk, and really begs the question I always ask is what's the residual risk even after you clear psoriasis or other autoimmune conditions for that matter. So in summary, based off this clinical translational work, endothelial damage is present in psoriasis. The inflammasome pathway is highly upregulated. Platelets may be playing a role. And I just want to say a lot of people played a very, very strong part in this process. So I just hear all the collaborators and people that we've worked with over the past 3 years. And thank you.
Thank you, Michael. That was great. It was really nice to see what you have done over the last few years. And I'm excited to see what you will do over the next many years. Okay, just to remind everyone, we are getting in a lot of comments and questions. Please to continue to upload any questions you have into the chat box. And at the end of the third speaker, Dr. Mehta's talk, we will have a Q&A session with all three speakers. So for our next talk, it is actually my privilege to introduce Dr. Nehal N. So many people may not know this, but I was introduced to Dr. Mehta, and I met him before he became very famous in this area. We were actually fellows together at the University of Pennsylvania. And more importantly, we became very good friends and collaborators. And it has really been a privilege to watch him grow and develop into, in my opinion, really a superstar in the field. Dr. Mehta was the inaugural scholar in the Lasker Clinical Research Scholar Program in 2012 at the NIH. And currently he serves as the senior investigator in the section of inflammation and cardiometabolic disease. His research focuses on a lot of different areas, including innate immunity and inflammation and the development of cardiovascular and metabolic diseases. He's really been a pioneer in understanding the role of inflammation and how it affects inflammatory diseases. In fact, he is directing the largest ongoing cohort study to date in psoriasis, which you will hear about soon. And I think Dr. Mehta should be noted that he was the first to describe a link to neutrophils and atherosclerosis in psoriasis, and that psoriasis accelerates lipid-rich plaque in vivo. Most importantly, I think that he has served as a mentor for many people, including Dr. Garshick, who we both co-mentored together. And I'm excited to hear his talk today on human inflammation clinical trials using psoriasis as a model. Nehal, please take over.
Jeffrey, thank you so much. I'm so excited to be presenting this data here today. So first thing, it always pleases me when we have such a great group. It reminds me of the days we used to be together in one room. And so over the next 30 minutes or so, I'm going to try to make this interactive and try to remind people that we're all still watching the same talks. So I will interject some commentary based on Paul's and Michael's contributions up till now. I was asked to speak about trials in human inflammation using psoriasis as a model, and you'll see I've grayed out to study cardiometabolic risk, and I'll talk to you about why. The first thing that I'd like to point out is cardiometabolic disease as a title is disease of subclinical athero, insulin resistance, obesity, and high cholesterol. I urge you to consider this to be different from metabolic syndrome, which is a cluster of 3 or of 5 of these. I'm not going to have time to talk about our recent work demonstrating metabolic syndrome marking high-risk patients, but the dyslipidemia piece we will talk about. I still run with Joel Gelfand and Alexis Ogdi, the first cardio room clinic that we created about 12 years ago at Penn. And it's an inflammatory risk program. And this is a patient who I saw 3 years ago and still remains one of our biggest fans and supporters for understanding why this is important to ask. So she's 44, tobacco user, family history of CAD. She has high blood pressure and she is obese. And I'm going to go through a little bit of her past medical history, pointing out what we see in psoriasis. First, she has borderline hypertension. These patients don't seem to make the actual diagnosis because of a lot of sheepishness. Number 2, the mother has diabetes, very common in our patient population. Father has an MI, very common in the patient population. Social history, half pack per day of use of tobacco use, very common in this population. Diastolic hypertension of 89, body mass index of 32, high risk waist to hip ratio. Apple, not a pear, holding that central obesity. We'll talk about that later. Plaque psoriasis, 9% of her body surface area is covered. These are her labs she brings to me. On the European colleagues, we have on the right in millimoles, and on the left, we have it in milligrams per deciliter. You'll see that her LDL is 159. And you'll see that her triglycerides are 200 with an HDL of 40. Very metabolic syndrome E if you consider suppressed HDL with this high triglyceride. Her fasting sugar was 116. So again, I started with her case summary to remind you, untreated mild psoriasis, 44, tobacco user, family history of CAD. Except for Reynolds risk score, no one's really going to even capture that family history of CAD. High blood pressure, diabetes, risk with prediabetes at a glucose of 116, and she's obese. I remind you, her Framingham risk 10-year score would be 9%. She wouldn't even be marked as a high-risk patient. So heart attack still remains the leading cause of death. Atherosclerosis is the leading cause of this heart attack, and is accelerated by inflammation. And my lab has been spending the considerable last 10 years understanding these inflammatory cells. And I'm going to talk about trials and methods by which we have understood which cells to be important. I'm not going to spend much time on this. We had our excellent talk by Paul this morning, reminding us inflammation is critical to atherosclerosis and atherogenesis. And really thinking about what is it about inflammation that goes from the left, which you have this nascent blood vessel, all the way out to plaque rupture. So ideally, the broad goal would have been to study a human model to understand the mechanisms of these associations, with the approach being the best way to understand would be a model where a non-inflamed state can be modulated to an inflamed state. And in this inflamed state, we understand all of the modifications and modulations. So the first models I'm going to talk about just briefly brings me back to my days when Jeffrey and I would sit in the fellows room and think about all our big future plans and research. My first project was funded by the ACC in 2006, and it was called lipopolysaccharide, human endotoxemia, and the metabolic syndrome. So I used endotoxin, injected 1 nanogram to 3 nanograms per LPS into humans, and using adipocytes and monocytes to understand downstream how inflammation is perturbing these very important cell types. Remind you that endotoxemia looks like cardiometabolic disease, little low-grade elevation of TNF, IL-1, IL-6. The inflammatory component, lipoprotein component, and glucose component are exactly what we just saw in our patient with psoriasis, high triglycerides, low HDL. You'll see a hyperinsulinemic state as well. This is the study protocol. I'm not going to go through it in detail. It's just to make me smile a little bit, to remind myself from where I came from. This was 20 healthy college students brought in. I was on call for the study. I was in at 6 a.m. injecting LPS. I was doing biopsies at 10, 2, and 6, and then coming back in for a 24-hour screening, a follow-up visit. But the beauty of this is that we would exclude obesity in screening. We would see a baseline. We would get fat measures. We would admit to a clinical center, let them acclimate. We'd give them the saline. So the first day was a placebo sort of control day. They would then get the LPS, and we would compare the 24-hour to the 0 as our comparison. And young group, nice cholesterol, nice body mass indices. We all wish we had these labs ourselves. And what we saw after giving LPS was a spike in leukocyte mRNA of IL-6 and TNF-alpha. Plasma proteins of those went up. And what was incredibly of interest was that there was this increase in what we called adipose inflammation. And this will come back towards the end of the talk with the lipid-rich necrotic core. So what else did we learn from this LPS model besides adipose inflammation? So here is reverse cholesterol transport. I fundamentally believe that psoriasis is a defect in cholesterol handling. And one of the primary ways to test this hypothesis is to understand reverse cholesterol transport. So shown on the right is a macrophage loaded up with cholesterol. A nascent HDL using the ABCA1 transporter can pull out that cholesterol, esterify it with LCAT, push it out to the liver, poop it out in the bile. Reverse cholesterol transport. This was first shown to be retarded in inflammation. So our healthy subjects reduced their efflux by approximately 20% every incremental time, and it returned to normal by the next day, suggesting that there's inflammatory modulation of HDL function. What else did we learn? Now, it's a little early in the morning. You may have had a cup of coffee. If you're on the West Coast, you may not have had that cup yet. So I'm not going to put you to sleep with insulin receptor signaling. But what I will remind you of is that inflammation is tied to insulin resistance in three cardinal ways. Number one, if you are inflamed, you are not able to bring the insulin receptor substrate because of the serine phosphorylation. Number two, if you're inflamed, you have this suppressor of cytokine signaling that blocks the insulin receptor substrate from allowing GLUT4 to translocate to the cell membrane. Number three, endotoxemia directly via the TLR4 transcribes NF-kappa B and IKK beta from the transcriptome, which then further enhances TNF and IL-1 beta. What did we find? In these healthy humans, in these college students, a single dose of LPS made them insulin resistant. So again, one would love to say that this is due to the inflammation. And we looked in the adipose, and in fact, the adipose signaling pathways for insulin handling glucose were completely affected to a point where we saw insulin receptor AKT2, IRS1, and SOX3 mRNA all elevate in concert with a return to normal by 24 hours. So you may say, hey, stop what you're doing. This is all the information you need. Not true. Grant after grant, paper after paper, and it gets tough. You better have thick skin to be in academia, because it was ridiculous over the next 3 years that all the data supported the hypotheses. It resembled the milieu, but I was constantly told it's a challenging model and it doesn't represent true human in vivo inflammation. I was going to the CCU in 2007 and a half, and I bumped into smiley Joel Gelfand on the elevator. Joel and I hit it off. We talked about what psoriasis was, and he said, I've just published a paper where psoriasis patients are having increased heart attacks. You're a cardiologist interested in inflammation biology. Let's have a discussion. And so that born what we're going to now talk about over the next 10 years of why psoriasis serves as this model. It's a common chronic inflammatory skin disease. About 2 to 3% of the population have it. A lot of undiagnosed cases. And what you'll see in the upper right is a thick, scaly patch of severe psoriasis on the trunk, representing a severe psoriatic flare. In that patient, there are over 1 billion immune cells activated, allowing us to understand this relationship. My first charge, if you will, was to say, do we really believe this is there? So working closely with Joel Gelfand, this is the work of over 10 years of epidemiological experiments spearheaded by his lab. He shows three things. Number one, there's 50% increased risk of mortality in psoriasis, the curve on the right in red compared to the curve on left in blue. This shift of 5 years due to three things: cardiovascular disease by far and away, infection, and cancer. Number two, the paper by Dr. Gelfand's group showed that there was an age interaction, that somebody with severe psoriasis between the age of 40 and 50 has a twofold elevation. And you'll see my cohort is specifically defined between the ages, specifically targeting between the ages of 35 and 55 for this reason. Number three, on the bottom left, these are hazard ratios from fully adjusted models from this papers listed on the bottom right, showing that anywhere between 40 and 60% of an increase in risk of first heart attack, stroke, or dying from your first heart attack and having major adverse cardiovascular event. So usually it's by this time I remind you that we're utilizing psoriasis as a human model to study inflammatory atherogenesis. If we all could do it big, we would do 10,000 person outcome studies, but that's becoming more and more difficult, especially in the midst of a global pandemic. But we utilize psoriasis, the immune activation, the systemic inflammation, and the lipoprotein dysfunction observed in it to see what of these pathways are leading to myocardial infarction. So some unpublished data. First, psoriasis is an inflammatory disease. Shown here compared to those undergoing a true acute coronary syndrome with troponin positivity and EKG changes, compared to those with non-troponin positivity, or what we would call non-acute coronary syndrome. Psoriasis has a 9-fold elevation in TNF-alpha and a 5-fold elevation in IL-1 beta. Secondly, I alluded to this earlier, that when one looks at NMR spectroscopy, there's this ApoB shift. There's more lipid-rich triglyceride and small dense LDL, owing to the fact that there's suppression of ApoA and an increase in a shunting towards ApoB. I went through this reverse cholesterol transport with you, reminding you that every time a psoriatic patient eats something, 8 to 12% of their cholesterol is retarded in their body. Shown here are data from 2 papers, one early, one middle, and now one late, showing that this is a consistent signal that there is a decrement of 8 to 12% in cholesterol efflux, HDL efflux in these patients. There are key immune factors between psoriasis that relate to atherosclerosis. So if one looks here at the initiation of psoriasis, one sees that these incredibly important cytokines in cardiology activate a myeloid dendritic cell. And I highlight the word myeloid. Dr. Ritger used myeloid in his talk as well, thinking about the NLR. That myeloid dendritic cell activates, becomes a Th117, secretes its own cytokines, goes back to the keratinocyte, where this keratinocyte becomes a hotbed, secreting all of these mediators that are in fact very important in cardiovascular disease. So usually by this point in the talk, I breathe, I stop, I remind you, we're trying to show that psoriasis provides a model to prove that inflammation in fact precedes and is associated with cardiometabolic diseases. It's a common disease, has a waxing and waning course. They have a young age for development, CVD. And this last bit is what I'm going to spend the remaining 15 minutes of the talk on, which is the immune activation that is reversible with a broad range of phenotypes. How do we do it? So at the NIH, we're lucky enough to have a 4-year ongoing cohort study. We've enrolled about 350 individuals. They get PET CT, PET MR, and coronary CTA at 0, 1, and 4 years. And I'd like to be the first to tell you and share with you that we've just now opened up a 10-year imaging time point. We're going to call it Y10. And Y10 is going to be 10 years from their first scan with the ability to adjudicate events and hopefully create a risk score specific to psoriasis. So on the left, we also do coronary CT angiography. Jeff Berger will remember our favorite consult attending would make us laugh by saying, "Why are you looking there? Be Willie Sutton and go to where the money is," right? So CCTA is where the action of MI happens. So we have vascular inflammation in the aorta. We have the functional consequence of distensibility and thickness. Distensibility is what Michael Garshick is studying in his K23. And then that ideal coronary CT angiogram is going to allow us to not only understand plaque characteristics, but also CT-FFR-based perfusion, which is yet another one of our teammates in Boston, Brittany Weber, is going to be studying as well. Before I get to some of that data, I want to remind you, psoriasis is a whole body disease associated with vascular inflammation. Shown on the left is a healthy control without psoriasis. Shown on the right is a patient with psoriasis who has vascular inflammation. You'll see along the aortic pathway as well as its branches. You'll see that there's tremendous skin uptake. There's also joint inflammation in someone without psoriatic arthritis, which we'll hear from Leahy Eater and Jose Scher, who are experts in this space later. And we also see this tremendous amount of hepatic FDG uptake, which we'll not have time to talk about, but is an important precursor of non-alcoholic steatohepatitis. I wasn't on Twitter until 2020. And I used to make this joke all the time that this picture on top was the first time that Twitter was active with psoriasis showing itself that what goes on the outside is going on the inside. So let me walk you through this. This is an FDG PET CT in the upper left, and this is a control. You see an absence of vascular uptake compared to a severe psoriatic who has a tremendous amount of target to background ratio. This is aortic uptake of a radiolabeled glucose. What one sees is as they get more severe psoriasis on that axis of X, the Y-axis increases their target to background ratio. What one sees on the outside, one gets on the inside. It was at that time that we also started enrolling fresh myocardial infarction patients from GW. I see I'm on service there 4 weeks a year on the acute MI service, and we will enroll patients from there 6 weeks later. And what was shown here very elegantly was a simple step back and take a look. Vascular inflammation in CVD post-MI resembled what we were seeing in psoriasis. So it was then that we asked this question, that if psoriasis and CVD share inflammatory pathways, might the coronary arteries be affected? So use of 2 CT angiographic machines, computed coronary CT angiogram, we are able to get these images that I've shown here on the bottom left, and then the artery itself on the upper right. And we have two machines, a Toshiba 320 and a GE Force. The usual scan is completed in under 1.5 millisieverts. And let me just walk you through this because I think this is important. As surrogate markers go, I think we have one now that provides a whole host of opportunity for us to learn from. One single coronary CT angiogram here shows a mixed coronary plaque that has some calcification. You'll see an orange border and a yellow border. That itself is this thing of coronary wall thickness called plaque volume. So we can subtract out the luminal volume from the opacification. We have the total volume. Remember, atherosclerosis is a disease of the wall, not of the lumen. Atherosclerosis is a disease of the wall. So we're capturing this plaque volume very early on. And when indexed to the length of the segment, we get something called a plaque index. In our first set of studies, we showed that psoriasis had a 20% increase in this total plaque that was predominantly non-calcified. We do not see calcification very early in this population unless they go on some other agents that may augment calcification. Furthermore, you also see that in fully adjusted models, psoriasis portends anywhere from a 15 to 18% increase in non-calcified burden. And I also remind you that non-calcified plaque is the major reason why people have myocardial infarction. So when they roll into our cath labs, we usually don't end up seeing those 70, 80, 90% chunky lesions. We end up seeing these. That made us ask the question in that paper, not all plaques are created equal. So do we see high-risk plaques in psoriasis? So these are two types of those plaques. One where atherosclerosis is a disease of the wall, not of the lumen. It pooches out. That outward pooching is positive remodeling. An index greater than 1.1 to 1.8 has been shown to increase risk for future events. The bottom one is a low attenuation plaque, and I want you to keep your mind and your eyes on that low attenuation plaque. That low attenuation plaque was recently shown to be a predictor of major adverse cardiovascular events in Scott heart. The low attenuation plaque histologically is called the lipid-rich necrotic core. So I'm going to talk about that shortly. So are high-risk plaques present in psoriasis? They are. This is an unfortunate 38-year-old male with severe psoriasis, came into our cohort in 2016. He's since had CABG because of severe vascular disease. This is a right posterolateral shaggy plaque that you'll see here has positive outward remodeling, also has a lipid-rich necrotic core. And the summary level data of that paper demonstrates that when you have psoriasis, you're younger, and you get the same amount of high-risk plaque as someone who's 60 with hyperlipidemia. This has to stop, okay? This has to stop. This is probably one of the most important slides I think that we have generated, because this was the genesis of our meeting 2 weeks ago when we gathered to say, if we actually treated with statins, could something like this not happen? These high-risk plaques go on to rupture. So it was at that time in 2017 that I got a call from the reading room saying, hey, the 30% shaggy plaque in this patient has disappeared. What have you been doing to them? And I said, I simply treat their primary skin disease. And it was then that a medical student who's now actually at Jeffrey's NYU clinical investigator program asked this specific question. Can we treat psoriasis with a biologic and understand whether or not it changes the coronaries? So a little aside here. The aside is that when one has severe psoriasis, there's a choice of not going on a biologic therapy. Whereas when you have lupus, rheumatoid arthritis, or psoriatic arthritis, those are destructive diseases that must be treated. Inflammatory bowel disease without a biologic, when it's severe, could be life-threatening. Here, I'm trying to move that severe psoriasis needs to be treated, but we still have about 20% of our patients who choose not to go on a biologic in our cohort. They serve as our referent group. So we took 90 who went on a biologic, 30 who did not, and we compared their CT scans. I really liked Paul's comment that this is the first time that we had seen in his Cantos study a non-blood pressure, glucose, and lipid effect. And look at our slide here. So Paul, thank you. The slide says there's no change in blood pressure, no change in glucose, no change in lipids, but there was a 33% reduction in CRP and on the IL-1, IL-6 pathway. You've heard me speak and say that CRP does not represent the active amount of inflammation in psoriatic diseases. But here, this 33% reduction is great proof of concept that we're still hitting a very important canonical axis in atherosclerosis. So what did we see? First thing, let me orient you. LAD, mixed plaques, this speck of calcium is seen here. In A, baseline, lipid-rich necrotic core, fibrofatty burden. In B, 1 year of treatment, lipid-rich necrotic core goes away. Calcification increases. Calcification is a great thing. This is the body telling you that we are trying to put something in there that's not going to let it rupture. So I'd love to be able to speak about this later. In statin therapy, we see calcification over time. Now with biologic therapy, we're seeing calcification over time. So what did we see in the numbers? I'm going to go through this fairly quickly. 5%, 7% reduction in those who got biologic therapy compared to a 2 to 5% increase in those who didn't, non-statistically significant. What did we see in the high-risk plaque features? 55 to 57% decrease in their fibrofatty burden and their necrotic core. This is the second time I stop and remind you, we're treating their skin disease. We're not treating any other risk factors. We're treating inflammation in their skin disease. In those who did not go on biologic therapy, we saw an increase in fibrofatty burden, which was statistically significant. I always ask this question and I point people to the supplement, but because it came up a lot on my last symposium, this is by biologic therapy. This is anti-TNF therapy, saw a reduction non-statistically significant of 5%, but in 22 individuals on IL-17 therapy, look at this. Total plaque burden down 16% with a non-calcified plaque going down 12%. You must ask, so these are non-luminal plaques. They're not there yet. What happens if you look before the plaque forms? So these are also data generated with Oxford, Caristo, showing that perivascular fat attenuation index is reduced following biologic therapy. So this is our same CT scan. And I always shamelessly plug when I get a chance, if not any interest, but to learn more, please, Coronary CT Angiography Symposium is online and MARTed from 2019 that goes over these concepts. This perivascular attenuation index, P5, demonstrates here that the red, all of this water replacement of inflammation and edema after reduction in anti-TNF, after reduction of inflammation following anti-TNF, results in a reduction in that inflammation. Shown by groups, when you didn't go on a systemic or biologic therapy, you had no reduction in your P5, whereas when you went on biologic treatment, anti-TNF, or 23 and 17 therapy, there was a reduction. Finally, our most recent efforts with elucid bioimaging, which just helped with the VASCEPA study, showing that we have reduction when we take certain kinds of fatty acid in non-calcified plaque. This is VascuCap. This is a histopathologic validated software where the initial training was done on carotid endarterectomy species, sent down to Renu Vermani's group and Alok Finn's group at CD Path, then reverse histologically proven back into the images, so a radiomic approach. And the second paper just came out, and I really congratulate the authors, Andy Buckler and others on there, Ulf Hedin, for getting the cover of ATBB. But what I show you here is I brought that into the coronary arteries. Andy said, Nehal, it's been done in the carotids, let's do it in the coronaries. So using his software, we now are able to generate these beautiful images of lipid-rich necrotic core. And I don't want to go over time, but I do want to get excited about this, that you see these areas of lipid-rich necrotic core in the plaque. So shown here in the recent publication in Circ CV Imaging, this was about in 250 individuals followed for a year. Simple treatment of their skin disease led to a reduction in this lipid-rich necrotic core. I remind you that this lipid-rich necrotic core is the equivalent of the low attenuation plaque, which I remind you was a 4-fold elevation for future heart attack risk in Scott heart. So something very important to think about. So what if you find an abnormality? So in our 4-year study, we found that 350 patients have a very high prevalence of impaired fasting glucose, high visceral adiposity, dyslipidemia, which is surprisingly modifiable with diet and exercise, suggesting a large lifestyle component. Here's our 44-year-old female. Sadly, her untreated psoriasis did lead to the serial LAD lesions. You'll see that there's a lesion of 70% followed by 30 to 49%. And I want to remind you, Paul said something that was music to my ears. Paul, you're always a visionary and a pioneer, and I love that. You said, I told my rheumatology colleagues years back to put them on statins. One of my most, I'd say, proud professional moments was December 18th of 2018, when we saw psoriasis get into the guidelines. So Paul, thank you for being that visionary on that. And psoriasis, RA, and HIV are conditions that warrant early initiation. I remind you, this cuts across to the American Academy of Derm guidelines, the National Psoriasis Foundation guidelines. And I'd like to conclude with 3 last slides. First, the conclusion slide, because I'm a purist. I believe I've shown you that human experimental models do show that inflammation precedes HDL dysfunction and insulin resistance. I've only had time to show you those 2. Psoriasis provides a model to test the effect of chronic in vivo inflammation. These people are always inflamed, okay? They're always inflamed, and we need to figure that out. This translational model has become a hotbed of exploration and discovery. I can't thank, again, Michael for dedicating his time and his work to this. Paul for saying that more of you should really think about a career in cardiorheumatology and cardioinflammation, because we're at a point at which I share this infographic, another shameless plug, that thanks to the Psoriasis Foundation, we have redefined psoriasis as a whole body disease. And if you look at this, I'm trying to teach my 6-year-old how to look at art. Step back a little bit. You'll see here, there's a little heart. You'll see here, there's some fingers. You'll see here, there's a beer belly. And you'll see here, there's a brain. The root of all of this is systemic inflammation. The skin is the driving bed, the flakiness, the hyperkeratosis, the neutrophils. This infographic has made me realize that the awesome psoriatic researchers and inflammatory researchers and the providers out there, we can move this dial forward, okay? And one of the biggest things that I think we need to remember here is with team science and approaching this, we can make the next generation appreciate the nature of this whole body disease. And so with that, I will remind you, please post your questions into the question answer. Please follow me on Twitter if you're interested. Email me for questions. And I just want to say thank you again to everybody who's here for the energy that's provided. And we're happy to open up the panel for questions whenever our moderator, Dr. Berger, permits us to do so. Thank you.
Thank you so much, Nehal. That was really, really great. It's that was a fantastic hour and a half. I think our audience loved it as well, because I have so many questions coming in. So I will get started. I have, I think, over 15, so I will just start. One of them is, Dr. Ritker, you spoke a lot about high sensitivity CRP. How do you deal with that in patients who have established inflammatory disease? Is it still worthwhile to measure? Do you track it? What are your thoughts about that?
So sure. So when we originally started this work, which was literally 30 years ago, we eliminated all the patients you all are talking about today from our studies because we were concerned that it might give us a false positive signal. Fast forward, what you've just heard is that in RA, you'll hear about lupus later, in psoriasis, I would argue in inflammatory bowel disease, a host of other things, you have the same relationships between inflammation and vascular disease. It's just augmented. So in fact, I encourage people to use CRP in their patients with inflammation, just as those without. You're going to get on average higher levels. But what's so fascinating to me, and Nehal and Michael know this, when you start to measure CRP in patients with, say, RA, many of them are higher than the usual level, but some actually aren't. And that's what's fascinating. So I think the expression of the low-grade inflammation is probably the driver of these bad outcomes. And to my pleasant surprise, the test still works, which we actually thought originally it wouldn't. But it's kind of interesting.
There was one other question about CRP, which is there are different forms of measuring them. What do you recommend? Because in traditional rheumatology, they use CRP. In cardiology, they use a lot more HSCRP? Do you see a difference in these types of patients? What would you do if you're taking care of rheum patients?
Yeah. So actually, from a clinical chemistry point of view, most major labs at this point in time are using what's called an extended range assay, so that you, the clinician, can misorder the test as often as you want, and you'll get the same thing back. Because that was done because people were so confused by this. I think you just use HSCRP all the time. But it's that comes back milligrams per liter. If you get something back from your lab that's milligrams per deciliter, by definition, they measured regular CRP. You can't quite just multiply by 10. It's not quite that simple, but most labs at this point in time have figured out how to get around that. So this was a big issue a decade ago. Not so much an issue now.
Here's a question for all three of you. A dermatologist is asking this and says, I see a lot of patients with psoriasis. Should I be prescribing aspirin and statins to all my patients? Good luck with this one.
I'll go first, then Nehal can correct me or however you want to say. So just to expand a little bit on what Dr. Richter said in CRP, there's a really interesting phenomenon in psoriasis where even sometimes when you see really inflamed psoriasis patients, the CRP is not elevated, and you'd be shocked. The skin's completely inflamed, but the CRP is 0.5 or 0.6. And, obviously a lot of it's driven by IL-6, and IL-6 is upregulated in psoriasis, but it doesn't seem to, targeting IL-6 doesn't improve psoriasis, skin severity. So there is some mismatch, which I can't quite explain. Nevertheless, in my own data and others' data, CRP is a biomarker that's readily available in the lab. It's a blood test. So I do check it, and I use it as a risk modifier, just like psoriatic activity. And that kind of leads me into the aspirin statin question. So, I think that it's always a conversation with the patient. I always tell them at the very least, things are a +1, psoriasis plus a traditional risk factor. It kind of really pushes me in that direction, plus Lp(a), plus CRP, plus imaging techniques, which we'll get into. But I'm generally a lot looser about giving these medications, with the caveat being with aspirin, if they're on a lot of NSAIDs, then we have different conversations as well.
Jeff, I'm loath to ask any questions about aspirin with you, actually, as our moderator, because you're as knowledgeable about this as anyone on this section. But it's really interesting. Michael, when you were giving your talk, I was smiling because, our original 1997 paper was done in a randomized trial of aspirin, and I just didn't show it today because I knew you'd be talking about aspirin later, and Jeff always gets me anxious because he knows more about this than I do. But the thing is that it's amazing that in that original publication, we were in an era when aspirin was an antiplatelet. That's what it was. And this notion that it might have some anti-inflammatory properties that might intermix with this was so radical an idea that we sort of just buried it. But it's rather extraordinary that the benefit of aspirin was directly related to the underlying level of inflammation. And that's kind of what you just showed. So I was really interested in your new data, Michael. So I thought that was terrific. I have to say, aspirin as a therapeutic, more complicated. You can't get out of my office without being on a statin anyway. And what your community has convinced me, and again, I tried to say as politely, is that they almost all would have qualified for Jupiter. And so I know that many societies want to see a statin trial in lupus, a statin trial in RA, a statin trial in psoriasis. Well, it's never going to happen because it's not pragmatic to do so. And I think we already have evidence that it works.
So let me, I'm going to ask one other question on this topic before we move on. So let's say you have your patient that Michael described. He has low levels of circulating inflammatory biomarkers, whichever ones you measure, whether it's HSCRP or something else. But they have severe psoriatic skin disease. Does that affect how you treat them in terms of cardiovascular prevention?
Nehal, do you want me to take this or do you want to take it?
I'm happy to. I was waiting for Paul to jump in just to see what Paul would say. Unfair question, but I think that, the first thing I would say is we're at a point where I think if you're not treating the primary source of inflammation, you're doing disservice to the patient. So I always start with our referring doctors and all of our practices by starting with primary cutaneous disease treatment, whether it includes skin, joint, or both. And in parallel, I do tend to diagnose. I don't work up, I diagnose risk factors at that same time. And in my note, I thoughtfully say, in the first 30 days, we will attempt cutaneous disease, because there's something to be said, and you can't oversell the impact of improvement in cutaneous and joint disease in these individuals. They will get out more, they will walk more, their moods will get better, they'll eat better. So primary disease treatment always starts, in my opinion, and I think Dr. Gelfand will probably be a good one to bring this up with as well, because I think the rheumatoid arthritis literature is supported. You got to treat the primary disease as well. Dr. Kaplan's approach in lupus is a parallel approach. I think what you're getting at, Jeffrey, is what we're detecting in our individuals is very difficult. And if you look in our cohort of, we've done 1,000 scans in psoriasis, we have a plaque prevalence of 35%. So 1 in 3 patients walking through my office door, I have to think has a plaque. Now, what increases the chance of them having that plaque? If they have one, usually a high CRP. If they have one, a high glyc-A through NMR spec. And the best one is if they are able to have a high NLR. The last paper we wrote with Paul actually showed that a cutoff of 2.29 with NLR with a certain amount of skin disease signifies you have a chance of having a plaque. That's where I struggle, because then the right thing to do, the cardiology hack goes on. Anybody who now has the chance of having a plaque, and we have, directors of prevention centers sitting on this moderation panel, you will be on a statin, you will be on an aspirin. But one of the things that we've just learned after our meeting on April 9th, trying to get statins prescriptions into the hands of derms and rheums, is there's a tremendous amount of underdiagnosis, let alone undertreatment. There's a tremendous amount of underdiagnosis. So I guess these discussions have to be in a vacuum a little bit, because in an ideal world, Jeffrey, I would treat the patient's cutaneous disease, start them on a statin, probably depending on, I would ask you, would you put them on an aspirin? And I probably would follow them closely, because what our data shows is after about 2 years of quiescent skin disease, by 4 years in our 1 to 4 year scans, we're seeing stabilization, if not some regression of this coronary wall thickness, suggesting that control of primary skin disease or primary disease is of utmost importance. And I would love for Paul or Michael or Jeffrey, yourself too, to comment on that last primary disease point, because I know we're going to hear from Priscilla Sue as well, who's going to talk about HIV, and then Udo Hoffman. And in the HIV world, I've also been told that statin therapy is anti-inflammatory from a lipid standpoint, but also treating the primary HIV matters.
Okay. No, I don't disagree. I think as a physician, your job is to treat the symptoms the patient comes to you with. I think we would all agree that's the first thing you do. But people on this call are different subspecialties. I think you're right. I think we need to say, okay, to the dermatologists and the rheumatologists, the same way you want me as a cardiologist to at least consider the fact they might have psoriasis when I see it across the room and say, cardiovascular risk is higher here. I think our derm and rheum colleagues also have to say, okay, I'm going to treat that, but maybe I need to think about their heart. I think that's just good medicine.
Good medicine. Thanks, Paul.
I completely agree. Let me ask, right? So we spoke about cardiovascular prevention meds that are typically used, aspirin and statins. Nehal just spoke a lot about some of the biologic therapies used by the rheumatologists and dermatologists. I guess my question is, how quickly or how soon would you start considering some of the newer anti-inflammatory drugs that you showed, Paul? For example, colchicine. When do you start to use that? When do you bring it out? Especially in a setting such as the one we're discussing today, which is a little bit different than those randomized trials that you've shown us.
Well, Jeff, let me start with those randomized trials, because at the end of the day, I really believe that trials determine care, and that we have to, and so the first thing that will enter the guidelines, I would hope, would be patients with stable chronic atherosclerosis or recent myocardial infarction, because that's Colcott and Lodoco too. I would anticipate guidelines worldwide, whether they want to or not, will be forced to acknowledge that this seems to work. Again, a few caveats. I would not give colchicine to individuals with renal failure. There's a few antibiotics you got to be a little bit careful with, but the relative risk reductions are in those two trials larger than what you get for a PCSK9 inhibitor. And outside the United States, colchicine is 25-30 cents a day. So that's A. B, the U.S. dose of 0.6 is different than the dose that used in the trial of 0.5, but we'll figure that one out. So I am encouraging cardiologists to start thinking about this in residual inflammatory risk, and to think about the fact that maybe they don't have to spend $8,000 to $10,000 a year for a PCSK9 inhibitor, and perhaps it's not even the right drug to pick for that particular patient. Outside of that setting, I get very conservative. I'm sort of, let's see what happens. In the last two discussions, we've learned that IL-6 inhibition, for whatever reason, doesn't seem to work so well for psoriasis, even though upstream inhibition looks very good. So I think we have to be a little careful about disease-specific settings, even though I think on this symposium today, we think there's enormous commonality between these diseases. There's still going to be specific differences that matter. And actually related to that, if I can ask a question of Nehal and Michael, because it's great to have them. I'm sitting here wondering, would you consider an NLRP3 inhibitor as a drug for psoriasis, as an example?
I was going to ask you that question. That's not fair. Okay. Michael, I'm going to let you start with that one, but I was going to ask that question to Paul.
I think I think that it's pretty clear in our blood RNA sequencing data that inflammasome pathways, and not just we, others have shown this too. When you look at people on, off biologics, these were all comers, about 45 psoriasis patients that we looked at. Inflammasome signaling was the highest pathway. But as I just showed with the IL-6, I think that, these pathways are very complicated. And just because you inhibit one, is the question, is it a bystander cytokine, or is it a cytokine which is implicated in either the initiation or the maintenance of the disease? I think you have to test that. And so I think I'll defer, for clearing skin severity. But I think in terms of, further immune inhibition, I think you balance that against some of the infectious risks. And what other medications can you do to reduce cardiovascular disease? So I would definitely go to an aspirin statin, at least right now, before I thought about, double, triple immune modulating therapy for these patients.
I think, Paul, that there is a definite role for NLRP3 inhibition here, because two of our recent in vitro papers, these are now published in the public domain, so I can speak of them, have demonstrated that this lipid accumulation early on has three different effects. One of them is foam cell formation, which we all are classically aware of. Another one is this myelodyspoesis. I don't know what we want to call it, but there's this production of immature cells from the bone marrow. And the third piece of that is that if there is that piece that's being activated, the NLRP3 inflammasome is leading to early changes driving the lipid-rich necrotic core because of the downstream effects. My only concern, and what my question to you was going to be, is there a point at which we've seen that IL-17 therapy in the predisposed host for psoriasis can actually bring out rheumatoid arthritis? Inflammatory bowel disease, not rheumatoid arthritis. I'm sorry. And we know that IL-17 therapy did not work very well in rheumatoid arthritis, suggesting that there's different kinds of inflammation, right? So my question to you would be, is there a worry that by inhibiting the NLRP3 inflammasome that we may change downstream effects of biologic therapy that the patients may be on?
Well, the reason I was asking the two of you because no one knows the answer to that. So I think the reason for having this part of the discussion here is for all of us to recognize that we're talking today about extraordinary commonalities in some underlying biology of innate and acquired immunity across 6, 7, 8 diseases, many of which we haven't talked about yet. You're going to hear about in the later sessions. And to be a little cautious to say it's extraordinary how similar these are, but it's also been proof to date that not all these respond the same way. So again, the beauty to me of what Cantos has done for all of us is, the OA data is really interesting. I'll let Dan Solomon talk about that a little later. The anemia data is really interesting. The gout data kind of makes intuitive sense given NLRP3 activation. But I don't think we can assume any of these things are necessarily going to work. But it's extraordinarily exciting to recognize the possibility that many things might well work. So I think the end game of this is going to be, we're going to have oral NLRP3 inhibitors soon. And they're going to all have to go through testing in all of these settings because I don't think we can assume the answer. And I'm going to predict in some settings they'll be terrific, in other settings they might not work. But how are you going to know in advance? Someone much smarter than me is going to have to figure that one out.
I actually think that is such a great point, and I've learned a lot, over the past 1.5 or 2 decades or so in this area, learning that is why we do clinical trials, because many times we have incredible hypotheses. Many times we think we are very, very certain, and yet when we do the large clinical trial, what we originally hypothesized did not come true, especially when you're thinking about benefit versus risk. So I completely agree. As a moderator, I just want to ask one more question before the session ends. I know we have a few more minutes. Somebody asked about another potential pathway. So we know that IL-17 and IL-23 are important pathways that are targeted across diseases, specifically in psoriasis, though, that may not have the risk of infection seen with IL-6 targeting. And the question was, does the panel see IL-17 or IL-23 as targets for lowering cardiovascular risk? Nehal, do you want to start with that?
I'll start, yeah. IL-17 therapy comes in forms of IL-17A inhibition, AF inhibition, and then the receptor brodalumab inhibition. So you can actually block the receptor. When you look at IL-17 therapy across the board, it appears that blocking A, recent paper in Nature Metabolism shows that there's benefit to adiposity in mice. There's benefit to lipid handling in mice. And our data, if you look, Paul taught me something years back. If you really want to read a paper, read its supplement. And Paul, I tell that to my lab meeting all the time. So in the supplement of most of our papers, you're going to see IL-17 has beneficial effects on fibrofatty burden, non-calcified plaque, PFI. Now, these do remain to be tested in randomized trials because our IL-17 randomized trial using FDG PET as well as FMD both showed that you needed to be inflamed to see benefit. So I think that if you have the right host, 17 therapy could be anti-inflammatory and anti-atherogenic. However, I just brought up in the improper host or in someone who has predisposition, it can actually cause a gut epithelial reaction that looks similar to IBD. So I think we just have to understand the biology a little bit more. My question in response to that, if someone else wants to take the 17, that's fine. But my question would be to Paul, asking if he believes that the IL-6 pathway looks to be something exciting because of what we had seen prior with the jump in LDLs. But the data you showed us, the concept you showed us makes me realize that possibly looking at this from a fragmented or a different molecule may be effective. So a question answer with a question.
I will touch on your IL-6 question with a little bit of saying, talk to me after the ACC is over, but let me just give you a little preview of that. So obviously a major pharma who knows what I know has decided to go ahead and do a targeted direct IL-6 trial for atherosclerosis risk reduction. And I think you can probably infer from that neither they nor I are particularly concerned about the theoretical issue of LDL increase on. So again, it's exactly what Jeff just said. I don't think you can assume that, what's an example here? That what you might know for tocilizumab vis-a-vis LDL change, which I think is pretty consistent, it doesn't necessarily mean it's going to be there for all IL-6 inhibitors, which of course can be very different in terms of how they function. And that's part of what the new data will show. And then Jeff said something else about why trials matter. I'll just remind everybody that everything we've talked about today, you would think would be true for diabetes. I mean, again, a huge literature about NLRP3 function and inflammation diabetes. We knew that literature 20 years ago and 15 years ago, and that's why in our Jupiter trial, we tracked incident diabetes because we thought it would go down. And of course, it went up. And then we learned that all statins increase a little bit. And so again, we have to test all these things to figure out what really matters. And I think with IL-17, we don't know.
I agree with that. I think, what we've circled the drain about here is that what's the best biomarker to identify risk reduction? And if we're not going to have a huge outcomes-based psoriasis trial, what are we using? And I think there have been biomarker trials in 1723. These drugs are, most of the IL-17 combined blockers, A, F, maybe C, in the specific IL-23 are approaching skin clearance rates upwards of 100%. So I think we need more data. I know Nehal is very active in this with CT angiograms of figuring out which one's the best to reduce cardiovascular risk. And the person who asked the question, Joe Gelfand, who we'll hear from in a few hours. So,
okay. To all of our viewers out there, this is going to be the end of our first section. This was fantastic. I just want to thank Drs. Ritger, Garshick, and Mehta. Really, I have learned a lot. I think a lot of our viewers have as well. I'm excited for the rest of the day. Just to remind everyone, there is a break now for 30 minutes until 10:25. Section 2 will start on time on clinical pearls in the identification and management of cardiovascular risk and pro-inflammatory conditions. We have, again, 4 outstanding speakers. So we hope to see you in 30 minutes. And I think we're off to a great start of the day. So enjoy, everyone, and we'll see you soon.
So welcome back. Thank you all for joining us for this symposium today. As a refresher, I'm Michael Garshick from NYU Langone Health. And we're going to start our second section right now, clinical pearls in the identification and management of cardiovascular risk and pro-inflammatory conditions. This section is going to run from 10:25. We're going to have a lunch break at 12:45. And that's just before the moderated question and answer session. And I'll invite you back at 1:30, where we're going to be having a really great lunchtime talk on barriers and to implementing dietary and lifestyle changes in these pro-inflammatory conditions. So without further ado, I'm going to introduce our first speaker, Dr. Daniel Solomon. He's going to talk about the identification and management of cardiovascular risk in rheumatoid arthritis. Dr. Solomon is a professor of medicine, chief of the section of clinical sciences in the division of rheumatology at Brigham Women's Hospital. He's really a leader, a world leader in this field of rheumatoid arthritis and cardiovascular risk. He's done a number of clinical investigations. He's a co-PI on an NIH-funded clinical trial testing the efficacy of DMARDs in cardiovascular disease. He's the chair of the FDA Arthritis Advisory Committee. I'm really honored and excited. We are really honored and excited to have him here. And Dr. Solomon, I'll let you take it away.
Well, thank you, Michael, and thanks for the invitation to speak today. This is a slide just to pick up where things left off this morning. This is a slide from my colleague, Paul Ritger, that he shows to the Harvard medical students in an early pathology lecture on atherosclerosis. And Paul likes to make the point that the atheros seen in the abdominal aorta on the left has great similarities to the pathology of rheumatoid arthritis. And so I think that's really where we started out with the morning session. And now I want to drill down on some of the issues as they pertain to rheumatoid arthritis. This was one of the early studies that we did using data from the Nurses Health Study, a very large cohort that's managed here at Brigham Women's Hospital. We were interested in comparing the risk of myocardial infarction and stroke among the women with rheumatoid arthritis compared with the women who did not report rheumatoid arthritis. And as you can see, after multivariate adjustment, we found a twofold increased risk of myocardial infarction, about a 1.5-fold increased risk of stroke. This was not statistically significant because of small numbers of cases over time. As more cases of rheumatoid arthritis and stroke have accumulated, this is indeed statistically significant. And this is really, again, just one of the early large studies that helped to define the level of risk that we observe in patients with rheumatoid arthritis with respect to their cardiovascular events. This sort of work really spurred us to look at this in other cohorts. And here I'm showing you data from a much larger cohort of patients that are derived from a administrative data set from British Columbia. These are all patients that had rheumatoid arthritis, 25,000 of those compared with a 10-to-1 match, 250,000 without rheumatoid arthritis. And we matched on some key factors. And what I'm showing you here is, again, very large cohorts compared with what we did originally in the Nurses' Health Study, with many events, over 1,000 events in the rheumatoids, over 6,000 in the non-rheumatoids. And what you can see, the incidence rates of any cardiovascular event in the rheumatoids, 14.8 per 1,000 person years versus 9.1, giving us a rate ratio of 1.6. So the incidence and the risks are clear in rheumatoid arthritis. This is really one of the most common autoimmune inflammatory arthritides that we see in rheumatology, as most people know listening in. We wanted to understand how different variables, traditional cardiovascular risk factors versus variables that we see only in rheumatoid arthritis, might contribute to that risk. And these were data that we generated over a decade ago from Corona. Corona is a very large US-based RA registry, actually co-led by Jeff Greenberg, NYU, a rheumatologist. At the time, there were 10,000 rheumatoids, median observation about 2 years. We looked at traditional cardiovascular risk factors listed here. As well, we assessed for a number of RA severity measures, duration of disease, serologic status, clinical disease activity index, rheumatoid nodules, erosions, total joint replacements, HAQ score, which is a functional status measure. And amongst the 10,000 patients with RA, we found 76 cardiovascular events at the time for 4 per 1,000 person years. And what we looked at here was how the cardiovascular risk factors listed on the z-axis compared to the x-axis, the RA markers of severity with respect to the incidence rate of cardiovascular events. And again, you can see that traditional CV risk factors helped explain part of the risk, giving us a C statistic of 0.57 when you add in age and gender, 0.61. But when you add in the markers of RA severity, the C statistic goes up quite a bit. Again, just pointing out that this is not just about traditional risk factors. This is about variables that we see specific to an autoimmune condition like RA. We've gone on to look more specifically at how disease activity might impact this. And I think this picks up on some of the themes that were raised during the first session with respect to psoriasis. But here we're looking at rheumatoid arthritis, again, going to the Corona registry now, about 25,000 rheumatoids, all of them on disease-modifying agents. And we looked at the time average clinical disease activity index every 6 months, so semi-annually. And Cox models were set up looking to estimate the risk for MI stroke and CV death. We looked at a number of different types of models. Model A, age and sex adjusted. Model B, we added in cardiovascular risk factors. And Model C, we added in RA factors and medications. And what you can see is that in all three models, patients with high disease activity had the highest risk. We set these as the reference group in this analysis. And as we gain better control of disease, moderate to low to remission, remission being in the black circle, the hazard ratio for cardiovascular events goes down. Again, this really suggests that disease activity in rheumatoid arthritis, at least a surrogate for inflammation, is associated with future cardiovascular events. This has been looked at using biomarkers by Jeff Curtis and others. Jeff Curtis, investigator at UAB, looked at something called the Multi-Biomarker Disease Activity Index, MBDA. This is also known as the Vectra biomarker panel. It contains 12 analytes listed here. And in this analysis, they're looking at the incidence rates of MI and coronary heart disease as they relate to different quartiles of the MBDA score. And again, you can see that as the score goes up, more biomarkers being elevated, the risk of MI and CHD goes up. So looking at this using clinical variables, as we did in the original Corona data, or looking at it with biomarkers, as was done here, gives very similar answers with respect to the risk of cardiovascular disease. I also want to raise the issue of venous thromboembolic disease, because not only are there very clear data that cardiovascular events are increased, but also VTE. And as well, I'm not going to talk today about heart failure, but heart failure risk seems to be increased as well. But here, these are data generated in the last year from some Swedish registry studies, very large numbers of rheumatoids, over 46,000, matched with the general population. And what you can see here is in the top analysis, this is only among the rheumatoid arthritis patients that the risk of VTE, so now I'm not talking about MI or other specific cardiac events, but VTE also goes up from low to intermediate to high with relative risks that are above 2 in the high disease activity. When we compare the rheumatoids to the non-rheumatoids, here general population being the reference, you can see about a doubling of the risk of VTE. So VTE, very interesting because, not an athero-related vascular event, but likely related to other factors as well as inflammation. And in these data from Sweden, there's a suggestion that as there's better control of disease activity, there's less of a risk of VTE. So, people have been very interested in how lipids might relate to cardiovascular risk in patients with autoimmune disease. And here, this was a paper published from investigators at Mayo Clinic a decade ago, Elena Maisadova. And here they pointed out that total cholesterol, as you increase total cholesterol, there wasn't a clear increase, as we might have anticipated, in the hazard ratio for CVD. And the same held true for LDL. And this was kind of termed the lipid paradox, and really is something that Nehal Mehta and others have studied. How does inflammation impact the lipid profile? And I think there's still a lot more to come on this issue, but it gets to how we risk stratify patients. Should we be using LDL levels, or should there be other markers of a risk stratification in patients with autoimmune inflammatory conditions? I also just want to highlight some data that were generated from my colleague Catherine Liao at the Brigham, where she kind of followed up the work from the Mayo Clinic. Here, looking at the odds ratio for major adverse cardiovascular event, MACE, in the rheumatoids, here looking at LDL levels and HDL levels. Let's focus on the LDL level. Again, you can see this reduction in risk with increasing LDL, which is curious. But as you might anticipate from general population studies, as the LDL went up over here to the right, the odds ratio for MACE also increased. And what I think she really added to this literature is looking at non-rheumatoids, and also found a very similar pattern amongst the non-rheumatoids. So again, I think this lipid paradox is still a work in progress, and much more needs to be done to understand which fractions of lipids, which types of inflammation, and in what circumstances there might be this sort of paradoxical relationship. However, the task that I was asked to speak about was the CV risk stratification of rheumatoids. And, we obviously have risk scores like Framingham, which is tried and true now, the population cohort equation, or ACC-AHA. But one of the things that was recognized by investigators from Mayo Clinic about a decade ago was that the Framingham risk score underestimates risk in rheumatoid. So here, we're looking at 525 patients with RA, a mean follow-up of almost 10 years, not many cardiovascular events. But the red here shows the gap between the predicted in the white bars and the observed in the black bars. So again, there's this discrepancy between observed and predicted being based on the Framingham risk score, observed being what was observed in these patients from the Mayo Clinic. And that really got many of us thinking that there were other issues at play. And perhaps when we think about a risk stratification tool, risk score in cardiovascular disease and RA, we needed to start with the Framingham, but think about enhancing it with other variables. And that's exactly what we did. Again, turning back to the Corona data, and we call this the expanded risk score, ERS for RA, ERS-RA. And here we derived and then validated it within the Corona data. And we added in several RA risk factors through a very rigorous process of testing one factor at a time in models that we call the base model. That's in the dashed line. The base model had the Framingham variables, and then we added in the CDI when it was moderate or high versus remission or low, the functional status score, MHEC, above 0.5, any prednisone use, and disease duration of at least 10 years. Those variables all made it into the model and improved the discrimination of this model. The C-statistic improved compared to a Framingham-only risk score model. We've gone on to look at how the base model is the Framingham model versus our expanded risk score model using 4 categories of risk, which was kind of the original Framingham. I know this has been updated in ACC-AHA models, but here what we're looking at is how, when we add in these other risk factors specific to people with RA, how do we do in predicting cardiovascular events compared with the base model, the Framingham model. And what I'm showing here with the green arrows is that we improve the ability to predict. The actual event rates are much closer to what was predicted using the expanded risk score compared to the base model, only Framingham variables. And that's shown with the green arrows in multiple cells. As you might anticipate, when you're testing many cells, many different variables, there will be some cells where the risk prediction is less good. And that was seen in this specific cell marked with the red arrow. But the net reclassification index was quite good. And we have a lot of enthusiasm for this sort of expanded risk score. And in fact, we've collaborated with some of our colleagues from Sweden, looking at some of their registries. And this is an external validation of the expanded risk score. And we found quite good discrimination, again, in this external cohort. We actually have a tool on our website where people can go and you can see the URL at the top there. It's a little bit of a clunky and long URL, but it allows you to test a given patient sitting with you in clinic. And honestly, as rheumatologists will tell you, many of our patients with RA have relatively routine visits now that we have such a broad armamentarium. We find something that puts them in remission or low disease activity, and they come in and we get the chance to catch up with them about their grandkids or talk to them about their cardiovascular risk, which is what I often do. And I bring up the tool and I talk to them about how we can modify their risk. How do we think about the drugs that we use in rheumatology? The first session this morning got into a lot of different therapeutics, TNF, IL-17, drugs directed at the inflammasome. But in rheumatoid arthritis, we have our tried and true methotrexate. And methotrexate, as many know, has been tested in a number of observational studies. And there was this meta-analysis that I think I was involved with, and I think Paul Richter was a co-author on, that suggested a 21% risk reduction in cardiovascular events in primarily rheumatoids and some with psoriasis. And I think this was some of the reason why Paul was so bullish on methotrexate possibly being a treatment for cardiovascular risk prevention in the general population. The CERT trial was born, and I think this group knows CERT trial unfortunately did not give us positive results. Here's a brief review. I think Paul probably gave this early on this morning, but 4,700 patients randomized, all had known diabetes, metabolic syndrome, and CAD. And after 2.3 years, the trial was stopped. It was felt to be futile. And, the risk curves, the cumulative incidence are shown here. But the big question is why did low dose methotrexate fail? And again, this was something that Paul touched on. And, inflammation comes in many flavors. It's not so simple. It's not all IL-1 and IL-6. There's many types. And methotrexate as a broad immunosuppressive really has effects very different than an IL-1 antagonist like canakinumab. How about TNF in rheumatoid arthritis? And I'm showing you here some data that were generated about a decade ago in an observational study, 17 patients with active RA compared with 34 patients with stable known CVD. And all of the rheumatoids had active disease and were started on an anti-TNF agent. And they underwent FDG PET. The aortic TBR results are on the top, the TBR in the most diseased segment on the bottom. And after 8 weeks of a TNF antagonist, there was significant reduction in the FDG PET vascular inflammation indicators. And this has given a lot of us enthusiasm about pursuing TNFs in this role as well. Observational data. This is a meta-analysis from over a dozen observational studies suggesting that patients on a TNF antagonist compared to other DMARDs had a 30% reduction in cardiovascular events. So this, gave us optimism. And Joan Bathon, another rheumatologist, chief of rheumatology at Columbia, and I have this target trial, which we've enrolled our last patients, and our last visits are in the next several weeks. This is an FDG PET study, 24 weeks among patients with rheumatoid arthritis who were inadequate responders to methotrexate. They were then randomized to adding a TNF antagonist, etanercept or adalimumab, or triple therapy. Triple therapy is the addition of sulfasalazine and plaquenil to methotrexate. It's been shown to be clinically similar over 1 to 2 years. But the question is whether the FDG PET results would be different after 24 weeks. And the hypothesis that we're going to be testing in the analyses to be done this summer are that the TNF antagonist arm will outperform the triple therapy arm with respect to vascular inflammation reduction. However, there's again, this was touched on in the first session. There's dyslipidemia that we see with IL-6 blocker tocilizumab, the JAK inhibitor tofacitinib. There's concerns that have been raised recently about major adverse cardiovascular events. And we do know that there's a lot of patients develop dyslipidemia. Even some patients on TNF inhibitors develop dyslipidemia. So again, it's not such a clear shot that these potent immunosuppressives are necessarily going to improve cardiovascular outcomes. And as I think was stated in the first session, this is exactly why we do cardiovascular event trials, or with respect to target, it's an intermediate endpoint, the FDG PET trial. So there are observational data around tocilizumab here. This was a phase 4 FDA-mandated observational study that I participated in. It was a multi-database study, Medicare Pharmetrics market scan, led by my colleague So-Young Kim. And we compared tocilizumab cardiovascular event rates to TNF event rates. And again, you can see the incidence rate, 0.52, 0.59, incredibly similar. This was published in 2017. Already there had been a trial called the INTRACT trial that was also mandated by the FDA that was enrolling and finishing up. And again, this was published in 2019 in Arthritis and Rheumatology, an open label RCT, 3,000 patients randomized to tocilizumab or etanercept. Primary endpoint was major adverse cardiovascular events. And here the hazard ratio is really very close to 1. So observational data, when done well, can give you very similar results to a randomized trial. And I think these two complement each other and should give us a lot of comfort that the risk of cardiovascular events is quite similar between tocilizumab, an IL-6 blocker, and a TNF blocker like etanercept. So 2 active agents, not a placebo-controlled trial, but still very important information. The bugaboo of rheumatology is steroids. Corticosteroids are used commonly. About 25 to 40% of patients with RA will use steroids in a given year. 20% will be on them chronically, often at dosages below 5 milligrams. But the observational data are very clear that cumulative dose is really a bad actor with respect to cardiovascular events. This is a meta-analysis with about 250,000 rheumatoids, 500 cardiovascular events, and you can see a 50% increased risk of cardiovascular events in the patients using steroids. However, I will say that in observational data, it's impossible to disentangle the effects of RA disease activity from steroids. And there will never be a large randomized trial of steroids and cardiovascular events. So these are the best data that we have. They may be confounded by disease activity, but I think that most rheumatologists would agree that less steroids is always better steroids. So I spend a lot of time talking about dose reduction of steroids in my patients. Thinking about mechanisms between cardiovascular disease and rheumatoid arthritis. We know that IL-1 is an important actor within the joint. This is important in OA. Paul Ritker mentioned the OA sub-analyses of Cantos trial. We saw a reduction in total joint replacements through IL-1 blockade. We know IL-1 is important in RA. IL-1 antagonists are not as effective in RA, but IL-1 is an important cytokine in joint destruction. And we know that IL-1 is clearly an important cytokine in cardiovascular disease, as demonstrated by Cantos. This is a cartoon that I don't need to reiterate, but people see kind of this 2-step activation of the inflammasome, and then the inflammasome after being the different components being produced, being assembled, and this giving us the pro-IL-1 to IL-1 enzymatic reaction, and then the pyroptosis, which we know is important in many conditions: autoimmune, autoinflammatory, gout, and likely cardiovascular disease. As well, we think about IL-6 as being a critical cytokine in many of our autoimmune inflammatory arthritis, but especially in rheumatoid arthritis. We know that IL-6 blockade is very effective in rheumatoid arthritis, and IL-6 really has multiple roles and is derived from multiple cells in an active rheumatoid synovium. We also know that IL-6 is incredibly important at the atherosclerotic plaque. And as people talked about in the first session, IL-6 blockade is under investigation as a possible treatment for cardiovascular events. Oxidized LDL is something that's being explored by a number of investigators. We know that the levels are increased in patients with active rheumatoid arthritis. And it has an interesting relationship to non-oxidized LDL, and whether there can be some targeting of this by some treatments going forward will be interesting. It's likely an interesting biomarker, and many of us are thinking about how we can add oxidized LDL or other lipoprotein fractions to biomarker panels that might help us with risk stratification in RA. I think I'm at the end of my time to just give you a couple of conclusions. Patients with RA are clearly at an increased risk of all forms of CVD, including venous thromboembolic disease. The traditional CV risk factors are part of the RA CVD story, but systemic inflammation, RA factors, probably some biomarkers still to be confirmed, also underpins risk. The lowering RA disease activity likely reduces CVD risk, but it's really unclear whether different treatments may differentially impact risk, and that's why Dr. Bethan and I are pursuing the TARGET trial, and we'll have some results in the next 6 months. Clinical implications, I have a low threshold for preventative CVD treatments like statins and working up patients with autoimmune inflammatory arthritides, as well as HIV and psoriasis. Aggressive disease control likely lowers CV risk and should be discussed in patients. I have patients that are quite happy to sit in lower moderate disease, but I always push them to lower disease activity limits because of a variety of factors. Long-term steroids likely raise CV risk, should be avoided. I didn't talk about NSAIDs and COXIBs today, but NSAIDs and COXIBs clearly associated with CV risk and are contraindicated in patients with recent CV events. And when we in rheumatology, we prescribe NSAIDs and COXIBs like they're candy, but we often don't spend enough time talking to patients about their prior CV history and potential CV risk of these agents. This is something that I spend time documenting when I talk to patients. And I will stop there and just say thank you very much for the time to talk.
Thank you, Dr. Solomon. That was really wonderful. And I really love how you discussed the utility of cardiovascular risk scores for a potentially personalized approach to this, kind of challenging topic at times. We've left up a lot of questions from the last Q&A session, which I think really can be translated into the end of this session as well. But please, please, please keep asking them and we'll try to answer them. So next up, I'd like to introduce Dr. Mariana Kaplan. Dr. Kaplan is going to be discussing identifying and treating atherosclerosis and systemic lupus erythematosus, probably, I think, one of the highest risk cardiovascular conditions and very, very challenging. Dr. Kaplan is a senior investigator and chief of the systemic autoimmunity branch, as well as the deputy scientific director of NIAMS. Her research focuses on unraveling fundamental mechanisms that confer susceptibility to immunologic tolerance in conditions such as lupus. We're really honored and pleased to have her speak here today. I understand she's also a close colleague of Dr. Mehta. And with that, I will give her the floor.
Thank you very much. And I want to thank the organizers for their kind invitation to this great meeting. So just my disclosures. And what I hope to do today is I will review some perhaps unique aspects of cardiovascular risk in lupus. I would like to talk a bit about the potential mechanisms that are involved in premature vascular damage in lupus, and our group has focused a lot on the role of innate immune responses. And then at the end, we'll talk about some potential interventions to try to prevent or mitigate this risk. So just briefly, some of the aspects I want to emphasize for the purposes of my talk is that, as you know, this is an autoimmune syndrome that primarily affects young women, disproportionately affects minorities. And one key aspect of lupus that really complicates the assessment of vascular risk in this case is the profound clinical heterogeneity. We call it the disease of the thousand faces. This is really a syndrome more than a disease. And also the fact that patients go through periods of flare and remission throughout their disease course. And even when they're clinically inactive, many have smoldering disease activity as evidenced by markers that we use the specific markers that we use to talk about disease activity in lupus, and whether that smoldering disease activity subclinical plays a role in promoting the evolution of cardiovascular disease still remains to be determined. As you know, they require the chronic use of immunosuppressive drugs, and how that modulates cardiovascular risk is an area of intense interest. And a point I want to emphasize is that in the case of lupus, the dysregulation in the type 1 interferon pathway, both chronic enhanced levels of type 1 interferons and enhanced response to these type 1 interferons, appears to be key in the pathogenesis of lupus. And I'll talk about this pathway in the context of cardiovascular risk. And this dysregulation in this pathway is not unique to lupus. We see it in other autoimmune diseases such as dermatomyositis or Sjogren's syndrome. But in this case, it's probably the disease where it's studied the best. And so just to emphasize that despite the fact that women with lupus are doing much better now than they were 50 years ago, when you look at the cumulative mortality in lupus, thinking that these are young women at the type of diagnosis, most of them, you can see that the cumulative mortality is pretty striking, more striking in African Americans than in Caucasians, but striking in both groups in this case. And what I want to also highlight on the right is that having lupus and getting older is a pretty bad combination. And this was a study from 15 years ago, but I don't think things have changed, that even in pretty young patients, patients in their 30s, you already see a significant increase in the prevalence of atherosclerotic plaque. But of course, as the patients get older, you can see that the difference continues to be quite remarkable, and the risk to develop cardiovascular complications significantly increases. So what we can say at this point is that vascular events contribute substantially to increased mortality in lupus. In young women, actually, myocardial infarction risk has been described to be up to 50-fold compared to young women without lupus. And although for a long time the discussion was whether it was all due to vasculitis, what we know now is this appears to be due to accelerated atherosclerosis. Whether that atherosclerosis looks the same as the atherosclerosis you will see in the general population is a matter of discussion. Furthermore, in general, what we know is traditional risk factors can only partially explain the increased risk of cardiovascular disease. Not that they don't play a role, but they cannot account for the majority of the cases. I want to emphasize that patients with lupus are more likely to die following their first MI than patients with diabetes, and that the average age of first MI is considered to be about 10 years younger than in the general population. And I also want to emphasize that although we're focusing on atherosclerosis, this vasculopathy that is such a prominent feature of lupus patients may also be playing a role in other end-stage complications in these patients, the progression of renal disease, involvement of the central nervous system, many of the pregnancy complications that are much more prevalent in lupus patients. And this is a concern also in childhood onset lupus, that we do know that kids who develop lupus have evidence of subclinical atherosclerosis developing at a very early age, which is quite concerning. So the overall message I want to give here is that not that traditional risk factors do not play a role, but that immune dysregulation, characteristic of lupus, appears to be a key driver in the development of premature atherosclerosis in this patient population. And so, similar as with what we have discussed for other diseases during this meeting, lupus patients without prior vascular events, the vast majority of them that we have studied, and this has been replicated in studies from different groups, they will show evidence of subclinical vascular dysfunction and subclinical atherosclerosis. So here I'm just highlighting some of the studies we did now almost 15 years ago, almost 20 years ago, showing that young women with lupus have evidence of profound endothelial dysfunction, increased arterial stiffness, and then there have been multiple studies showing, for example, evidence of myocardial perfusion abnormalities, increased LV mass. And when you look at subclinical atherosclerosis, there is evidence for both enhanced carotid plaque and increased coronary plaque, even in those young women, and sometimes just a couple of years after diagnosis. What is unusual about the development of atherosclerosis in lupus, and what can we learn about the heterogeneity of atherosclerosis development in the general population? And I may posit that there are some very unique features in lupus cardiovascular disease that perhaps differ somewhat from what we know about cardiovascular disease in RA or in psoriasis, even if there are, of course, commonalities. One is, of course, this is a disease of young women, and young women shouldn't be getting atherosclerosis, but we have all seen as rheumatologists striking cases of women that present as first symptom of lupus or first manifestation of lupus with an MI. And they have never been on steroids. They don't have other risk factors for cardiovascular disease. If something tells us that before they develop over lupus, something happened in their immune system for a long period of time that led them to present this way. The other thing I want to emphasize is that the classic inflammatory burden that we associate with atherosclerosis and that has been so beautifully described by the talks earlier this morning, does not appear to be a key factor or a prominent or prevalent observation in lupus. And one thing I want to emphasize is that we typically don't see in the majority of lupus patients high levels of CRP or high sensitivity CRP. And in fact, when we see high levels of CRP in lupus patients, we have always been told suspect infection. And why does CRP not, we don't see this increased CRP response in lupus is in fact associated with the observation or that type 1 interferons are increasing lupus, because type 1 interferons have been demonstrated to suppress CRP response. And so in our observations, both studies we did when I was at the University of Michigan and now at the NIH, we never see CRP correlate with any of the markers of vascular damage that we have followed, both subclinical and clinical vascular disease. So this complicates things further where we're trying to assess risk. And in fact, I may expand that many of the biomarkers that you see mentioned in studies in the general population or in other inflammatory conditions, in our hands and from other observations, do not significantly correlate with vascular risk in lupus. Again, another, what is unusual and want to emphasize is that enhanced cardiovascular risk in lupus cannot be fully explained by framing a risk equation. And we'll talk a little bit more about lupus medications. And there's, like Dan was saying, a lot of discussion about the role of steroids. But looking at steroids, we still hear a lot that this is all from steroids. The studies that have been done in lupus do not support that these are main drivers of the enhanced atherosclerosis. Not that they do not play a role and we must limit at all costs higher doses of steroids, but they don't seem to explain this enhanced risk. And the other observation, although these trials have been small in lupus, is that both in adult and pediatric lupus, the trials that have been done so far on statin have been quite inconclusive about the role they play in decreasing cardiovascular risk. So at the NIH, and this has been a really great collaboration I established with Nehal Mehta's group when I moved to the NIH, is we have a study to better understand the natural history of SLE with regards to the development of cardiovascular disease. So in a very simplistic way, what we do is we bring lupus patients. We have a large cohort that we follow at the NIH. We do phenotypic characterization, and at each visit, we have, we collect a number of biomarkers. We measure small, medium, and vessel vascular function by a variety of methods. We perform FDG PET-CT to look for arterial wall inflammation, and we do CT angiogram to assess coronary plaque. And this is allowing us to hopefully to better understand the natural history, to use it also, something that Nehal and I want to do, to compare it, for example, with psoriasis and look at commonalities and discrepancies, and also to enroll patients on clinical trials, the proof of concept clinical trials to assess the modulation of these of various drugs in these disease manifestations and complications. What we have found so far is that patients with lupus, and confirming what we had seen previously and what other groups have seen, is their arteries are quite stiff, and these are young patients, the majority are women, but when we do cardio-ankle vascular index, you can see a significant increase in arterial stiffness. And in these same patients, we have confirmed the prevalence of aortic wall inflammation by FDG PET-CT in association with enhanced prevalence of non-calcified plaque burden in the coronaries. And this has been the most striking finding, that this appears to be at the expense of non-calcified coronary plaque. So when we try to dissect what are the key factors driving premature atherosclerosis in lupus patients, this becomes quite complicated because lupus is such a complicated disease when you study pathogenesis. And so, but we can say that there are, of course, a variety of lupus-specific factors that may be associated with enhanced endothelial cell damage and accelerated plaque formation. And of course, there are autoantibodies and immune complexes and a variety of cell types that are dysregulated in lupus, and that may be playing some role in damaging the vasculature. We also know that there are a number of cardiometabolic factors that are not lupus specific, but that are enhanced or more prevalent in lupus patients, including the presence of renal disease, high incidence of insulin resistance, and we'll talk a little bit more about dysregulation in lipoproteins in SLE. And there are certain genetic polymorphisms that convey risk to lupus that have also been associated with enhanced risk for cardiovascular disease. So I want to talk about a couple of the pathways that my group has been focusing over the last 15 years or so. I'll try to then discuss a bit some potential therapeutic strategies that we're investigating regarding these pathways. And I mentioned to you that type 1 interferons are key drivers in lupus pathogenesis, and this has been through the use of animal models, but also studies done both in vitro in patients, and also the recent evidence that from clinical trials. But what we have also found is that this chronically prolonged enhancement of type 1 interferon responses in lupus also may be a central player in mediating vascular damage. So just in a schematic way and summarizing many years of work by our group and others, is that type 1 interferons have pleiotropic effects in the vasculature of lupus patients. They can impair vascular repair that may be triggered by a variety of signals that are more prevalent in lupus patients by interfering with the phenotype and function of endothelial progenitor cells. They can promote the formation of foam cells from macrophages directly through interactions with specific receptors in macrophages. They are strong platelet activators and can induce, and that may promote or enhance acute coronary events. And there have been, they also have direct effects on vascular smooth muscle cells, promoting proliferation. And there have been some recent hints, very interesting, that type 1 interferons can have effects in the liver that can promote insulin resistance and contribute to metabolic syndrome. So all this has led to thinking that the group of cytokines in the context of lupus patients may be central not only to many disease manifestations, but to the progression of atherosclerosis. And the other component of the innate immune system that we have been particularly interested in studying in the context of lupus is the role that aberrant neutrophil function may play in this phenomenon. So for more than 10 years, we've been studying this kind of unique or distinct neutrophil cell subset called the low-density granulocytes. And this is because when you do a Fickel gradient, typically neutrophils will go to the bottom of where the red blood cells are. But in lupus patients, invariably, we find at various degrees of frequency, these cells, these neutrophils that actually colocalize with the mononuclear cells in a Fickel gradient, and that we have spent a lot of time trying to figure out the role they play. And what we think is that they they really are a distinct pathogenic neutrophil subset that plays important vasculopathic effects. And one of the things they do, and by which we think they are involved in damaging the vasculature, is they're exquisitely primed to form neutrophil extracellular traps or nets. And these nets, in the context of lupus, appear to be particularly good at damaging the endothelium. And so when we have gone and looked into the, within our cardiovascular lupus cohort, what are the markers that may be associated with either enhanced non-calcified plaque or enhanced vascular inflammation or vascular function. As I mentioned, the typical biomarkers that are associated in other disease groups really, in our hands and for what we have seen in other groups, do not significantly correlate with markers of vascular damage. What was quite striking in our observation is that when you look at the levels of low-density granulocytes in lupus patients, there is a significant correlation with the degree of non-calcified plaque burden and with the degree of vascular inflammation. And in fact, when we have done RNA sequencing analysis looking for a low-density granulocyte gene signature in lupus patients, it is those patients that have high levels of low-density granulocytes that will show significant, or patients that have this low LDG gene signature that will have higher levels of non-calcified plaque burden and increased vascular inflammation. And this has persisted after multivariate analysis, adjusting for non-confounders in this patient population. So this suggests that LDGs may play a prominent role in driving vascular damage in lupus patients. And in fact, there have been evidence, and some of the initial evidence that nets were implicated in vascular damage actually came from the observations in lupus patients. But now there is, I think the field of nets and vascular damage has really exploded. And we know that nets can have pleiotropic roles in promoting vascular damage. They can directly kill endothelial cells. They're potent inducers of thrombosis. They can actually themselves induce more type 1 interferon synthesis and inflammasome activation. So they may amplify these inflammatory loops. I'll talk a little bit more about the role that they may have to directly oxidize lipoproteins and impede some anti-atherogenic roles of HDL, for example. We know from animal models that our group and others have performed that net inhibition can mitigate atherosclerosis in these animal models. And overall, there seems to be an important crosstalk in the context of lupus between nets and type 1 interferons. And our current working hypothesis is that lupus perhaps represents this extreme phenotype that perhaps is happening in other inflammatory conditions, where there is this pathophysiological alliance between enhanced net formation and enhanced type 1 interferon signaling pathways that may converge at the level of the artery, and through multiple pleiotropic effects in various inflammatory cells, chemokines, pro-inflammatory cytokines, platelets, etc., may promote this accelerated vascular damage. So a few minutes, I would like to talk about some of the work on dyslipidemia in lupus, and the field has been somewhat confusing, and some of the papers may be contradicting each other. But overall, these are some of the observations that have been made regarding abnormalities in lipid profiles in lupus patients. What I would like to emphasize is that in our hands, a lot of the abnormalities we see are primarily on HDL and HDL function. And when you look at correlations between markers of vascular risk or subclinical atherosclerosis, it is not so much the LDL that is associated with the changes we see, both when we look at lipid profile, but also at NMR and lipoprotein particles. The main associations we see are with high-density lipoprotein abnormalities. And so Nehal gave this very nice introduction about impaired cholesterol efflux capacity and vascular risk in psoriasis. Observations from several years ago from Barbara Hannan, Maureen McMahon, and UCLA have shown that lupus HDL is pro-inflammatory. And we have confirmed this by looking at cholesterol efflux capacity in lupus patients. And you can see that it is significantly impaired. And these are observations that have been replicated by several groups. And in fact, in our studies in the lupus cohort at the NIH, we see that cholesterol efflux capacity is significantly negatively correlated with the presence of non-calcified plaque burden. What is interesting is that the observation is that HDL from lupus patients becomes oxidized in region-specific areas of the lipoprotein, and that these same modifications that we observe in HDL can be triggered by the nets that are formed by low-density granulocytes. So we believe that nets, aberrant net formation present in lupus patients may modify the HDL to make it lose its atheroprotective capabilities and impair, among other things, cholesterol efflux capacity. And an interesting observation has been, this was a beautiful paper by Ike Lat's group several years ago, and what they show is that some of the anti-inflammatory effects of the HDL are related to its ability to block toll-like receptor signaling pathways upon exposure to danger signals. And this is done through engagement of this transcription factor, ATF3, that suppresses pro-inflammatory cytokine synthesis. Now, what we found in the case of the lupus HDL is because it becomes oxidized, this pathway is not functional and not operational. And in fact, the oxidized HDL from lupus patients signals through the oxidized LDL receptor and leads to increases in pro-inflammatory cytokines. So in this context, we would have a model where nets that are being formed by aberrant lupus neutrophils releases pro-inflammatory oxidative molecules that oxidize the HDL, impair cholesterol efflux capacity, promote the induction of M1 macrophage polarization with enhanced cytokine synthesis, and all these factors may be involved in promoting cardiovascular disease. So in the last few minutes, I would like to talk a bit about prevention and tell you a little bit about what we're thinking about modifying specific pathways that we think are relevant for cardiovascular disease in lupus patients. So what I would like to say in general is that the guidelines for cardiovascular prevention in lupus remain highly nebulous, and I think this is an area of great need that the examples that we have seen from guidelines in diabetes and other diseases have not yet translated into proper guidelines for cardiovascular prevention in lupus. And what the most you may get is that it is important to do yearly monitoring of traditional cardiovascular risk factors and, of course, control these risk factors, which may synergize with the vascular risk given by immune dysregulation in lupus. But there are still a lot of questions. For example, how do we treat lupus as a cardiovascular disease equivalent? How do we follow recommendations on lipid management? And as I mentioned before, even if we think statins are very important for cardiovascular prevention, their role in lupus and the way they may have in preventing cardiovascular disease in lupus is quite unclear. The European League Against Rheumatism has come up with some recommendations about this, but again, they're pretty vague, and those are that calculation of the 10-year cardiovascular disease risk using the score is recommended, and that they point, although the actual risk is underestimated in patients with lupus. And then there have been some recent studies trying to compare the Q-risk-3, which includes SLE as a variable, versus Framingham versus the ACC, American Heart Association. And there have been some suggestions that the Q-risk-3, because it includes SLE, is probably more favored to talk about cardiovascular risk in SLE. But again, these are areas of great need that need to be further studied in larger groups of patients to try to better assess who is at particular risk to develop accelerated atherosclerosis in SLE. And what about medications and primary prevention? So we heard a lot about these things this morning. There have been some small studies suggesting that use the Mediterranean diet in lupus may have favorable effects. There have been many discussions about the roles of antimalarials, which are drugs that we use very often in our lupus patients. And there is evidence that hydroxychloroquine may lead to reductions in overall mortality in SLE. And this may be in part by vascular protective effects and improvements in lipid profiles. And interestingly, antimalarials decrease both weak inhibitors of type 1 interferons and of net formation. So perhaps some of their role is through the pathways I have mentioned. I won't talk much more about the corticosteroids after what Dan said in his very nice talk. But again, the balance between, of course, limiting the dose of steroids, but also making sure that patients are well controlled, because there is some evidence from studies from Jane Simon's groups and others that uncontrolled SLE is a significant risk factor for the progression of lupus cardiovascular disease. We don't use methotrexate that commonly in lupus, but I think it remains to be determined whether the observations that were present in RA regarding decreases in cardiovascular mortality, but of course not replicated in the general population, may apply to lupus or not. We do often use mycophenolate mofetil in lupus, and there is some nice data from the transplantation field that it may have some vascular protective roles. There is conflicting data in the case of lupus, and I don't think we have an answer yet on whether this is a strategy that may help to prevent vascular disease progression in SLE. And again, the role of aspirin, statins, and ACE inhibitors, I think, is still being debated on how effective they are at preventing progression of cardiovascular disease. Of course, not that they shouldn't be used, but I think we need more guidelines and larger studies to, the jury is still out there with regards to these drugs. Now, I want to spend the last couple of minutes just telling you very briefly about some studies we have done to try to address whether targeting the type 1 interferon pathway and net formation may mitigate vascular disease. And these are preliminary studies that we're hoping to expand in larger patient groups for longer periods of time. This was using data previously acquired during the anifrolumab trial in lupus, which is a type 1 interferon receptor inhibitor. And we were able to collaborate with AstraZeneca to obtain data from the phase 2 study design, which used anifrolumab at 2 different doses for up to a year of treatment. Because the samples we obtained after the study was completed, we were only able to obtain serum and plasma, so we had to get very creative. But what we were able to measure in patients who receive anifrolumab versus placebo was whether for the presence of net formation, because the idea is that type 1 interferons may prime neutrophils to form nets, even if they don't directly induce it. And we know that levels of nets are increasing the circulation of lupus patients, and these nets can damage the vasculature. So what we were able to see is that patients that receive anifrolumab at 1 year had significantly decreased levels of nets, whereas those that had received placebo had actually increased the levels of nets, suggesting that we can mitigate net formation by inhibiting the type 1 interferon pathway. And furthermore, we were able to look at cholesterol efflux capacity, thinking that if we can decrease NES, we may be able to decrease oxidation of HDL. And what was interesting is that, of course, cholesterol efflux capacity was significantly decreased in lupus. Being on placebo did not significantly change cholesterol efflux capacity, but those patients that receive anifrolumab had significant increases in cholesterol efflux capacity, suggesting that modulation in the interferon pathway may alter this biomarker. And lastly, we have recently been working on the JAK-STAT pathway and inhibition of this pathway, because as you know, type 1 interferon signals to the JAK-STAT signaling pathway, and neutrophils have a very active JAK-STAT signaling machinery. So we did a phase 1/2 clinical trial of tofacitinib in lupus patients. And I will just very briefly mention some of the results that are pertinent to vascular risk and neutrophil dysregulation. Interestingly, low-density granulocytes in patients on placebo went up, whereas they went down in patients that were on tofacitinib. And we also saw significant decreases in the ability of patients to form nets when they were on tofacitinib when compared to placebo. The type 1 interferon pathway, of course, was modulated down. And importantly, we saw that this was kind of expected, that HDL was increased when the patients were on tofacitinib, which is they stop at day 56, whether no changes were observed in the placebo arm. But most importantly, cholesterol efflux capacity on tofacitinib significantly increased in lupus patients within the 56 days of treatment, whereas it didn't change in patients on placebo. And this was associated with significant decreases in arterial stiffness on tofacitinib as measured by CAVI by day 56. So just in that we may be able to modulate vascular function and cardiometabolic abnormalities in patients with lupus with JAK inhibitors, and we are planning a larger study to further prove our hypothesis. So just to finalize here, my take-home points are, I hope I convey that, increased cardiovascular risk with lupus is a big problem, and it's related perhaps to a combination of both traditional and non-traditional risk factors. I think that long-term suppression of immune dysregulation may be an important way to try to lessen cardiovascular risk, but strategies to reduce traditional risk factors should be implemented. And we are very interested in further exploring whether therapeutic strategies that block type 1 interferon signaling and aberrant neutrophil function may improve cardiovascular risk in lupus. And we desperately need disease-specific guidelines for cardiovascular prevention in SLE. And just to end, I want to thank many people at the NIH and also during my time at Michigan for all these studies, my collaboration with Nehal Mehta, the great work from the Lupus Clinical Group, and collaborators outside the NIH. And thank you very much for your attention.
Thank you so much, Dr. Kaplan. Your points in CRP are very well taken, and clearly a lot of very exciting therapeutics in the pipeline that hopefully can be proven efficacious later. So I'll jump right into our next speaker, Dr. Joel Gelfand. Dr. Gelfand is going to be talking about identifying risk and preventing cardiovascular events in patients with psoriasis and psoriatic arthritis. Again, I have the pleasure of introducing a real world leader in the field, someone who's really helped develop this field of cardiovascular epidemiology in psoriasis. He is a professor of dermatology and epidemiology at the UPenn School of Medicine, vice chair of clinical research, medical director of dermatology clinical studies. He's really a nationally and internationally recognized expert in psoriasis. Again, we are very honored and pleased to have him here. So Dr. Gelfand, please take it away.
Thank you, Michael. And I assume you can hear me well? Everything's working? Okay, excellent. It's great to be with you all. It's been a terrific meeting so far, and I'm enjoyed to be with you all today. And I invite you to follow me on Twitter at Dr. Joel Gelfand. Let's see if I can advance. Okay. There we go. These are my disclosures. And these are my learning objectives. I'm just move past them in the interest of time. So we're going to try a little audience response opportunity here. So on your screen, you should have the opportunity to answer this question, which is which anti-inflammatory treatment commonly used by medical dermatologists and rheumatologists is proven to prevent cardiovascular events in a placebo-controlled trial? And your options are adalimumab, methotrexate, canakinumab, colchicine, or secukinumab. So hopefully everyone could do a quick vote. And then the folks behind the scenes will send me a message of what the audience response poll was. And if you listened to Paul Ritger's talk earlier, then you should know this answer. Move on, and I'll reveal the poll results later on. All right, so first of all, let's talk about psoriasis. This is a chronic inflammatory disease. It has red, thick plaques that crack, bleed, and itch. They occur in the trunk, the scalp, the extremities, the genitals, the nails, basically anywhere. Affects 2 to 4% of the adult population, so it's one of our most common chronic immune-mediated diseases. And there's over 125 million people worldwide with this disease. The impacts on health-related quality of life of psoriasis exceed those of things like cardiovascular disease, diabetes, and even arthritis. And despite all of our advances in understanding psoriasis, it still remains a highly stigmatized disease. So in recent surveys of the US population we've showed about a third of US laypersons think that psoriasis is contagious, not a serious disease, and only affects the skin. So we have a long way to go to improve how people think about this problem. This is sort of a paradigm of how we think a disease like psoriasis relates to cardiovascular disease. First, there are shared environmental and genetic risk factors for developing psoriasis. And these risk factors often overlap with factors that predict or create cardiovascular risk. There is the pathophysiology of psoriasis that clearly overlaps with atherosclerotic disease, thrombosis, and cardiovascular events. And then there's potential treatment effects as well as the burden of this disease. And what our work has tried to do over the years is trying to tease apart, how much of this relationship is from the disease itself or these commingling risk factors that are shared between psoriasis and cardiovascular disease. This is sort of a summary of the initial work we did in the early aughts, if you will, using large medical record systems in the United Kingdom, studying over 100,000 patients, dividing mild disease as patients who are not receiving systemic phototherapy, more severe diseases, those getting systemic phototherapy. And what you see is a clear dose response that you see more clinically significant relationships between MI, stroke, cardiovascular death, and even things like advanced chronic kidney disease and diabetes. And this is independent of risk factors traditionally measured in a medical record system. It also accumulates in about 5 years of life lost, with cardiovascular mortality being the number one excess leading cause of death in people with psoriasis. So if we could eliminate the excess risk of cardiovascular mortality in people with psoriasis, we could add a number of years back to people's lives. This work has since been confirmed in a number of meta-analyses. These meta-analyses are really just lumping studies that had very different methodologies. They often didn't look at disease severity. They may not have adjusted for confounding variables like we did. But in any event, you can see a fairly consistent pattern here in over 500,000 patients, roughly 40% higher rates of cardiovascular disease in people with psoriasis. And a similar story for people with psoriatic arthritis, and smaller number of studies in this case, but similar conclusions that people with psoriatic arthritis primarily have higher rates of cardiovascular outcomes. So then we started to do some studies looking simultaneously in the medical record system in the United Kingdom of people with either psoriatic arthritis, psoriasis, or rheumatoid arthritis, following them longitudinally using the same statistical model and seeing what would happen with these outcomes. And interestingly, we see a clearly strong signal for diabetes, which is elevated in people with psoriatic disease, but not so much so in people with rheumatoid arthritis. And then when we look at cardiovascular mortality and all-cause mortality, now we look at people on disease-modifying agents like methotrexate, for example, you see that psoriasis behaves much more like RA, even potentially exceeding RA in terms of all-cause mortality compared to, say, PSA. So clearly skin is an important driver of what's going on in these events in people with psoriasis, but we know the joints are important as well. And this is sort of a paradigm shifting paper that sort of led people to suggest, well, psoriasis really should be considered part of the risk models for cardiovascular disease. So then we were doing a prospective cohort study that we started in 2009. This was funded by the NHLBI through an R01 mechanism. And basically we call this the Incident Health Outcomes in Psoriasis Event Study, the IHOPE study. We started this in 2009, as I mentioned. It's people 25 to 64 years of age. We identified roughly 10,000 people who were eligible for our study. And we used a system of research in the UK where you get very high response rates because the GPs are being compensated. So response rate was nearly 96%. And this work is ongoing today. And we basically asked the general practitioners to tell us a little about the patient's psoriasis, because the medical record doesn't tell you a lot about what's going on with their disease. So we said, can you confirm they actually have psoriasis? Have they seen a dermatologist and had it confirmed? How long have they had it? And then we use these sort of epidemiological models of defining disease severity, meaning that you have less than 3% body surface area, 3 to 10%, or more than 10%. To define sort of mild, moderate, or severe disease. And once we got these sort of estimations of body surface area from the general practitioners, we then followed people longitudinally. And what we've found in some of the papers we published so far is that clearly body surface area is prognostic for future major events. So looking at people who have 10% or more body surface area as a static measurement, follow them over 4 or 5 years of follow-up, you see they have a roughly 80% higher risk of dying over that period of time, independent of all the mortality risk factors in the GP's medical record, their body mass index, their smoking, and other health issues. Similarly, on the right side of your screen, what we found for diabetes is that for every 10% increase a patient has in their body surface area, they have a corresponding 20% higher risk of developing diabetes over time, again, independent of risk factors for diabetes captured in their medical record system. So, this clearly begs the question, as your disease is getting worse, your risk of bad outcomes gets worse. So, should people with psoriasis have their skin disease aggressively treated to lower their risk of cardiovascular disease? By paradigm shift, if you think about it, in the late 60s, it was felt that hypertension was a lifestyle disease, that you didn't really need to treat it unless people were symptomatic. And it wasn't until the VA trial showed that lowering systolic blood pressure lowered the risk of stroke and mortality that completely changed the paradigm of how people thought about high blood pressure. And still, to this day, some people still think psoriasis is a elective disease to treat. We still conduct placebo-controlled trials in this patient population, and many people are not treated or undertreated for their psoriatic disease. Now, the challenge is that when it comes to prevention, you really want the highest level of evidence. Ideally, we have randomized placebo-controlled trials and even meta-analysis of multiple randomized controlled trials. So I'm going to go through the data a little bit here. And part of the challenge here is that the immune system can be pretty unpredictable. Okay, so we know TNF inhibitors are really effective for treating psoriasis and other immune diseases, but they actually can induce psoriasis-like disease in the skin in people, right? So they're anti-inflammatory, but can end up being pro-inflammatory in some situations. Similarly, a lot of our models are not always right. So we know that TNF inhibitors were supposed to help multiple sclerosis. It actually aggravates it, potentially induces it. But we know that IL-17 inhibitors were supposed to improve inflammatory bowel disease, but they actually tend to make it worse or potentially can induce it. And then similarly, tofacitinib potently lowers hsCRP, but we know from large clinical trials in the RA population that it's used to promote thrombosis and all-cause mortality. So clinical trials are really important to sort these things out. So there's two basic approaches how we've looked at this. One is, cardiovascular biomarker studies, and then events-driven studies. And there's either done it by observational work or RCTs. I'm going to focus on the RCTs first in the biomarker arena. And so this is work I was doing with Nehal. I've been doing with Nehal Mehta for the last 10 years or so. And first, we showed over 10 years ago that if you do a PET CT scan, that radiolabeled glucose, we believe, is selectively taken up by CD68 positive macrophages and fatty plaques in the aorta. And we knew from other work that this measure is predictive of future cardiovascular events, and that when you give someone a statin, that signal goes down within 4 to 12 weeks. So it's a really nice model for studying in a short-term clinical trial as a cardiovascular imaging biomarker. We also showed that people with psoriasis have higher aortic vascular inflammation, equivalent to about 10 years of aging. And then the right side of your screen is some work from Nehal's work when he moved to the NHLBI, basically showing as your skin disease severity increases, so too does the amount of aortic vascular inflammation signal we're able to see on these PET CTs. And this is sort of a schema of how our trials are set up. So basically, people get a scan at baseline. We do biomarkers to look at lipid metabolism, glucose metabolism, and markers of inflammation. And then they get randomized to the treatments of choice or placebo. We could give people with psoriasis placebo in our studies, making an interesting model for experimentations. We then do a scan at week 12, which we know should change based on the statin data I just showed you. And then in our usual designs, people go into open label therapy for about a year for one of the treatments. That way, people who are getting placebo get the opportunity to get effective treatment. And this is sort of a summary of what we found in 3 trials that we've conducted. Looking at aortic vascular inflammation, we found that adalimumab, phototherapy, and secukinumab, a blocker of IL-17, none of these changed aortic vascular inflammation compared to placebo over 12 weeks. But ustekinumab, which blocks IL-12 and 23, reduced this signal compared to placebo. When it comes to inflammatory biomarkers, provocatively, only adalimumab and phototherapy improved IL-6, and in this case, CRP, some of the more important markers for cardiovascular risk. We also saw some improvements with ustekinumab, but not in IL-6. For lipid metabolism, provocatively, only phototherapy improved lipid metabolism by increasing HDLP particle size. And then finally, and somewhat vexing, is that despite the fact that in all these trials we dramatically improved people's psoriasis, and none of these treatments that we used did they improve glucose metabolism. This is sort of similar to Paul Ritker's talk. where essentially he showed, I believe, in Cantos that they didn't lower the risk of diabetes over time and people getting IL-6 inhibition. Now, one of the challenges about using surrogate endpoints, surrogate markers, is that they're not always predictive of the endpoints we care about, which is cardiovascular events. This is a nice paper from the cardiology literature showing that if you look at clinical trials of biomarkers or imaging markers, and then follow them up with RCTs of events, the positive predictive value of the RCT of a marker being confirmed by the event trial was only 55%, basically a coin toss. Okay, and so again, it emphasizes the importance for having event-driven trials. Ultimately, when we're thinking about what this means for our patients. Let's now look at the clinical trial. Now let's look at the event-driven data. And we're going to get back to answering our question here. And I'll say that when I ask people which therapy has been proven in a clinical trial to lower cardiovascular events compared to placebo, 14% said adalimumab, 17% said methotrexate, 17% canakinumab, 38% colchicine, 14% secukinumab. And we will show the answer in a second. It was a commonly used medication by derms and rheums. Okay, so we know in observational data, this was shown by Dan Solomon, TNF inhibitors seem to be cardioprotective of cardiovascular events. We know that methotrexate also seems to be cardioprotective in observational studies as well. And this, I'm focusing on data in rheumatology, but it's also been shown in psoriasis as well. But we need to be mindful that there are key limitations of observational data when we look at the benefits of systemic therapy, especially biologics, and especially in the psoriasis population, because in the field of psoriasis, we have a lot of undertreatment of moderate to severe disease. And so there's a strong healthy user effect. And this is data we published recently in the JAD. If you look at people who are going on biologics compared to people who are non-biologic users in a large US system, the biologic users are way healthier. They have less congestive heart failure at baseline, less psychiatric problems, less kidney issues, less lung problems, less prior history of stroke, less prior history of hypertension. Okay, and so this strong healthy user effect may impact how we think about the results in this observational data. So let's now get into the RCTs. All right, so when we look at this in the placebo-controlled psoriasis trials, this is sort of some meta-estimates looking at TNF inhibitors, 17 agents, and then IL-12/23 inhibitors. And basically, all these studies have very wide CIs. None of them have statistical significance for changing cardiovascular events over 12 weeks. Now, this shouldn't surprise us. These patients are relatively young. These are, for cardiovascular endpoints, fairly small trials, and only 12 weeks. Usually, you're looking at months or years of treatment to change cardiovascular events. And so this type of analysis probably is not particularly meaningful at this stage. All right, so now we're getting to the three phases of MACEs, looking at Cantos, CERT, and Colcott. All right, so Cantos is a study of canakinumab, a biologic blocking interleukin-1 beta. CERT was methotrexate, and Colcott was colchicine. And what you'll see is that both colchicine and canakinumab lowered cardiovascular event rates in patients who had underlying cardiovascular disease, that prior MI or coronary disease or recent MI, if you will. There were some interesting other findings, though. So the methotrexate finding was null. There was no benefit on cardiovascular events. And one of the questions is whether or not that trial was able to test a hypothesis, because the average hsCRP at baseline was not particularly elevated. And so one question is, if you repeated CERT by requiring an elevation in CRP where they truly had residual inflammatory risk, might you have then shown a positive effect? So we don't know if methotrexate in our population of people has cardiovascular benefits because they're more inflamed. In the CERT trial, clearly compared to placebo, the patients had higher rates of non-basal cell carcinoma skin cancers, mainly squamous cell carcinoma of the skin. So that's important for us to know about for those of us who use this drug regularly. And they had a higher rate of non-serious infection, but not serious infection. In Cantos, there's a decreased cancer mortality, which is a reminder that we had this sort of idea that anything that modulates the immune system may increase your cardiovascular risk. that's not exactly right. It really depends on which pathway that you're targeting. And in this case, blocking IL-1 beta lowered cancer mortality, particularly through lung cancer. But it unfortunately increased the risk of mortality due to infection. And that makes it problematic, I think, for using as a source of certainly primary prevention. When you're trying to prevent something in people otherwise healthy, you don't want to increase the risk of something else. Similarly, in the Colcott trial, there was a higher risk of serious effects of pneumonia, serious adverse events of pneumonia. And now 2 other papers have since come out in recent months. This is a study now, not in people with recent MIs, but people with underlying coronary artery disease. And again, here you see that it takes about 6 months, but then the curves separate. The colchicine group does better, protecting people from future cardiovascular events. So the answer to the question is a commonly used method would be colchicine, but of course, we're not using canakinumab that commonly. It's a pretty expensive drug for an orphan disease. But the story continues in Circulation. This paper came out also a few months ago, and they found no effect of colchicine on cardiovascular events, and it seemed to be associated with increased mortality in people presenting with acute coronary syndrome. This is a much smaller clinical trial and therefore a little bit harder to interpret, but it's a reminder that we don't still know how to use anti-inflammatory therapies to safely and predictably lower the risk of cardiovascular events in people who are at high risk. And that's where the work needs to focus going forward. All right, so what should we be doing, though? So, our guidelines from the American Academy of Dermatology and National Psoriasis Foundation, we really encourage people, as Paul Ricker sort of talked about in the discussion, that, thinking not just about the skin, but the person's heart is just part of being a good doctor, right? That person's sitting in front of you, they have significant skin inflammation. And in the data I showed you earlier, that means they also have a higher rate of having cardiovascular disease. And we know from the imaging data shown by others, they also have a high rate of having atherosclerotic disease that you could find on imaging. So patients should be screened for traditional cardiovascular risk factors. This screening should probably be earlier and more frequent in those who have moderate to severe psoriasis or more than 10% of their body involved with psoriasis at any point in time. And we encourage earlier use of statins based on adjusting the risk model that you're using to predict 10-year risk by a factor of 1.5. This is what UR recommends for RA, so a similar recommendation. Now, ACC-AHA took a slightly different approach. Instead of multiplying a risk score to see what you should recommend, they just basically said, well, if you have a cardiovascular risk enhancer like psoriasis, RA, or HIV, then you should be thinking about statins and people who have borderline risk. Their 10-year risk is only 5 to less than 7.5% 10-year risk. And you'll see a lot of these other risk factors, risk enhancers, include things like chronic kidney disease and metabolic syndrome, which I showed you earlier, are also much more common in people with psoriasis. So your typical psoriasis patient that you're going to see in your practice is going to have not just psoriasis as a risk enhancer, but metabolic syndrome and possibly kidney disease as something that should be warranting a discussion of moderate intensity statins. Now, the problem we have is that cardiovascular risk factors tend to be underscreened and undermanaged in people with psoriatic disease. So on the left side of your study, on your screen, the study we did in the United Kingdom, where we're looking at people who have psoriasis and hypertension compared to people with just hypertension. And as we go from mild to moderate to severe psoriasis based on their body surface area, they have an increasing odds of having their blood pressure inadequately managed. The exact opposite of what you'd want to see, right? As their skin disease severity is going up, their risk of poor events is increasing as well. And yet we're doing a worse job in controlling traditional cardiovascular risk factors. We know in the US, the rates of screening by dermatologists for diabetes and dyslipidemia is very low. It's less than 5% of our patients with psoriasis were screening for these things. In data in the United Kingdom, they basically identified people with psoriasis, asked them, said, just come in, we're going to check you out. And when they just randomly screened these people who weren't checked out, nearly 40% had more than 10% 10-year cardiovascular risk. That's a substantial amount of risk that's undiagnosed in our populations. 37% of patients have newly identified hypercholesterolemia, and amongst those people who are being treated for hypercholesterolemia, 46% were suboptimally managed. So if we just narrow this sort of evidence to practice gap, we can really do a great deal of benefit for our patients. Let's talk a little bit about statins, because my lab's now focusing on this issue a bit through the National Psoriasis Foundation Psoriasis Prevention Initiative. And, when you look at the literature, there's one nice paper where they did a post hoc analysis of one of the mega statin trials and basically showed that in people with psoriasis in the study, roughly 2% of the population had psoriasis in the study, if you will, that they had the same effect on lipid reduction, and that was statistically significant because they had enough patients there. And it wasn't statistically significant for cardiovascular event reduction, but the point estimate was about what you'd expect. And so it's likely that statins are just as effective as lowering lipids in people with psoriasis and preventing cardiovascular events. The other thing that's intriguing is that statins have pleiotropic effects, that they're anti-inflammatory in a variety of ways and may modulate some pathways involved in psoriasis and other inflammatory diseases. And so this is a meta-analysis that recently came out looking at statins in placebo-controlled trials of people with psoriasis and show on average that those getting statins had an improvement in their psoriasis compared to placebo over a period of 12 weeks or so. Now, the problem is that only about 24% of people with psoriasis who are eligible for a statin for primary prevention are actually taking them. That lags even the general population. So again, they have higher risk, worse uptake of a preventative modality. And then another study led by Lihi Eder, who will be speaking later today, an international study, that they found that under treatment of dyslipidemia was greater in people with psoriasis who had psoriatic arthritis, greater in severe psoriasis than mild psoriasis. So same pattern, okay? Worse risk related to skin disease, worse control of traditional cardiovascular risk factors. So that leads me to sort of this last second slide, I should say, which is that psoriasis is really a model opportunity for prevention. We know it's associated with increased risk for cardiovascular disease, with an increasing evidence to practice gap for management of dyslipidemia and hypertension as psoriasis severity increases. And in data I'm not showing you here, but we'll be presenting at a national meeting pretty soon. And we also showed at the NHLBI meeting last week, 2 weeks ago, I should say, in a series of surveys that we've done of patients and qualitative research we've done with patients and providers and surveys of providers. We know that both people with psoriasis and the specialists who care for them are motivated to deal with their cardiovascular risk problem, and they're interested in having their specialists engage them on these issues. We know that statins are safe, highly effective, widely available, and expensive, and acceptable to patients, but it's underutilized. And where our work is going next is trying a care coordination model to see if we can improve the lifespan and health of individuals living with celiac disease, because we know our specialists are sort of overburdened. It's hard for them to manage cardiovascular risk in their setting. So I'll just end there by saying that when it comes to skin disease like psoriasis, it's important to look behind the skin. I think Francis Peabody summarized it best. He said the secret for caring for the patient, or for the care of the patient, is caring for that patient. And so for me, I pick up people with high LDLs and high cardiovascular risk all the time. I do a hemoglobin to A1C, and many of my patients, on average, they have A1Cs that are in a pre-diabetic range. And these are people we could intervene on early through lifestyle modification or pharmaceutical therapies to improve their overall health and their longevity. So that I will stop there, and I'm looking forward to the next talk.
Thank you so much, Dr. Gelfand. A real lot to unpack there, and I'm really, really excited to do that in the Q&A, which happens just after Dr. Hsu's talk. And now I have the distinct pleasure and honor of introducing Dr. Priscilla Hsu. Dr. Hsu is going to be talking to us about HIV, so non-rheumatologic disease, which I'm really, really excited about. Dr. Hsu is the William Watt Care Professor of Medicine at UCSF. She's a chief of the Division of Cardiology at Zuckerberg San Francisco General and co-director of the Center for Vascular Excellence at UCSF. Her research interest, she's had an amazing series of publications with a strong research interest in the pathogenesis, clinical manifestations, and treatment of cardiovascular disease in patients with HIV. And Dr. Hsu, after your talk, I'm really excited to ask you if all patients with HIV should be on a statin. But anyway, I digress. I'm really excited, and without further ado, Dr. Hsu.
Great. Can everyone hear me okay? Can folks hear me? Is the volume okay? Fantastic. So thank you so much to Nehal and Michael for this kind invitation. I'm so honored to talk today. And I think everyone will realize lots of themes and kind of commonalities among all these disease states. So thank you so much for this kind invitation. These are my disclosures. And I want to go a little bit about the history of cardiovascular disease and HIV. So on the left hand here, we have the first case report of cardiovascular disease and HIV published in 1990. And let's flash forward now 28 years later. This is a meta-analysis showing that people with HIV are twice as likely to develop cardiovascular disease. And this accounts for very significant disability and life issues. And you can see here that it's mostly in underdeveloped countries. So even in the modern era, cardiovascular disease is a significant issue in HIV. So I wanted to have several take-home points from today's talk. We know the HIV population ages and cardiovascular disease continues to increase in prevalence. And aside from traditional risk factors, chronic inflammation and immune activation in the setting of treated HIV is strongly predictive of events. Similar to the other disease states today, HIV is a model for chronic inflammation, can help us understand more about atherosclerosis in the general population and to identify novel therapies. And finally, understanding some of these novel inflammatory therapeutic agents in the setting of HIV could have an impact on HIV cure. With respect to inflammation in HIV, I wanted to also focus on these points. So is inflammation important in HIV? And so we do think that these biomarkers are strongly predictive of clinical events. Is there HIV-specific therapy that can lower inflammation? So we know that this helps, but additional strategies will be needed. In the general population, we know that reducing inflammation has an impact not only cardiovascular disease, but other disease states. I will touch upon some different trials that have looked at ways to reduce inflammation in HIV, and then I'll look at future directions. So I apologize that the animation is so slow. So this is a study looking at aging in the HIV population in the Dutch Athena cohort. You can see here in 2010 that around 28% of individuals are age 50 and over. So let's go flash forward to the year 2030, where over 70% of individuals will be age 50 and older. And in fact, 12% will be age 70 and older. And this study estimates that over 70% of these individuals will have cardiovascular disease. And in fact, this study by Matt Freiberg's group in the veterans aging cohort showed that HIV is associated with a 50% increased risk of acute myocardial infarction. And this increased risk was present even in the setting of well-treated and suppressed HIV, and that the HIV impact was similar to that of very potent traditional risk factors. In fact, Matt's group has done this evaluation of HIV in other cardiovascular states, including heart failure, whether it's HFpEF, HFrEF, or unknown ejection fraction, that the risk of heart failure is higher in HIV. And his group has also done this for other atherosclerotic conditions, including peripheral arterial disease. So with that in mind, lots of studies now have looked at the setting of chronic inflammation in treated HIV. And this was a study that was done now several years ago looking at the impact of antiretroviral therapy guided by CD4. And this was back in the era in which antiretroviral therapy was thought to be unsafe. And so they were looking at a strategy of starting and stopping versus keeping patients on antiretroviral therapy. So we all know the punchline of that study, that keeping patients on ART was good. I think what was novel about this study is it was the first evaluation of inflammatory and coagulation markers in the setting of HIV. And so they did this and found that those biomarkers at study entry were very strongly predictive of mortality as well as cardiovascular events. And since then, there have been many studies looking at the relationship between inflammatory coagulation markers and mortality in the setting of HIV. So on the next slide, I review some of the studies that have looked at inflammatory and coagulation markers and specifically cardiovascular risk. And so now there have been a whole slew of studies relating these biomarkers to cardiovascular disease in the setting of HIV infection. This has now been studied in many different cohorts, and I'm going to try to get this to move a little bit faster. And so it is, I think what's amazing about these studies is across these very different cohorts, some looking at just men, some looking at just women, there's a very strong signal that inflammatory and coagulation markers are strongly predictive of all-cause mortality. And this is really despite the great variability of some of these markers, including IL-6. So this has been a very important finding in the field. With that in mind, this trial looked at pooling some of the biomarker studies, and they showed that IL-6 and D-dimer were strongly predictive of serious non-events as well as mortality, even in the setting of treated HIV infection. And as you can imagine then, they hypothesized that lowering these biomarkers could then translate to a significant reduction in clinical events in the setting of HIV. So because of that, many different groups are now looking at methods to lower these biomarkers. So in order to do that, we have to understand the mechanism of excess risk and inflammation in HIV. What accounts for this risk? And this is one potential scenario, and this includes the multiple factors that come together to cause persistent inflammation. And these include HIV production replication, toxicity from antiretroviral medications, co-infection with CMV, as well as microbial translocation. So I want to focus first on HIV production and replication. So as I alluded to earlier, HIV medication and starting meds earlier lowers inflammation. This is comparing inflammatory and coagulation biomarkers in the setting of HIV to uninfected individuals, and they remain high. So antiretroviral therapy helps, but it does not fully restore levels to that of uninfected individuals. And starting meds early in the course of HIV, which was the START trial, versus waiting and starting later, results in clinical benefit for HIV-infected individuals. It has a small impact on inflammatory and coagulation biomarkers, as shown here, but the actual absolute value of the decrease is very low. So finally, in conclusion, antiretroviral therapy itself and likely starting meds early rather than waiting till HIV disease is advanced is probably beneficial, but it does not have a significant impact on inflammation and coagulation. Let's go on a little bit to toxicity from antiretroviral medication and also traditional risk factors. And so the study that I had mentioned previously was looking more at antiretroviral therapy like protease inhibitors and older agents. And so now we have novel, newer therapies, including integrase inhibitors. So there have been a whole slew of studies to ask whether changing medications to the newer integrase inhibitors that are less likely associated with dyslipidemia or intensifying regimens, what impact does that have on biomarkers? So I've tried to summarize a lot in just one slide, but the take-home point is that they really had very minimal impact on inflammatory markers. And so additional strategies will be needed. So let's go on to co-infection with CMV, which is very common in the setting of HIV. Our group showed that this CMV-specific T-cell responses were strongly related to HIV-associated atherosclerosis. And there have been some interventional trials looking at valganciclovir to reduce CD8 T-cell activation, but had no impact on inflammatory markers. And based on this study, there's another follow-up therapeutic study focused on CMV that is about to start in the setting of HIV. So clearly, some of these pathways of inflammation are specific and unique to HIV, and the work is continuing on this. So what about microbial translocation? So the thought is that HIV preferentially infects CD4 positive T cells of the gut. This leads to leaky gut and downstream inflammation. And so in the setting of HIV, there have been many different studies to target different aspects of the gut, including sevelamer, mesalamine, rifaximin, and probiotics. And again, to summarize a lot of work, all these studies were largely negative. Of course, they all had different limitations, and the work on this is really continuing. So I think lots of individuals have looked at imaging as a means to ascertain pathogenesis and the impact of different interventions. And so similar to the other disease states, our group has used FDG PET-CT as a means to evaluate both the lymphoid, so hematopoietic system, as well as the arterial system, and look at the impact of HIV infection. And so using this, you can see in uninfected individuals on the top, you can see the lymph nodes are very quiescent. And in contrast, the lymph nodes of an HIV-infected individuals just really light up here on the bottom panel. And in fact, our group looked at this and found that lymph node activity was strongly related to HIV disease activity. So all of these patients with HIV had higher lymph node activity versus controls. but you can see the degree of HIV suppression was strongly related to the degree of lymph node activity as well. And in fact, our group is now looking at more specialized means of looking at HIV disease, so specialized assays of the HIV reservoir to show that in the setting of treated and suppressed HIV, that higher levels of HIV replication are strongly associated with carotid plaque, suggesting that therapies that might reduce the size of the HIV reservoir could be a means to reduce cardiovascular risk. And using more novel tracers, so this is a study of ARIG PET imaging to look specifically at T cell activation. These are kind of our next steps in imaging in the field. We will look at tissue measures of the HIV reservoir, so through the gut as well as the lymph node, and correlate these to imaging of T cell activation using ARIG PET. So what about interventions that reduce inflammation in the general population? So should all HIV patients take statins? So Michael, I predicted your question. So we know from Paul's work and others that lower is better not only for LDL, but also inflammation. So individuals who are taking statins who can lower both their LDL cholesterol as well as inflammatory markers do better. In general, interestingly, statins are underutilized in the setting of HIV. This is a study in veterans showing that even individuals who meet the criteria for statin therapy, around 25% of HIV, they are not on statin therapy. And I think in the interest of time, I'm going to skip this slide. And so that comes to mind, should we consider an HIV CVD equivalent similar to psoriasis? And I think Dr. Gelfand already mentioned that HIV is a risk enhancer in the new ACC/AHA guidelines. In the European guidelines, it says that LDL cholesterol control using statins should be considered in patients with HIV. Now, I'm going to look at the schematic on the left. So how are we going to get to this low LDL in the setting of HIV? And similar to the other speakers, should we consider HIV a risk equivalent similar to diabetes? So I'm going to touch on these points later. So we know that beyond statins, there are many new agents out there to lower LDL cholesterol, including PCSK9 inhibitors, as well as inclisiran, which acts on silencing RNA and is injected once every 6 months. So in the setting of HIV, PCSK9 inhibitors have been shown to effectively lower LDL cholesterol. There's no drug-drug interaction, so that, of course, is very attractive. As a follow-up study, our group is also looking at the impact of aggressive LDL lowering using PCSK9 inhibition, the impact on arterial inflammation using FDG PET-CT, as well as non-calcified plaque, and this is with Udo Hoffman, who will be speaking later today. So, however, will statins lower inflammation in HIV infection? What do we know so far? So there have been some small studies looking at this, showing interestingly that statin therapy lowers LDL cholesterol in the setting of HIV, as we predicted they would, but interestingly, they do not seem to have a significant impact on many inflammatory biomarkers. Reprieve, which is a large outcome statin trial, which Dr. Hoffman will probably discuss this afternoon, will be able to look at that in more impact. So we still don't know, however, whether statins will lower the inflammatory pathways of interest in the setting of HIV infection. So I want to move a little bit now to target inflammation. I know people have discussed this diagram already, so looking at the possibility of moving more upstream in the inflammatory pathway to see if that will have a more potent impact on inflammation in HIV. So the AIDS Clinical Trials Group did a study looking at the safety of low-dose methotrexate among individuals with treated and suppressed HIV infection and the impact on inflammatory markers. So this study showed no change at all in inflammatory markers in the setting of HIV using low-dose methotrexate. There was a reduction in CD4 T cell count, which is bad in the setting of HIV. However, there was also a significant reduction in CD8 T cell count, which is beneficial in the setting of HIV infection. So this was an interesting study. One of the first large immunosuppressive studies in the setting of HIV. There was a signal towards more pneumonias in the setting of HIV. No impact of low-dose methotrexate at all on vascular or inflammatory markers. However, a significant reduction in CD8 T cell activation, which was interesting. I want to now move on to a different target, so IL-1 beta. So we know, interestingly, in animal models, SIV stimulates the production of IL-1 beta from the gut mucosa, leading to a breakdown in mucosal integrity, downstream inflammation. And also through some indirect pathways, CD4 T cells are lost during HIV, and there's a reduction of a caspase-1 dependent pyroptosis, which involves IL-1 beta, and this then leads to a chronic cycle of CD4 T cell death and inflammation. So there's some possible pathogenetic role of IL-1 beta in the setting of HIV. So our group did a very small pilot study to look at the impact and safety of IL-1 beta in the setting of older HIV-infected individuals who had well-treated disease. So here, you can see here our patients were older, in 59, almost all men. They had one traditional risk factor, known cardiovascular disease. Most of them were on statin. Their HIV disease was very well controlled for safety reasons, as you can see here. So canakinumab had no significant impact on CD4 T cells or HIV RNA at any time point, so that's a good thing. Canakinumab significantly reduced CRP by 41%, a single dose in the setting of HIV, as well as IL-6. This is really one of the only agents that have been shown to reduce IL-6 in the setting of HIV. Interestingly, canakinumab had no impact on T cell activation in the setting of HIV infection or CD8 T cells as well. With respect to imaging, the diagram on the top shows before canakinumab with respect to both arterial inflammation and bone marrow activity. And indeed, there was a significant reduction in arterial and bone marrow activity after a single dose of canakinumab in HIV. So I think to conclude from that study, we have a larger placebo-controlled study that we're just about to finish out that treated patients for longer. And so we're really interested to see what will happen in the larger study as well to follow upon that finding. Individuals I've mentioned in the setting outside of HIV, some of the studies of colchicine and myocardial infarction, as well as chronic coronary artery disease. There has been a small study looking at colchicine and HIV, showing no impact at all on inflammatory markers, no impact on endothelial function. And this is from Robert Weiss's group at Hopkins. So, sorry, that slide was a little bit out of order, but in our pilot study of canakinumab, we found a reduction in inflammatory markers, no impact on T cell activation, and a reduction in arterial inflammation and bone marrow activity. We conclude then that canakinumab could be acting directly on the bone marrow, could be acting on the monocytes, and it could be acting directly on the arterial vasculature. So from our studies looking at methotrexate and also canakinumab in HIV, we have been able to make some conclusions. So we know from Peter Libby's work that both innate immunity as well as adaptive immunity play a role in atherosclerosis. From our small studies in HIV, we know that IL-1 beta inhibition probably impacts innate immunity, while methotrexate may have an impact on adaptive immunity. And in general, the HIV population is incredibly well engaged, loves studies, and these are things that we learned from our studies in HIV that were not previously understood in the general population. So I want to turn back now a little bit to HIV itself. So we know that HIV causes immune activation, T cell activation. This leads to tissue damage and fibrosis, which then circles around to poor HIV disease control. And this then leads to a vicious cycle. So there's two different issues here. Inflammation itself could cause viral persistence, and this could be through more virus production, upregulation of negative regulators. And so if that's the case, having an intervention that lowers inflammation may accelerate cure of HIV disease. Now, if the opposite are true, and that is uncontrolled HIV and HIV persistent causes inflammation, then strategies that cure HIV will lower inflammation and the disease that's associated with inflammation as well. So with this in mind, in partnering with Rafiq Sekali, we are looking at different markers of the reservoir. And so Rafiq's group has looked at a tilde assay, which is a very sensitive assay of the reservoir, and has shown that the inducible reservoir in HIV is strongly related to levels of IL-1 beta. And this is in the setting of high inflammation. So you can imagine that we are looking at the impact of canakinumab on the HIV reservoir at this time as well. So I want to try to finish up by looking at what is the best way to intervene in the setting of treated HIV. And I think you could actually replace this model with any of the different inflammatory models we've been discussing this morning. So we have the roots of the tree here, which is HIV. It could be reservoirs from HIV, co-infection with CMV. We have our trunk in the center, which could be monocyte macrophage activation. Our branches then may be inflammation, coagulation, different adaptive immunity, B cell activation, and the leaves could be end organ disease. So we see the model here, but I want to see in reality, is this model much more complicated than we suspect? And so I think we also want to realize that when we intervene on just one pathway, that these pathways are likely much more complex and bidirectional than we may expect. So from our study of canakinumab, we saw that there was a reduction in inflammation. And when we measured it, there was no impact on immune activation. But realizing that in reality, there could be an impact on the HIV roots of the tree, and that is maybe we reduce viral activity at the roots of the tree, we increase T cell activation, and in contrast, at the top, at the branches, we reduce inflammation and we decrease immune activation. So when we measure these things at just one time point, the sum effect could be no impact on immune activation, but just realize that in reality, it's likely much more complex and bidirectional. So finally, there are many different overlapping pathways in HIV in the setting of atherosclerosis. We know of coronary arteries in general, that we have the endothelium, monocytes, and macrophages coming together to form an occlusive thrombosis. Similarly, many similar pathways to underlie atherosclerosis in the setting of HIV infection. Finally, just looking towards the future, I think all these studies will help us understand more about the role of immunology in cardiac disease, so cardioimmunology. So finally, I've touched upon many different things in this time. So the pathophysiology and management of HIV-associated cardiovascular disease, some things specific to antiretroviral therapy, the role of co-infection with CMV, targeting traditional cardiovascular risk factors, targeting inflammation, using things that we use in the general population like beta blockers, ACE inhibitors, statins, for example. So in conclusion, cardiovascular disease is significantly elevated in the setting of HIV, and this impact on health will only continue to grow. This biology of chronic inflammation, however, is very complicated. I highlighted two differential anti-inflammatory strategies in the setting of HIV, low-dose methotrexate, IL-1 beta inhibition using canakinumab. We hope that some of these scientific questions that we study in HIV can help us inform our understanding of cardiovascular disease in the general population. And then for my HIV colleagues, understanding some of these mechanisms of cardiovascular disease in HIV can have an impact on cure. I know I've also left you with many unanswered questions, and that is, should we treat HIV a risk equivalent like diabetes? Will targeting these traditional risk factors is sufficient enough to reduce the risk in HIV? What is the best treatment to lower inflammation in the setting of HIV infection? Will this be specific an HIV therapy approach, or will it be more general? And will this have safety issues? And then many different things are needed to move the field forward. Just want to end for more clinical questions. We do have a recent scientific statement in the setting of HIV that was published in 2019. And I realized I forgot to put in a summary slide, so really want to thank all of my collaborators, my team, and folks across the United States, and also the patients that are participating in this research. Thank you so much.
Thank you so much, Dr. Hsu. That was really wonderful. And I'm also struck by how on time we are, which is really, really exciting. So we have 25 minutes for Q&A with our four discussants, Dr. Hsu, Dr. Kaplan, Dr. Gelfand, and Dr. Solomon. Please ask questions via the app or via the on-screen messaging system. I'll try to filter them and then send them to the discussants. We do have some ones left over from last time, and I think there are some interesting things that came up. One thing that really struck me actually is that, and this was unintended, in the first session we had actually all cardiologists, and now in the second session we actually have more of a mixture between dermatologists, rheumatologists, and cardiologists. So I want to unpack the colchicine comments a little bit more, because now we're dealing less with non-specific inflammation and we're dealing with inflammation from autoimmunity or from a specific disease state. So I want to ask whoever how they feel about colchicine. I guess we'll think for secondary prevention in the setting of these patients that are on other active immunosuppressants, on biologics, but also have very high cardiovascular risk.
I'm happy to jump in. It's an easy decision in someone with gout who may need prophylactic colchicine or chronic treatment because lowering the uric acid is not enough. I think it becomes a much more difficult question in patients who are on chronic immunosuppressives for RA or psoriatic arthritis or lupus. Those patients already have immunosuppressives on board. Not that colchicine raises the risk of infection much, but there's always been this lingering issue with increasing mortality in the colchicine arms of most of the colchicine cardiovascular trials. So I think as a conservative, interventionalist, I'd be loath to give colchicine unless I had good data that it was safe and effective in patients on multiple immunosuppressives.
And I think that sort of was the point of that I was trying to make in that data presentation there, which is that even in a situation where you have a cheap pill that's been shown in 2 trials to prevent cardiovascular events in people at high risk underlying cardiovascular disease. Another trial showed it didn't work so well and maybe increased all-cause mortality. Then, Dan brings up the other issues that drug is associated with a higher risk of certain infections and some other side effects, what have you. And so this is a reminder that the field has a little ways to go to put into practice sort of use of therapies to target inflammatory risk as a way of lowering people's cardiovascular disease.
I'd be curious from my cardiovascular colleagues just out there. So, despite these really impressive clinical outcome studies on cardiovascular disease, I'm curious, like in real life, who is using colchicine for the cardiovascular indication at this time? And I just, in my practice, we really haven't adopted it, but I'm just curious if others are, like Paul.
So first of all, Priscilla, thank you for joining us today. Great to see you. Great to see Joel. Great to see Mariana. It's been really wonderful to listen to this whole thing. And I get to see Dan all the time. So that's an easy one. I actually have to say, Priscilla, that, I am using it in what I call my frequent flyers. People who are, on aggressive statins already, whose LDLs are already low, but who keep coming back and get more angioplasties and more readmissions. And I'm encouraging lots of my colleagues to do so. I mean, the question asked here is whether you'd use it on top of another immunotherapy. That's a much more complicated issue. But for run-of-the-mill stable atherosclerosis patients, I'm cynical enough to believe that one of the reasons we're not talking about it anywhere near as much, given the data, is that frankly, there's no profit margin here. If these were corporate-run trials, can you imagine what you'd have? You got 35% reductions in risk, twice a PCSK9 inhibitor. But that's a bigger medical issue than we're going to cover today.
I think this gives a great idea for our next session of great debates. That would be a lot of fun, but maybe we'll stick away from the autoinflammatory population and just go with the elevated CRPs. But, that brings us to a next question that's come up a few times about the concept of CRP and elevated risk specific to these autoinflammatory populations. And Dr. Kaplan, I'm really interested in some of your comments that the CRP isn't necessarily elevated. I'm wondering if you could unpack that a little bit more and also talk about biomarkers you do use that are clinically available.
Yeah, so, my observation was, in a way, compared to the other diseases, kind of unique to SLE, right? But in our hands, CRP does not correlate with markers of vascular risk in lupus. And as I was mentioning, we think part of this is because lupus patients tend not to mount a high CRP response because of the type 1 interferon signature. Now, they do it when they're infected, and that's, to us, is a good indicator that we need to look for infection, but it doesn't appear to be a good biomarker for vascular risk in lupus. And similarly, the LDL story does not appear, this is kind of unique as well. It's not, we see much better correlation with impaired HDL function or low HDL than we do with low LDL in the case of lupus. Again, I think the immune dysregulation that is somewhat unique to lupus is probably driving these differences that we see with other groups at risk.
And what biomarkers do you use, or do you hang your hat on? Any that are clinically available?
I mean, because ours is more of a discovery cohort, and we are looking at, progression, and we are having a broad approach. We are using the ones that people typically describe as correlating well in other disease groups, but we're also incorporating some of the ones we think may be relevant to disease pathogenesis, interferon signature, neutrophil subtypes, and neutrophil LGG gene signature, nets. But it's more of a discovery, and whether it will end up being a good biomarker for cardiovascular risk remains to be seen. We're now doing longitudinal assessments to try to better understand the correlations.
Great, thanks. And I think Dr. Mehta has a question on different types of inflammation. I think while he's getting queued up into the program, I'll ask something from the audience. So there's a question: how do you explain different effects of methotrexate on varying risk of different diseases? It's up to anybody in the audience that want to take it.
Well, I'll start off. I think what I was trying to show in my slides is that there's limits to how far observational data can take you, and there's inherent challenges in understanding therapeutic effects and observational data as well. And that's why RCTs are necessary, especially for events. I think that, and then the challenge, of course, is that in any clinical trial, there's often subpopulations where the drug will really work, and in overall population, it might not work, right? So we don't know if people have, have psoriasis, if they got randomized to methotrexate versus placebo or not, since they're inflamed, and you would lower that nice inflammation, that would end up resulting in better cardiovascular outcomes. I think it would have been interesting in a CERT trial if there was a population of people who had very high CRPs. There's enough power there. It'd be interesting to know if methotrexate could lower CRP in that group and also lower cardiovascular events in that group. I guess maybe Paul would know the answer to that, or others would.
Regrettably, it didn't, Joel. There really was no subgroup. And, you just get regression to the mean at the higher CRPs. I would also come back to the question Michael asked Mariana a second ago, just to remind your listeners that I actually find the fact that CRP doesn't work in lupus to be reassuring from where I sit, because from a histopathologic perspective, the pathologist will tell you the lupus patients don't get atherosclerosis. They're getting a vasculitis. It appears to a cardiologist in practice like it's an oxygen mismatch, so it looks like the same thing to us clinically. But it's a very different disease. So the fact that it's not predictive there in some ways to me is almost reassuring.
I mean, in fact, I may disagree with that. I do think lupus patients get athero, whether their athero looks the same quality of plaque and what's the inflammatory infiltrate that predominates compared to garden variety athero is different. But I do think we clearly see, from autopsy studies and from, imaging, that what you get is plaque. It's not just pure, vasculitis and no plaque deposition. And, maybe Nehal, you want to comment because we've done this.
Yeah, so Mariana, I think it's great that you chimed in, because you and I have been having these discussions about comparative biology between lupus, psoriasis, and we're lucky here to have both Dan and Priscilla bringing in this edge of rheumatoid arthritis and HIV. I wondered if the group could speculate a bit about types of inflammation. And I think Paul was alluding to this, that he's pleased to see that there's not this increase in hsCRP and lupus because of the biopsy results and whatnot. And I've been thinking 50 years ago, Friedrichsen typed hyperlipidemia using lipospots, right, at the NHLBI. And we had 4 types. We had types 1 through 4. And he said that dyslipidemia itself is just a general term, dyslipidemia, right? but in reality, it's actually types of hyperlipidemia. I wonder if this group, and maybe we start with Priscilla in HIV, maybe move to Dan in RA, and then Joel can talk about psoriasis with Michael, and then Paul maybe in CAD and Mariana in lupus, but the types of inflammation matter. Whereas Mariana brought up interferon-related inflammation, type 1, I always bring up this LDG myeloid neutrophil inflammation, which is rich in acute psoriatic plaques. Is there a time where we have hit, or are there studies that are ongoing? I know that Kennedy and Oxford has something similar. CHI started at Mariana, but unfortunately we weren't able to finish it. Types of inflammation. Can we talk about maybe this is an IL-6 type of inflammation? This is an IL-1, IL-6. This is a innate immune TNF-alpha. Are we not able to do that? But maybe we can start with the panel as a discussion. Not all inflammation is created equal. And not all inflammation is inflammation, or is it? And I will stop the question there and let you guys start chiming.
I mean, I'm happy to start. I think Mariana said it earlier that lupus is a syndrome with many subtypes. And I think the same goes for rheumatoid. This is why we don't see that one treatment works well in everyone. We know that there's different mechanisms of action are more important at different time points during people's disease. And whereas an IL-6 blocker works great in some, a TNF in others, and IL-1 blockers actually worked in some subtype of rheumatoids, not most. So again, it's such a heterogeneous disease that to say that there's one type of inflammation associated with RA would be to misspeak. I think it's IL-1, IL-6, TNF. It's definitely, macrophage driven at some point, but then it turns into a T and B cell disease. So it's anyone's guess in a given patient, and to understand what are the treatments that might hit upon the rheumatoid disease as well as the associated cardiovascular inflammatory athero disease. I think that's what we're trying to parse out, especially looking at target. Are there different subpopulations? I think it's going to go along with disease activity. So when you impact disease activity, this tells us that a certain branch of inflammation, a certain pathway is more active, and therefore it's going to be effective both for the RA disease activity and likely for the vascular inflammation. But that's kind of a vague answer to a difficult question.
Yeah, I mean, I think observationally, we've tried to get this question by doing simultaneous studies of RA, PSA, and psoriasis. And there's clearly this, interesting differences in metabolic outcomes. That the people with psoriatic disease are more prone to diabetic outcomes than people with RA. And simultaneous analysis, kind of something unique going on about that type of disease. Similarly, recently published an article using Danish data. Alexander Egerberg was kind enough to let us collaborate with him, where we can follow patients getting methotrexate who had either psoriasis, psoriatic arthritis, or rheumatoid arthritis for their primary indication. And in a similar pattern, those with pure skin disease had the worst liver outcomes, highest rates of cirrhosis and hospitalizations thereof, followed by the PSA patients, and then followed by the RA patients as our reference, who did the best from the liver point of view. And so perhaps there's something about the sort of psoriatic disease that causes issues in the liver that has a divergent pathway towards other metabolic issues. I was interested in Paul's point, and Paul, please correct me if I misheard you. I thought you mentioned that in Cantos, when you looked at diabetes outcomes, that there wasn't a benefit on diabetes. And if I understood that correct, it's very similar to work that Nehal and I have done, where we could show a lot of changes in inflammatory biomarkers in our trials. To some extent, we could show some changes in some of the lipid pathways, but we showed nothing in insulin metabolism, glucose metabolism at all, despite the ability to clear psoriasis with either ultraviolet light, a TNF inhibitor, a 17 inhibitor, or an IL-12/23 inhibitor. And so we're trying to sort out, how do we hit that needle also?
Yeah, I guess I could add, Nehal, that if you just look at this from a pure large-scale clinical trials perspective, sort of the test of what actually we all think is true, we've gone over the neutral data for methotrexate, and I tried to make the argument that it actually was informatively neutral because it didn't do what we thought it was going to do. and didn't affect the pathway we thought might matter. But I would point out that, think about verlasperdib. That was an SPLA2 inhibitor that had a 10,000 patient outcome trial that did not work. Daraplidib, an LPPLA2 inhibitor. So it's not like there weren't other large-scale trials that also didn't work. There's P-selectin trials that have failed. And, Dan Solomon's one of the world's experts about, what happens when you give a COX-1 or a COX-2 in terms of atherosclerotic risk, right? It's not going the right way. So I think I think the answer is obviously yes. Inflammation is a bucket term that for my colleagues is relatively recent to their way of thinking. But yes, I imagine that we will, in short order, have inflammation subtype A through L, or maybe even A through Z, as we figure out all these various nuances. Because as the rheumatologists on this call have, informed us, they're not very good at predicting which drugs work for which of their patients. It's just that they've, through trial and error, figured out, hey, this works really well for this works better for that. And that, until someone gets a better fundamental understanding of biology, I think that's the way this is going to progress. And so I will tell you, I mean, as I said before, we're going to do this 7,000 patient IL-6 trial, but there's real equipoise there. I mean, I can give you 100 reasons why it should work, but if I'm in a different mood, I'd probably give you 40 why it won't. So, that's why it's not easy, but it's how we make progress.
These are all really great points on inflammation. I want to switch gears a little bit and go back to cardiovascular risk and risk stratification and kind of falling back on our traditional medications. And I think some interesting points were brought up in the last session, and some blanket statements were made that all patients of X should be on a statin. But then here we had people talking about risk scores in psoriasis and RA, even risk in lupus. But in my mind, a risk score is only good if you're going to do something about it, or, you got to have a cutoff at some point. So I guess maybe I'll actually go back to Dr. Chu for a second. There is a HIV risk score, the DAD. I just want to know how you think about risk stratification in these HIV patients on an individual patient level, and specifically in the young patients as well.
Yeah, well, so I'm glad you asked that. We didn't have time to address it in my talk. So the traditional risk calculators perform very poorly in HIV, particularly at the intermediate and higher risk patients, when it can underestimate risk by as much as 50%. There is the HIV specific risk calculator, DAD, that takes into account inflammatory markers, antiretroviral therapy, T cell count, so on and so forth. Really hasn't taken off because it hasn't been replicated. So I would say I don't feel that many folks outside of Europe use that risk calculator. So for me, it's just really hard. It's very individualized on the patient. I don't use any inflammatory biomarker because it really doesn't help me at all. The CRPs are almost always like in the low 2s. And then IL-6 that we've been talking about today, even though it's a great population marker, it's terrible on an individual level basis. So this is a terrible answer to your question, but I really tailor it to each patient. I think there's just no great calculator that captures all of this in HIV.
Dr. Solomon, what about you, especially in the younger RA patients?
It's a good question, and I think it's I think you have to go back to the Framingham risk score, which I think was a really important way of identifying patients at high risk, where we had we have the variables in the Framingham are things that are all modifiable, or most of them. Some of them are modifiable: diabetes, hypertension, hyperlipidemia. And so the risk score points us in a direction towards intervention in a high risk group of patients. And while we'd like to think that a CV risk score or a risk calculator in RA or in other autoimmune diseases might do the same, it probably won't. It'll identify the subpopulation, perhaps where we might enroll them in certain intervention studies. What exactly those interventions are going to be? Are they going to be the next biologic DMARD, or are they going to be some other cardiovascular aimed therapeutic? I'm not sure. But I think that identifying the subgroup of patients, the young person who's at high risk because of their collection of risk factors plus inflammation, et cetera, helps us to become a little smarter and evidence-based in how we collect patients for cohorts, collect patients for trials, and think about treatments. So I think it's a very valid question, Michael. I don't know if I have a perfect answer to it, but I think it's a starting point for a lot of what we do in therapeutics.
Like Michael, several of us run Centers for Cardiovascular Disease Prevention at our various institutions, and I'm smiling with the discussion from Priscilla and Dan that risk scores don't work terribly well in people with, say, HIV or RA. I think we should start by admitting that risk scores don't work terribly well in people with coronary disease either. We got in quite a bit of trouble a few years ago by deigning to, suggest that the ACC-AHA risk score was wrong an awful lot of the time. And people who are aware of this debate know that there's been 35 or 40 studies since that corroborated that we were actually correct and that the score has never been fixed. And you have to ask questions about why hasn't the score been fixed and why is it so difficult for the public health community to do something as simple as recalibrate. But I think there's many issues involved there. Dan pointed out that most things in Framingham are modifiable. Well, actually, HDL cholesterol, we spent 30 years trying to modify it only to be very, very frustrated. And yet we leave it in the score because it's a good predictor. Triglycerides, we still don't have any notion of whether it really up or down. And we, among others, have various triglyceride lowering trials ongoing. But I think you have to actually be very careful here, Michael, to distinguish between what's the goal of risk prediction. If you just want to predict risk, get a CAC. If you really just want to predict risk, go ahead and look for the disease, get a calcium score. But I have to admit, I almost never order them because I'm already convinced you're not going to get out of my clinic not getting a lecture about a statin anyway. And the reason I say that is in Jupiter, and just think about this for a second, Jupiter was designed in 2001, and we gave a high-intensity statin in 2001 to people whose LDLs were already at 100, and we got a 44% reduction in risk. And our guidelines 20 years later are still talking about low doses and middle doses and high doses, and I have no idea why. So I think guidelines are a real problem because of the consensus nature required, but it's not the way anyone practices medicine as far as I can tell. I don't know that many people who calculate an ACC risk score to decide who to actually treat. And sometimes I think it's a good thing maybe they don't. And that's what's so complicated about this whole issue. Now, at a biologic level, think about some simple things. Family history is still not in the ACC-AHA risk score, but clearly matters. And you don't have to do a genome-wide scan. The simple question, mom and dad have premature atherosclerosis before age 60 or not, greatly alters the score. But that hasn't been incorporated either. So it's all about what are we trying to accomplish and where's that interface between the biology that so many of you are doing in a very cutting edge way and what we tell our clinical colleagues to do.
So, yeah, thank you, Dr. I'll actually remind you, age is not a modifiable risk factor. That's why I'm always so interested in the age component, because as you say, we really are, the risk estimates become very often these inflammatory populations, and it's especially challenging when you're talking to the young patients about what to do. This has been wonderful. Thank you. I think we have time for one more question, and this was asked by the audience. So it's in patients treated with IL-6 inhibitors or JAK inhibitors, do they need to be monitored for lipid elevation? And are these lipid elevations pathogenic in our patients with RA or psoriatic arthritis? So I thought that'd be a great way to transition and end with the group, so whoever wants to take it.
I mean, I would like to say that in the short duration study we did in lupus, yes, we were concerned about that, but in fact, the HDL went up, but also cholesterol efflux capacity improved. And we did not see, in the case of lupus, any negative modulation of other lipoproteins. So for us, it was reassuring. Yes, it's short term, but that the use of tofacitinib did not negatively alter lipid profiles.
Yeah, but it's so saying that now we have oral surveillance, which tells us that, Xeljanz is associated with an increased risk of MACE and as well as cancer. So you need to monitor. You need to advise. I mean, in clinical, the biology is one piece of it, but then it's the reality of a transparent clinical practice. And the LDLs go up in 20% of patients on an IL-6 blocker to the point where they need to go on a statin. I follow it and I put people on statins. However, I'm a co-author on a paper that says it didn't increase cardiovascular risk. But I think we have to do that because it's just kind of the transparent nature of how we should practice medicine and advise patients. And now with Xeljanz, as well as other JAK inhibitors, we're spending a lot of time talking to patients about the possibility of cardiovascular risk, especially in the older population, based on the oral surveillance data. So, there's the biology, but then there's the reality of what we see in clinical trials and how we have to be transparent about that.
This is a really wonderful. Thank you. I think this is also a great plug for a session at our 4, which is when Dr. Mehta or Nehal and I talk about the approach to cardiovascular risk stratification and really kind of sort of, I think, emphasizing what you guys all emphasized here today, which is really, really nice. We do have a break now, 12:45 until 1:30. And then 1:30, we have a pseudo lunchtime talk actually talking about barriers to implementing dietary and lifestyle changes. And then please stick around for that. And also please stick around for section 3, where we get a little bit more mechanistic before we go back into clinical to end the day. So thank you guys all very much. Thank you for our speakers today. It's wonderfully appreciated. And again, it's been great so far. So thanks.
Thank you.
See you at 1:30. Thank you.
Welcome back. Thank you all so much for sticking around and for coming back. We're really excited to have you here. We have our lunchtime talk, and I'm really excited to introduce Monica Ricky. She's a rheumatology nurse practitioner at Northwell Health. She has a special focus on lupus and lupus-related diseases. In fact, she used to run the cardiovascular prevention program for SLE patients at HSS. So I think this is such a great person to have speaking about barriers to implementing dietary and lifestyle and changes in these pro-inflammatory conditions. I'm very interested in what she has to say. So thank you very much, Monica. And with that, I'll hand the mic over to you.
Thank you so much for having me. Really happy to be able to talk about this. It's something I'm very passionate about it. So before we talked about counseling, we actually have to stop for a minute. And these are some of the lessons I learned when I run the cardiovascular program, is what are we asking actually the patient to do? We're asking them to change one behavior, but they actually have to learn a different one. So they have to stop something that they're eating and learn to eat something else, which is difficult. They also have to learn different behaviors, such as exercise and smoking cessation. They have to change their routine around what we're asking them to do, the number of meals a day, right? Some people only eat twice a day. We're asking them to eat 3 times. If they work the night shift, and I'm asking them to eat during the day, but they're sleeping. So it's very complicated. I'm asking to learn how to cook. I am not a cook at all. I don't know how to cook. So if I want somebody to have a healthy diet, they need to learn how to cook. Portion size is another one. Have to change the social habits, right? If I'm somebody who goes every Thursday or Friday for a burger, and then I cannot eat that burger and French fries anymore, I have to change, and it's going to affect my social life as well. Shopping habits, you know what to buy, and then you got to the supermarket, and now I need to learn everything else. So basically what we're asking is not just to change exercise and their diet, but I have to ask you to change your whole entire life around those 2 little changes. Also, when it comes to determinants of food, it's highly complicated to make somebody change their diet, right? It's not just about, here's what you have to eat. Is, can you afford what I'm asking you to eat? Do you know how to cook what I'm asking you to eat? So there's a lot more. It's a very intricate, it's associated with the culture, and we talk more about this in language and family. It's a very complicated thing to ask a patient. This is a basic of a healthy diet. So lots of fruits and vegetables, whole grain, high fiber, fish at least twice a week is the, what we usually tell them. Less alcohol, limits out intake, saturated fats go out, which means everything that is really tasty goes out. So not really an easy simple thing to do. Then we talk about, you have to exercise 30 minutes every day or 60 minutes every day. I'm a person who works 6 days a week. I don't have time to exercise, and then I'm asking my patients to do what I am not able to accomplish. Before I go into more of the patient barriers, I want to talk about provider barriers because, right, we are the ones in a way giving the education. So time constraints, When I was in the cardiovascular, I had a lot of time to spend with my patients. Now I don't. So time is really something that, stops us from trying to teach about cardiovascular health. Communication styles, some patients are slower, some patients get it very quickly. And then I'm just going to leave this as food for thought, but it's our own conscious bias. That's a whole different talk. Then where's my resources? Where am I going to send this patient, right? Referrals. If I'm in a rural area, where am I going to find a nutritionist? It's hard enough to find a nutritionist here in New York City. I cannot imagine what it is to find a nutritionist in, Idaho or South Dakota. And then is my knowledge also, right? How much do I know about nutrition? I'm not a nutritionist, so I only know the basics. It's no surprise that the barriers to a better health and nutrition is actually the social determinants of health. So we talk about socioeconomic position, race, ethnicity, social support, culture and language, access to care, right? If you're sick, but you don't even have access to care, how are you going to learn how to eat? And also your residential environment. And we're going to talk more about it in a minute when we talk about food deserts and food swamps. So those are really, truly the barriers to change patients' behavior. When we talk about socioeconomic positions, which is part of the social determinants, we're talking about material conditions, money, right? Health, education, access to work, right? Are you working? Are you unemployed? Your political voice that also actually matters, your social connections and your environment. And then, physical insecurity. Do you have a home? Are you homeless? For cardiovascular specifically, there's three that are the most important, which is the educational level of the patient, the income, and occupation or lack thereof. I have a lot of patients with lupus that don't work. So if I'm going to change their diet, I have to take that into consideration that they may not have the money. Interesting enough, the lower the SAP, the greater the prevalence of cardiovascular risk factors and also a higher incidence of mortality. There are modifiable barriers and non-modifiable barriers. In non-modifiable, race, age, gender, musculoskeletal disease, right? Although they can mix and match, but if you have psoriatic arthritis, that's something I cannot change and I have to work with that and your limitations, depending how severe your disease is. The older the patient, the harder it is for them to change their diet. Some ethnicities are really linked to their diet. Asians, African Americans, they have this specific things in their diets that are hard. I'm Latin, I'm from Brazil, and it's very hard for me to get out of my rice and beans. So I know how difficult that is. The financial is also something that I cannot change. Food insecurity, do they have access to food and what food? I do volunteer work in the Indian reservation in South Dakota, and the food there is really limited. The amount of food that they can have there, and they don't have the money sometimes, so all they have is canned food. Do they have children? Because if I'm changing their diet, I'm going to have to change the children's diet. Language, barriers of the culture, as I said, and definitely the educational level. And then there's modifiables. Food preferences. It's hard, but it can be done, right? We talked about the cooking skills. I have none. Motivation. If the patient is not motivated, if he doesn't see a reason to change, if he really doesn't want to change, you're not going to change that patient. And I work with a lot of patients like that. They think that if they drink, 2 liters of Coke a day, hey, I'm having fluid in, and that's the way it is. And they have no motivation to change. Food desert and food swamps are two interesting concepts. Where food desert it means there's no way, like my Indian reservation, where you're going to find fresh fruits and vegetables. Basically, you have canned foods, you have preserved foods. So those are food deserts. And then there's the opposite, which is food swamps, but it's actually fast food, right? So if I go up in Harlem here, there is like a McDonald's on each corner, there's a Popeyes, there's all of those fast foods. And then there's bodegas, but you don't see a big market where they can get fresh food and vegetables. Depression is something that also affects behaviors in terms of diet and exercise. And, with treatment, we can change that. Transportation, sometimes it was hard to get the patients to come in for their teaching because it wasn't like a set doctor's appointment. So they wouldn't get transportation to come in. And then the family traditions, right? If they sit every weekend and have pasta in a big Italian family, I'm not going to take the pasta away from that patient. And again, the nutritional environment is really, it's, whatever you grow up with. I grew up eating rice and beans and meat and salad, and that was healthy, but not everybody has that same background. But what I learned from 3 years doing the cardiovascular program is that the biggest change is the change. The biggest is changing that patient's behavior, right? It's a slow process. In 3 years, at every, in reminding and pulling into this, giving you options. The cost, it's expensive. Fresh food is expensive in New York and it's expensive in a lot of places. Motivation, again. Support. If they have somebody who's going to do it with them, if they have, a partner that is going to do it, they're going to do it quicker than if they're just doing it by themselves. Constant reinforcement. It's important to change because otherwise it's never going to happen. You have to relearn or learn a very new habit for you. And most of all is education. So education is really what counts in the end. So where do the patients get their education, right? So they don't come to the doctor's office. They don't read books about nutrition. They go to the internet, and right now it's Facebook, Instagram, and TikTok. And I have a lot of patients come, hey, I read this on, Facebook about this, dietary something or other, and I'm taking it, and I'm like, whoa, back off, right? So, so usually we need to also assess where they are coming from. Their neighbors give a lot of educations as well. Television, Oprah, Dr. Oz, in magazines, and not always the right magazines. There is a lot of bad information there, and it's up to us to know where they're getting it and actually to ask them, where are you getting your information? And, where did you find this information? All right, in terms of changing behaviors, which is the biggest challenge, there's several different frameworks, and I'm almost done. I had 20 minutes, I think I'm using most of it, and I want to leave a lot for discussion. So there's definitely different frameworks for changing behaviors. The one that I worked the most when I was doing is really the stages of changing and getting people to move around the stages of changing from pre-contemplation to contemplation to preparation, action, and maintenance. It's difficult for you to move one patient from one end to the other. You have to talk, hey, you have lupus or you have PCA, psoriatic arthritis. We need to do these changes, and you have to sit with them and know what they're eating. And it's really time consuming. And for the patients to change it, you have to give them solutions. So it's difficult. So each step takes months for you to be able to move a patient from 1 month to the other. So when I started, and I'm got to finish, when I started this program back in 2009, I did a self-assessment because I wanted to prove to my patients that it was easy. I ate no fish. I did not exercise. I ate no whole grain. I had 2 complete meals a day, drink a lot of iced tea at the time, ate fast food twice a week, drink whole milk. I love salt, and fruits and vegetables right in my refrigerator. Come fast forward to 12 years later. I still eat no fish. I still don't exercise. I still love salt. I have been able to change a few things, but they're really few compared to the whole picture there. And that's basically just to illustrate how difficult it is, right? So to change everything is not just to change diet and exercise. You have to change your whole entire life around it. And with that, I open to comments, questions, whatever comes out.
Thank you, Monica, very, very much for the talk. Let me just get back on screen here. So we actually have a few minutes. So I guess people can ask Q&As in the chat, but I'll ask you a question since you have such extensive experience in dietary counseling in this really very challenging population. Do you have a specific diet that you would recommend to these patients? How do you feel about the Mediterranean diet?
Right, so that's the usual
DASH diet, things like that.
I usually go to the Mediterranean diet because it's easier. It includes a lot of the foods that patients eat, and includes fish as well. But at the same time, it doesn't cut a lot. A lot of my patients ask me about the keto diet or other restrictive diets, and it's a lot more complicated to go into those restrictive diets. But definitely the Mediterranean diet, that's more cardiovascular with the addition of fish, whole grains. So definitely that's the one that I go for.
Great. And we actually have a question from the audience. Do you have any experience or any guidance in terms of how to counsel other patients like psoriasis, RA, in terms of changing your diet? Anything unique to these patient populations?
So, when we did the cardiovascular, we started first as obviously asking, what are you eating? So they had to come in with a 3-day diary of what they were eating. And we try to make it as simple as possible. But overall, for all of our diseases across the board, I always went and I work with the Mediterranean diet. There is a push for some of my patients did the keto diet, not then, but now, and they seem to be doing okay. But overall, across the board, for all of our diseases, I would recommend the Mediterranean diet. And I usually add one item at a time. So, whole grain, let's for, one thing at a time. So let's start with the whole grain, and here's how we go to whole grains. And then when the whole grains was there, then I'll say, oh yeah, let's start pulling out sugar out of your diet. So one thing at a time work better than, hey, just throw your whole pantry out and come back in.
Great. And I think Dr. Mehta also had a question, but I believe he has to be let in biotechnician. So give us one.
Yeah, wonderful.
Oh, there we go. Okay. Good timing.
Monica, that was incredibly helpful. And I wondered if you might be able to comment for us a little bit about, you said that this was a lifestyle that the family, the patient themselves cannot do this without their microenvironment. And I wonder if you might be able to speak to all of us about how you counsel for that, because in a pediatric psoriasis paper about 5 or 6 years ago, we showed that a lot of the lipid and body mass abnormalities, body mass index abnormalities, start between ages 8 and 13. And if that's the case, you really can't tell an 8 or 13-year-old to do certain things. So what we needed was family time and family intervention. And that then reminded me, even with our adult patients, a healthy lifestyle starts at home with what your microenvironment is. So can you walk us through how you take your patients and their families through? Because not everybody is lucky enough to have access to a Monica like this, right? So you can tell everybody what you would say so that we can bring that back to our patients.
Right. First of all, I actually asked them to bring the family in. We had this opportunity, bring your husband or your mom, your kids, if they want to come in and sit through that, so they can all hear and understand what's really going on. But I would usually give them that if they could not bring anybody, then, reading material. We were lucky enough to actually had a nutritionist working also alongside with us in the program. And then she would actually make specific diets, and she would give a tip. It's like, you have a kid and your kid wants cookie, and here's a healthy diet for somebody with cookies. But for the family, we really try to explain how important for that patient with lupus would be important. Diet would be really important in preventing cardiovascular disease. And a lot of the times the family was, really keen on changing and helping. The biggest barriers with our group that we had was really the money to get the food. But the nutritionist was able to get us a good, we almost had we did a book recipe, a healthy diets that would give it to the patients that they can use to the whole family. But the family dynamic is
that's very helpful to hear that you ask the families to come in. And it's very helpful to hear that the biggest contribution of all of this is very well a microenvironment, not just the macro environment.
Yeah,
thank you.
Absolutely.
In our remaining 2.5 minutes, we did have another question from the audience. And so a dermatologist wanted to know, in the first interaction with the patient, how do you broach the subject without making them defensive?
Right. No, I think what we did, it was a very structured. The first class wasn't even just like, we asked them to bring our diets, but we just talked about cardiovascular risk and what they will be facing with. So not without scaring, but just giving them the facts. This is your risk of cardiovascular disease. You have lupus, and then, really looking at the diet and asking them, why do you eat this? Is that something that is part of your day to day, or is those, and some people say, I don't eat apples because I can only afford cookies. So, it's really based on the patient's reality and listen to what they have to tell us. So if you buy 10 apples, but you can buy a box of cookies to your kids, then I have to work somewhat in the middle.
So understanding the social determinants of health really play a strong role in your counseling.
Was key. Yeah.
Great. Thank you.
Thank you.
That was a treat. Thank you, Monica. I think we are going to move on. I think we have just about 10 seconds or so before we move to the next live symposium. So thank you for that lunchtime talk and reminding us how important holistic care is. Thank you.
Thank you. Thank you very much.
I'm being instructed to wait just 10 seconds. We're making sure we're following nuclear time here. All right, well, welcome. I am very happy to be able to continue on this day and forge ahead. We are welcoming you back to our meeting entitled Management of Cardiometabolic Risk in Inflammatory Conditions, Improving Treatment in Psoriasis, Inflammatory Arthritis, Systemic Lupus Erythematosus, and HIV. I am Nehal Mehta. I'm a preventive cardiologist from the Heart, Lung, and Blood Institute intramural program. Along with my co-chair, Michael Garshick, I have the pleasure of opening this session. Section 3 is titled Novel Insights into the Pathophysiology of Cardiovascular Disease in Pro-Inflammatory Conditions. The session will run from 1:50 until 3:10, where there'll be another break. The first speaker I have the pleasure of introducing is Dr. Jeffrey Berger, who is the head of the Center for Prevention of Cardiovascular Disease at the NYU, an associate professor of medicine and surgery. And today he's going to be speaking to us about platelets in pro-inflammatory conditions, a sticky situation. Take it away, Jeff.
Thank you very much, Nehal. It's great to be here today. And I think you and Michael have done just a great job in setting up this really wonderful day. I have learned so much already. So to get started, we've heard a lot this morning how there is a significant burden of cardiovascular disease across rheumatologic diseases. In fact, when thinking about the types of cardiovascular diseases, there are many. We see vascular diseases and myocardial diseases and diseases specific to the pericardium, to the valves and to conduction. So all different types, all very important. I'm going to spend the next 20 minutes or so talking about issues related to vascular disease. And, I think there have been a lot of insight into why patients with rheumatologic diseases are at increased risk. This is actually a very nice review from Dr. Mehta's lab, where they discussed what are things that help progress vascular inflammation across human inflammatory conditions. You see a lot of the usual culprits. You see myeloid cells. You see neutrophils. You see the endothelium. What I would like to state is I would like to add another cell type. I would like to talk a little bit about platelets. Now, I am not the first to talk about platelets in inflammation. And in fact, there is a whole I would say, archive of literature that talks about the role of platelets in inflammation, in immunity, that have really highlighted their role in this disease state. I'm just going to, I guess, maybe remind the audience about the role of platelets, talk a little bit of our work just to show the prominent feature that platelets do play in the pathogenesis of some of these diseases. So this was a paper that looked at platelet activity. One of the more robust metrics of measuring platelet activity is how the platelet sticks to the monocyte. This is called monocyte platelet aggregates. And when you look at patients with cardiovascular disease, they have very high levels of monocyte platelet aggregates. And in fact, when you look at the plaque of a patient with atherosclerosis, when you look at their CD68 cells, which are their macrophages, you see platelet stains on this same spot, suggesting that even in the plaque, platelets are sticking to some of the macrophages. So our laboratory went on to sort of do some work proving that platelets play a role not just in thrombosis, but actually in atherogenesis. In this mouse model, we depleted platelets, seen in the blue, and you see that there is a significant lower burden of coronary atherosclerosis. It's not just the amount of coronary atherosclerosis. When you start looking at the inflammatory component of these plaques and you look at CD68 staining within these plaques, you see that when you deplete platelets, there is significantly less of these inflammatory macrophages. So this was in conjunction with Dr. Catherine Moore's lab. We did single cell sequencing of CD45 cells in the aorta of atherosclerotic mice, looking at all different subtypes of leukocytes. And when we looked at different platelet stains, in this example, looking at platelet factor 4, you see that macrophages have a high burden of platelet stains on this specific cell type. So how do they do it? How are platelets causing this effect? So platelets actually induce a pro-inflammatory monocyte phenotype. This is, once again, using the same animal model. When you deplete platelets, as noted in the blue, you see that in mice that have a lot of these inflammatory platelets, they have more inflammatory monocytes. On the left, we see Ly6C high ratio over Ly6C low. You see more CD11B staining of these monocytes, and you see more of these pro-inflammatory monocytes circulating. But it was not only the monocytes. When we looked at the macrophages within the plaque, we did laser capture microdissection. This was in collaboration with Dr. Ed Fisher's lab, showing once again that when you deplete platelets, these macrophages are much less pro-inflammatory, really demonstrating the importance of platelets in inducing this pro-inflammatory macrophage phenotype. That was in vivo. What about in vitro? Well, we see the same exact pattern, that with more and more platelets, you're causing a higher inflammatory burden of macrophages when incubated with, in this specific example, this is with activated platelets taking their supernatants, not the actual platelet by itself, and stimulating the macrophages. Not only do they have an effect on monocytes and macrophages, they actually have an effect on the endothelium too. I took this photograph from one of Michael Garshick's paper, showing a beautiful picture of a psoriatic platelet on the endothelium. And then once again, using the animal model, when you remove the platelets in the white bars, the endothelium is less pro-inflammatory, less adhesive. It is less VCAM, less ICAM, less PCAM. And when you do the same thing in vitro, when you take endothelial cells, in this case, human coronary artery endothelial cells, you incubate them with either platelet releasate or activated platelets, you see a stepwise increase in IL-6 and a stepwise decrease of the protective eNOS. So I started showing you the importance of monocyte platelet aggregates in atherosclerosis and cardiovascular disease, but we're talking a lot about other inflammatory diseases. So this is just an example of several diseases that we've heard about today that show the importance of platelet activity, from SLE, HIV, psoriasis, diabetes, and obesity, all inflammatory diseases, all of which have shown the importance of platelets and the higher levels of platelet activity. Now, I'm going to go through a few of these. These are all data from our laboratory. I'm going to start with HIV. So in this case, when you take HIV platelets or control platelets and you put them on endothelial cells, whether they're in the basal state or whether they are in the activated state, meaning you induce activation ex vivo after you take them out of the body, in both cases, platelets isolated from patients with HIV were much more likely to adhere to normal endothelial cells than platelets isolated from healthy controls. Now, these platelets, when you put them onto endothelial cells, were more likely to induce endothelial cell activation with increased expression of IL-6, ICAM-1, as well as MCP-1. When you take these platelets and you put them on monocytes, you see that platelets from subjects with HIV were more likely to induce monocyte pro-inflammatory expression of MCP-1 as well as IL-8. Well, we spent a few years or so trying to sort of understand why this was. We did some platelet RNA sequencing. There was one particular transcript called ABCC4 that was able to induce this effect. And when you blocked that transcript, all of a sudden you attenuated some of the endothelial cell activation as well as some of the pro-inflammatory monocytes. All of this suggested that platelets play a role, at least in part, with endothelial cell activation and monocyte activation in the setting of HIV. So what about SLE? This is another study. This was looking at a little more than 50 subjects with HIV. Their SLEDAI, which is their SLE disease activity score, ranged from 0 to 22. Their mean was approximately 5. We had a control group that was matched for age, sex, and race. And you see that platelet activity, in this case, looking at what we spoke about before, MPA or monocyte platelet aggregates, looking at leukocyte platelet aggregates, or whether you looked at traditional platelet activity like platelet aggregation in response to submaximal agonists, in this case, collagen, ADP, arachidonic acid, and even spontaneous platelet aggregation. There was more platelet aggregation in SLE compared to controls. Now, we did something similar. We took platelets from patients with SLE, we put them onto UVEX, and we looked to see, are the UVEX acting differently? And clearly you saw that the UVEX, in the 3 lines on the left, were inducing a more pro-inflammatory endothelial cell. Well, what about compared to control subjects? And you see a stepwise, so that normal platelets had a slight effect compared to just media alone, but the actual effect from SLE platelets was significantly greater than normal healthy platelets. And once again, another person in the lab went on to sort of understand how SLE platelets were able to induce endothelial cell activation. In this case, we found that it was via an interleukin-1 beta pathway. We heard a lot this morning about this particular pathway and its potential to target for prevention of cardiovascular events. So we thought this was really, really interesting to show that a lot of this effect was actually coming not from the typical players, but actually coming or originating from the platelet. Dr. Garshick showed you earlier the important role of platelets in psoriasis. This is looking at two metrics on the left. This is P-selectin, and then underneath it is P-selectin plus thrombin. In both cases, they were higher in patients with psoriasis compared to controls. But what I think is really interesting was that there was a significant correlation between some of these platelet activity markers and disease activity or psoriasis area skin index or skin severity, which is a marker of how patients with psoriasis are doing. So this suggested that platelets may play a role in psoriasis. So what we did next is we went to the skin. We went to go look, are there platelets in psoriasis? And to answer your question, compared to normal skin and compared to patients with psoriasis, skin that was not lesional, so from somewhere else in their body. So when you looked at psoriatic lesional skin, we found very surprisingly a lot of platelets in that skin. So Michael went on to show that similar to in HIV, platelets isolated from patients with psoriasis, whether they were in their basal state or their activated state, were more likely to adhere to the endothelium. And then looking to see, not only is it adhering, does it induce a more pro-inflammatory endothelial cell transcript? The answer was yes. So patients, platelets isolated from patients with psoriasis were able to induce IL-1 beta expression, IL-8 expression in normal endothelial cells. Michael then went on to sort of explain and understand how this occurred, right? And this is sort of just a cartoon of I would say, a year and a half's worth of work, basically showing that compared to healthy controls, patients with psoriasis had increased platelet activity. They induced a pro-inflammatory endothelium, and he went to the platelet transcriptome, showing there was increased platelet COX-1 mRNA. So that suggested to him that maybe COX-1 was important in these patients when he inhibited COX-1 with a drug that we know very well about. When he looked at what is the effect of aspirin, aspirin was not only able to inhibit platelet activity, I think that is quite obvious what it does, but Michael was able to show that aspirin was able to attenuate endothelial cell activation. And so when you gave patients with psoriasis aspirin for 2 weeks, there was significantly less inflammatory endothelial cells. All of this would suggest that maybe aspirin is a useful therapy in patients with psoriasis. I would put a little bit of caution and comment that aspirin, while it has potential benefit, there is also potential harm with major bleeding. So, I personally think we would need a large trial to assess the efficacy versus the safety to figure out if patients with psoriasis should be on aspirin. Although we heard Dr. Ridker this morning, and Dr. Ridker did have a seminal paper. It was actually one of the papers that I loved most as I went through my training, showing that aspirin had its greatest effect in people with higher levels of inflammatory biomarkers, supporting this idea that aspirin may be particularly beneficial in patients with inflammatory diseases. So what about COVID-19? I think that it would be remiss to not sort of comment on the role of platelets in this disease state. I mean, COVID-19 has become the inflammatory immune-mediated disease of the year. And God willing, things are going to get better and better. And, I look forward to the point where we can stop thinking about it. But I will just show you 2 slides just to show you some data. So we noticed very early on that there was a lot of thrombosis in COVID-19. We found that actually working with some NIH investigators, some investigators at NYU, we found early on that the virus was able to invade the megakaryocyte, the ancestor of the platelets. It was found in platelets, and the platelet phenotype was very active. These platelets were just extraordinarily active, pro-inflammatory. So we took some of these platelet releasates, we put them on microvascular endothelial cells. We've all heard of this endotheliopathy. And we looked to see what effect does platelets have on these endothelial cells. And as you see in figure A in the middle, the endothelial cell transcriptome dramatically changed in COVID versus control platelet releasates, suggesting that platelets had a dramatic effect on the endothelium. Well, when looking at some of instead of just mRNA, we looked at sort of cytokines that were released by the endothelial cells, looking at CXCL8 or IL-8 on the left, IL-6 on the right. You see that COVID platelet releasate was much more likely to induce both IL-8 and IL-6 release. Very, very common cytokines that we've heard a lot about today being induced by platelets from these patients. Once again, our lab spent really the majority of the past year understanding the role of platelets in the endothelium. We show in a simplified version here in this cartoon, the SARS-CoV-2 infects the megakaryocyte, which is sort of found in the platelet. It releases a bunch of cytokines. We spent the majority of our time talking about calprotectin or MRP-814, which induced increased platelet aggregation, increased platelet leukocyte aggregates, inducing a prothrombotic transcriptome. Now, a lot of this was attenuated not by aspirin, but actually by P2Y12 inhibitors. And we think that this may have an effect on some adverse events. And in fact, I can tell you that I actually serve as the PI for the Active-4A trial, where we are now investigating the role of P2Y12 inhibitors in the setting of COVID-19. Now, this was actually a review that was just published about factors influencing cardiovascular disease in psoriasis. And I would like to point out that platelets were added. So I was really pleased to see this. I must admit that I'm one of the co-authors, so I'm a little bit biased, but I think it's really important to sort of put it out there. Obviously, platelets are one part of the process, but I think they are a very, very important part. So in conclusion, I think in addition to their key role in thrombosis and hemostasis, I think platelets play a major role across many inflammatory diseases. I showed you data on HIV, SLE, psoriasis, COVID-19. There are others. Platelets are versatile effector cells in inflammation and immunity. Activated platelets are key thromboinflammatory activities. They represent a novel, modifiable target in inflammatory diseases. Now, I would be remiss without just commenting that, because of Dr. Garshick, we do have a cardiovascular risk reduction clinic at NYU. I think it's really tremendous what Michael has started at our local institution, and it's great to see everyone here. But I also need to thank everyone in the platelet lab. These are all the people who do all the work. I get to showcase some of it. Everybody's wearing, by the way, the sweatshirt that if you look on the upper right, that's a picture of a platelet. Everybody very excited about it, and just so many people to thank. And just thank you again to the organizers for inviting me.
Thank you, Jeffrey. Like always, a very great journey through the world of inflammatory platelets. Keeping things moving here, I would love to take a moment to say thank you and welcome to Jose Scher. Jose is Associate Professor of Medicine and Rheumatology at NYU School of Medicine. He's going to be speaking to us today on the impact of the microbiome on systemic inflammation and cardiometabolic diseases. Welcome, Jose.
Thank you, Nehal. Thank you, everyone. Michael, Jeff, a bunch of friends here, so I feel at home. I will change a little bit the subject of this course, another kind of sticky situation, but in a different way. And we'll talk about the microbiome as it relates to rheumatic disease and some of the cardiometabolic conditions with emphasis on cardiovascular disease. My disclosure here. And so a quick overview on what I'll be discussing in the next 20 minutes or so, going over basic microbiome concepts, the effect of what we now call gut dysbiosis in inflammatory arthritis, and what's known about the microbiome in relationship to both inflammatory arthritis and cardiovascular disease. And the last part of the talk will be about how microbial metabolites can modulate inflammation in general. And we'll finish with a new, and to me at least, very intriguing field, that one of pharmacomicrobiomics and how it affects the drugs that we prescribe. So let me first introduce to you the intestinal wall and the reasons for why it is so relevant to physiology. The basic idea is that a mutually beneficial coevolution requires microorganisms, bugs, particularly in the gut lumen, that know how to signal the host and receive signals back from the host. The overall data that we have seen so far has shown that this equilibrium or homeostatic process to be robust and resilient, where these immune cells that reside in the lamina propria are in a constant state of low inflammation. And this is because they need to actively tolerate this massive permanent amount of antigenic load that these microorganisms provide. And in return, these microbes obtain the nutritional support for their own survival, right? However, what we really want to talk about today is what happens when this equilibrium is perturbed and a dysbiotic process ensues. So a few decades ago, and this is Josh Lederberg, who's a Nobel laureate at the age of 33, very impressive gentleman. But amongst other things, he's defined the microbiome as the totality of ecological communities, commensal, symbiotic, and pathogenic microorganisms, including their genomes, that literally share our body spaces. And then he went on to say that most of these microorganisms have actually been all but ignored as determinants of health and disease. But how can we, or they, be ignored, right? So to put you all in perspective, the total amount of microbes that live in and on our bodies amount to about 100 trillion microbial cells. That's about 10 times higher than the human cells that we harbor, which in turn encode for about 3 million protein coding genes. That's now 100 times higher than the genes that we have in mammals. And all of us during this Zoom carry anywhere from 3 to 6 pounds of bacteria at this very moment. And so for over a decade now, the Human Microbiome Project was launched mostly to expand as an NIH roadmap initiative to complement the Human Genome Project, and fundamentally to answer a couple of questions, including one, is there a core human microbiome? That is, do we all share a substantial amount of microbiome in the different surfaces and cavities of our bodies? And two, do changes in the human microbiome actually correlate with changes in human health? The answers overall appear to be yes for those two questions. And then the notion that in order to accelerate the knowledge in the field, there has been a constant need for developing new technologies and bioinformatic pipelines. And this is particularly because of the advent of high throughput sequencing. And why is that so relevant? Because, and this is important, we are currently unable to culture over 80% of the known bacterial microorganisms that are out there. So this is mostly because we lack the understanding of their oxygen and nutritional requirements for their growth in vivo or in vitro. And due to these advances, we can now actually have several tools that can characterize the community composition in any given sample. So if you now take a biosample and you want to understand taxonomy, then you do something that's called 16S sequencing, which is essentially answering the question of who is there, and it gives us the capacity to understand the relative abundance of the various microbes that are in a given sample. And then there's shotgun sequencing. Essentially what this does is to characterize every single gene in a given community. So now after we sequence every single gene, we can understand the functionality of these microbes and answer the question of what are these bugs actually doing. And so what are those functions that are so critical to human physiology? Well, the first one is their capacity to synthesize essential amino acids and some vitamins that we actually lack. Then, and of high importance, is their ability to process and degrade complex polysaccharides, as well as xenobiotics and the drugs we prescribe. We're going to talk about it in a moment. And of course, these microbes are essential to shape our immune system and for defending us against pathogens. Bear in mind that the highest concentration of immune cells in the body reside in the lamina propria, as I showed you on my first slide. But what do we know about this perturbation of the microbiome balance in rheumatic and autoimmune disease? We've known for about half a century now that the intestinal microbiota is sufficient to trigger inflammatory arthritis in nearly all animal models. This is true in the HLA-B27 transgenic rats, the KB/N model, and many others, where animals only get disease, their arthritic phenotype, if they're raised under conventional cages filled with bugs. But they actually remain healthy if they're raised under germ-free conditions, suggesting that the microbiome is necessary and at times sufficient for systemic inflammatory disease. But what's the story in humans? About a decade or so ago, we performed one of the first studies looking at 16S and shotgun sequencing, essentially to determine any differences in the relative abundance at the various taxonomic and functional levels in rheumatoid patients, and actually found that a single microbe, in this case Prevotella, was highly prevalent and abundant in the gut microbiota of patients with new onset disease. So this is to avoid any confounding effects of anti-inflammatory medications or the long inflammatory process in the community composition, which led to the observation that about 3/4 of patients with new onset rheumatoid patients actually carry this Prevotella in high levels. A microbe we also has shown to cause local inflammation in the form of increased DSS colitis, which is essentially an IBD model in mice. But what does that mean? In a follow-up study, this is a Japanese group now led by Shimon Sakaguchi, showing that gavaging mice, giving mice human Prevotella from rheumatoid patients could lead to the exacerbation of arthritis, demonstrating ultimately that gut Prevotella can cause not only local, but also systemic inflammation. And since then, multiple groups, we and others actually have shown that this gut dysbiotic process can be found in nearly every autoimmune and rheumatic process, whether we're talking about rheumatoid arthritis, psoriatic disease, lupus, spondyloarthritis. The findings have been very similar study after study. Now, what about the microbiome in cardiovascular disease? So far, there have been multiple studies in the field, which are summarized in this table, all using slightly different technologies, but mostly demonstrating, in essence, that the presence of cardiovascular disease in its various forms is also associated with a perturbation in the gut microbial composition. The most robust of these studies was conducted in about 200 more patients and another 200 controls using shotgun sequencing or metagenomics in this case, which found that in atherosclerotic disease, the gut microbiome is enriched in a few pathobionts. These are microbes that have the capacity to become pathogenic, including Enterococcus and Escherichia. And importantly, samples from these patients with atherosclerotic cardiovascular disease had also an elevation in microbial enzymes that increase the transport of sugars and other propathogenic amino acids. Okay, so that's still correlative work though. And so from a mechanistic point of view, there's data available demonstrating in this case that both antibiotics and probiotics can actually protect mice from acute MI in a leptin-dependent manner. And you can see here that in this ischemia reperfusion model, I'm sure some of the cardiologists in the audience will know this model better, but the use of vancomycin in this case led to a 27% reduction in the rat's infarct size in this model. And the same was true for probiotics-treated rats, which demonstrated lower infarct sizes associated with a decrease in circulating leptin levels. You can see that in those two graphs, suggesting that a direct modulation of the microbiome has the potential to restore healthy communities and eventually promote downstream cardiovascular disease. What's the story in CHF patients? A similar reduction in gut microbial diversity has been found, and importantly, an overall decrease in the abundance of butyrate producers. We're going to talk about butyrate and short-chain fatty acids in a moment. But in the middle figures, you can see that CHF patients had an increase in both local bacterial overgrowth as well as gut bacterial adhesion compared to healthy controls. And also the finding that there was, as expected, an increased level of bowel edema leading to an impaired intestinal barrier function with a consequent increase in bacterial translocation measured by elevation in circulating LPS. But why are butyrate and other short-chain fatty acids relevant to physiology and inflammation? Well, it is now known that gut bacteria exert most of their functions through the metabolites generated as end products of dietary fibers. These short-chain fatty acids have immune-modulated properties such that they can activate, and this is not important in terms of how this happens, but they can activate regulatory T cells and at the same time suppress all kinds of inflammatory processes, including but not limited to inflammatory bowel disease, as demonstrated in several of these papers, and here as one of the examples. Butyrate and other short-chain fatty acids have also been shown to ameliorate disease in a rheumatoid arthritis model, as you can see in these graphs, and in the HE histology, you can see that using either one of these short-chain fatty acids will prevent or hamper the evolution into inflammatory arthritis. Propionate which is another active short-chain fatty acid, has also demonstrated hypertension-reducing properties in a dose-dependent manner. You can see this happening on the left panel, where the higher the propionate you give to a wild-type mice, the lower the blood pressure. And this is certainly achieved through the engagement of this particular receptor for propionate. It's called GPR41. It doesn't really matter. But the concept here is that if you knock that receptor out, the blood pressure in these mice goes right back up, and that's even in the presence of these short-chain fatty acids. So finally, a very elegant study. This is, I recommend you read this in Circulation a couple of years ago, showing that in wild-type mice, a normal gut microbiota is capable of maintaining a healthy level of these short-chain fatty acids and a consequent homeostatic immune composition that leads now to cardiovascular health. However, these investigators have done something really smart, which is if you deplete this microbiome, there's now a decrease in these short-chain fatty acids and a consequent depression on the immune response that now leads to myocardial infarction in mice and an increase in mortality. Of course, now the survival rates were improved when you perform either a fecal microbial transplantation, that is, you reconstitute the committed composition, or you feed these mice with short-chain fatty acids, or you transplant mice with the right immune cells. All of it suggesting that there's a direct effect of the gut microbiome and its metabolites on cardiac health. But what do we know about this in humans with cardiovascular disease? Here's a really fun story that has been evolving over the years about TMAO and gut Prevotella. Let me walk you through this. It turns out that when we eat red meat and shellfish, for example, we're ingesting large amounts of L-carnitine, which in turn can be metabolized into this substance, TMAO, only in the presence of particular microbes, in this case, gut Prevotella. And it is now known that high levels of this TMAO can lead to enhanced atherosclerosis, and hyperreactive platelets, which we know, I don't need to explain you, that this is a perfect recipe for all sorts of adverse cardiovascular events. How do we know this? Mostly from work from Stan Hazen's group at the Cleveland Clinic, which showed that circulating TMAO levels correlate with cardiovascular disease events. It's been shown, if you look at the left, that people that are omnivores, for example, and do carry this Prevotella in their guts, typically experience an increase in TMAO levels after ingesting red meat. And at the population level on the far right, the observation that higher TMAO levels in plasma alone can increase the risk of MI and all-cause mortality at 5 years, independently of other cardiovascular risk factors. So finally, a few words about the very exciting and nascent field of pharmacomicrobiomics, or the effects of gut microbiome on drugs. We know that human microbes can indeed metabolize xenobiotics. They alter the chemical structures of ingested compounds, particularly drugs. And these changes, we now know, can affect the toxicity, biological activity, and bioavailability of these compounds. So one fun and really intriguing story, really good work by Andy Goodman at Yale, recently looked at how gut microbes can metabolize the drugs we all prescribe. And by we, I mean we, and I'll explain to you. They used this high throughput platform. They tested the ability of about 75 or so different bacterial strains to metabolize about 270 different drugs that have different diverse structures and functions. And they showed that a staggering 65% of the drugs that they tested were indeed metabolized by the gut microbiome. And as a second step, this will interest the cardiologists in the audience, they were able to insert plasmids from different bacteria into E. coli, forcing the expression of specific enzymes so that when wild-type E. coli were exposed to diltiazem, for example, a calcium channel blocker, the drug was not metabolized. But when they exposed it to the genetically modified or engineered E. coli containing these particular plasmids, the drug, diltiazem in this case, was in fact able to be metabolized into various end products. Okay, final. This month, for example, and this has to do with autoimmune and rheumatic disease, we published on how the baseline gut microbe and its functional genes are different in rheumatoid patients that respond to methotrexate compared to the microbiome of those that do not. We've established for the first time in this case that the human gut microbiome can actually metabolize this drug, methotrexate, and when we use random forest and other computational tools, we're able to predict with a high degree of confidence future clinical response, and a little bit better than the previously proposed clinical pharmacogenetic models, suggesting that the gut microbiome can indeed be used for precision medicine approaches in inflammatory arthritis and beyond. And with that, I'll summarize, just saying that the gut microbiota is mechanistically linked to physiological processes that affect both musculoskeletal and cardiovascular health, that some dietary nutrients, particularly fiber, can serve as key environmental influences to intestinal microbiota and human host metabolism, that you can modulate the intestinal microbiota and short-chain fatty acids, its metabolites, and it essentially could serve as targets for cardiovascular and rheumatic disease prevention and treatment, and therefore we can exploit the microbiome for effective initiation of anti-rheumatic and other drugs as potential strategies for treatment. With that, I'll acknowledge the good work by a lot of good people in my lab and beyond, and I thank you for your attention.
Thank you, Jose, for your talk and your energy. It's always nice to have you joining our sessions. We're going to move forward. We're running 5 minutes behind. I apologize for that. As always, pathophysiology takes a little longer to explain is going to be my excuse when I'm the only one who ran behind. So it gives me great pleasure to introduce our next speaker, Udo Hoffmann. Udo is not unfamiliar to me asking him to speak about vascular health. He was a featured member of our CCTA symposium at the NHLBI. Udo is here today to talk to us about vascular inflammation, the impact of HIV and on systemic and vascular inflammation. And Udo comes to us from Boston as the director of cardiovascular imaging at the Mass General Hospital and a professor of medicine at Harvard Medical School. Udo, take it away.
Thank you, Nehal, and congratulations to you and Michael to putting such an extraordinary course together. And as some of the speakers have mentioned, in light of the COVID pandemic, I think this topic will gain more global attention very rapidly. And so all of us are kind of working on that a little bit. So I'm going to talk about the impact of HIV on inflammation, but mainly on atherosclerosis, because the inflammation has been covered by Priscilla already very excellently. So these are my disclosures. So this is probably to many of you a very familiar slide. It shows the work of many groups over the last 2 decades to show, starting in the early 2000s, that patients living with HIV express or a 50 to 75% higher risk for relative risk for MI as compared to non-HIV people. And this persists after adjustment for framing risk score, comorbidities, and substance abuse. More importantly, traditional risk factors only account for 25% of the excessive risk. Now, this is familiar, but when you look at this in a different perspective, what we're really saying is that there are 50 to 75% more people with HIV that suffer these events unexpectedly and at an earlier age as their non-HIV counterparts. So I think already here we heard the term premature cardiovascular death or events earlier today, and I think this slide already demonstrates that as well. So the question is, what leads to these unexpected and premature events in patients with HIV? And of course, the elephant in the room is the increased inflammation and immune dysfunction that has been described. So when we look at mechanisms, Priscilla and also Jeffrey Berger went into this in detail, so I don't want to replicate what they did, but perhaps as a summary, in HIV, immune activation provides a very fruitful field for promoting atherosclerosis through increased activation of endothelial cells, through chronic activation of select T cells and monocytes, and altogether to creating a pro-inflammatory and pro-anticoagulant milieu in these patients. We heard a few words in Paul Ritger's talk about some corollaries between cancer and cardiovascular disease, and this is another one. As you know, PET imaging, FDG imaging, is routinely used for screening and follow-up of cancer patients. But it was relatively new and introduced about 20 years ago to be used to image inflammation in cardiovascular disease. And this is work by James Rudd from London, published in 2002, so quite a while ago, showing that the PET signal can be located at locations of macrophages in atherosclerotic plaques. In follow-up work, my colleague from MGH, Ahmed Tabakol, very elegantly used the model of carotid and atherosclerotic specimens to correlate in vivo human imaging with histology. So here you can see his works from 2006 and 2011, looking at in vivo imaging of the carotid artery, CT and FDG PET imaging that you can see with the enrichment of PET signal and high uptake in regions that appear to be of atherosclerotic plaque. And then on the right side, you can see the correlating histology specimen with the accumulation of CD68 stained macrophages in shoulder regions of plaque. We also heard from Nehal the expression low attenuation plaque this morning, and this is not restricted to the coronary arteries, but it is a general systemic phenomenon of atherosclerosis and can be seen here in the carotid specimens as well. So this was a fundamental step in using this method more globally to examine inflammation and atherosclerosis. This is follow-up work that was published in JAMA 2012, and the first publication to look at this in HIV patients. You can see that most of the work in PET was done on aortic atherosclerosis because of the limited temporal and spatial resolution of PET. So the aorta is a much more thankful organ to image with FDG PET. And you can see here the discrepancy between HIV and FRS matched controls on the right side with a much higher TBR in the aorta in HIV infected individuals. And the graph shows you that this is about a 30% increase, and it is similar to, or even higher a little bit than those with known controls with known CVD. So another paper demonstrating increased inflammation as visualized by FDG PET in individuals with HIV. We already discussed a little bit about the role of ART, and this work by my colleague Marcella Zanni from MGH, and as well the work from Priscilla and Ahmed that was published in JAMA 2017, showed us very nicely that ART does what it is supposed to be. It restores immune function, but it does not suppress residual inflammation. And this is pretty elegant. On the right side, you see a FDG PET image before ART. You see the lymph node signal and the aortic signal. And then after ART, you see that the lymph nodes are devoid of FDG signal, while the aorta seems to be even a little bit more inflamed. So ART does what it's supposed to do. It suppresses viral load. It restores immune function by increasing CD4 count and reducing circulating activated CD4 and CD8 T cells, etc. One noticeable finding here that we're going to come back to is that the increase in aortic TBR was correlated with an increase in LPPLA2, specifically in this small cohort. I mentioned that PET imaging is very difficult in the coronaries. The only place where it is reasonably possible is in the left main, because it's anchored in the aorta and doesn't move very much. So here you can see this is a study in 41 HIV patients with HIV, and you can see the morphological image of a high-risk morphology plaque in the left main with positive remodeling and low attenuation. And then you see a fused PET and CT image with the high TBR in that very region. And when you compared the TBR of those patients who expressed a phenotype of high-risk plaque versus those who didn't, then you saw that the TBR was significantly increased even after adjustment for risk factors, HIV-associated factors, in patients with high-risk plaque morphology. So now we have established a link between high-risk coronary plaque and inflammation in patients with HIV, independent of risk factors or other HIV characteristics. This study is now taking this further and compares patients with HIV to those with non-HIV, and you can see that the phenotype of atherosclerosis, coronary atherosclerosis in this case, in HIV is is geared towards low attenuation plaque and positively remodeled plaque, so high-risk plaque morphology. In both cases, the prevalence was much higher than in those without HIV. I talked about FDG PET imaging, and it is, of course, as you know, a very unspecific marker because it essentially just measured glucose turnover and in a sense metabolism. But of course, having a macrophage-specific imaging available would be very promising. So this work by Steve Greenspoon and colleagues, just published a couple of years ago, shows the application of a novel CD206 positive macrophage-specific arterial imaging strategy in HIV-infected individuals. And the upper panel shows this tilmanocept co-locating with technetium tracer in HIV-infected subjects and then in non-HIV-infected subjects. And you can see here that the signal is much higher in HIV-infected subjects. So perhaps with this, we have a glimpse in or an example of a specific imaging strategy in HIV-infected individuals, which of course would open up a lot of opportunities for personalized treatment in these patients. Let's talk a little bit about epidemiology. So I choose to study from, this is a study from rural China. in about, I believe, 2,500 patients. And it looks at, I chose the study for two reasons. A, it looks at carotid IMT, so further completing the systemic nature of the effects of HIV from the aorta to the coronaries, now to the carotids, and also demonstrating that this is a global problem in rural China as well. And moreover, similar findings as studies that have been conducted by Priscilla and Jim Stein in the US. What this study shows is that, again, there's an increased prevalence of subclinical plaque in that sense in the carota, independent of a Framingham risk. In fact, the Framingham risk, when you look at this table here, is relatively is very low in these young patients with HIV, and much lower than in the patients without HIV. Whereas the CIMT is much thicker in patients with HIV. What garnered my interest actually is this group, is because this is a rare group. These are patients with HIV in controls that are elderly, so between 60 and 75. And here you can see that the CIMT is essentially similar between HIV and non-HIV. So, one question that arises is whether this effect of premature atherosclerosis through HIV-specific inflammatory noxus at some point, after survival, non-event survival, is essentially going away, and non-HIV individuals just catch up with their regular natural history of atherosclerosis. I want to spend the last couple of minutes on Reprieve. Most data on HIV were relatively limited to smaller, especially the imaging data, limited to smaller studies. So Reprieve is a large study funded by the NIH, two institutes, the ACG Clinical Trials Group, and many others that recruited patients at 110 sites across 25 countries. So the strength of this cohort is large, and it's generalizable across many geographical areas, for example. Now, the study was started in 2015, and the main results will be presented in about 2 years. But within the large study that enrolled almost 8,000 patients, there was a mechanistic sub-study that was conducted at 30 US sites and enrolled 800 patients. And we recently presented the baseline data at CROI of these 800 patients. And so this was a study where patients underwent a coronary CT and got a specific biomarker panel of to characterize vascular inflammation and immune activation. The good news is that this subset of the Reprieve study is representative of all enrolled patients in the United States. So even those that did not undergo imaging in the sub-study, and this were about 4,300 patients. So it's a pretty good reflection of the HIV population in the United States. And as you can see, pretty young people in this study. Only 16% of were females, which is the only factor that's in fact lower than in the overall population. You can see the ACVD risk score, a median of 4.5, so very low. More than 50%, 56% less than 5. And you see this is a well-controlled population in terms of HIV health. This is the main slide about the prevalence and extent of coronary atherosclerosis in this population. And when you look overall, there were 49% in this young and low-risk populations who had plaque. 35% had calcified plaque, and 23% had vulnerable plaque. Notable among those at the lowest ACVD risk, still 30% had plaque 22% had CAC, and 30% had vulnerable plaque. Comparatively, in the prevalence of vulnerable plaque in a chest pain population such as PROMIS is 15%. So this is, again, an expression, I'm sorry for this forwarding of the slides here. This is an expression of the premature and specific phenotype of atherosclerosis. Overall, this shows us that plaque increases with ACVD risk, but high prevalence of CVD, even in those at the lowest ACVD risk range, is present. And this, maybe we can discuss this later, gives us some idea how to answer the question whether every patient with HIV should get statin treatment. The other part of this study was looking at key biomarkers of inflammation and immune activation. And this just presents the results of a comparison between those who had atherosclerosis versus no atherosclerosis. And you can see here, Paul may say reassuringly, high sensitive CRP was not different between, as a very general marker of inflammation, was not different between those two groups, but some of the markers that we heard before, some of the more specific markers, such as IL-6 and LP-PLA2 were significantly different, and these differences remained after adjustment for CVD risk score, HIV and HIV factors, as you can see on the right side of this table. So it is nothing specifically new, but I think it is confirmatory and reassuring that immune activation relates to novel atherosclerotic plaque phenotype in HIV with an increased prevalence of non-calcified high-risk plaque features at young age and very low traditional CV risk. And that this phenotype is associated with increased immune activation and markers of inflammation. You can see here on the right side an example of a 46-year-old male with a risk score, ACVD risk score of 6.6, and 2 high-risk plaques in the left main and proximal LAD. I want to thank, of course, and acknowledge the work of the Reprieve team and the institutes. And thank you very much for listening to this presentation.
Udo, thank you. We're going to go ahead and assemble the speakers back on for Section 3, Novel Insights into the Pathophysiology of Cardiovascular Disease in Pro-Inflammatory Conditions. We will be joined by Dr. Berger, Dr. Scher, Dr. Hoffman, Dr. Garshick, and myself. And I guess we can get this started by, making some connections before we get to the Q&A. Michael, I think you're monitoring some of the Q&A, so if there's something else that comes up, please do let me know. I had one for Dr. Scher come up, but before I get to it, I guess one thing that I'd like to ask the speakers, and particularly since it was the last talk, Udo, when you do see this response, if you will, of the immune system in driving atherosclerosis, might you speculate a little bit about the role of inflammation and the dyslipidemia? So the HIV model has taught us that, even after treated infection, there's still inflammation. There's interaction with dyslipidemia in driving what you guys found in 2000. It looked like 8 years ago, the high-risk plaques, the low attenuation plaque. Can you speculate a little bit about the inflammation dyslipidemia axis and what things you've learned from what you've seen so far from Reprieve, so that the other disease states that are trailing behind can learn from you?
Yes, Reprieve has, of course, one of the entry criteria was a very well-controlled lipid level. So there we don't have any hyperlipidemia, and we still see these very, these relatively strong associations. It's, as you know, Nehal, it's not so easy to find good correlations between phenotypes and between phenotypes and biomarkers. And Reprieve has 800 patients, so this provides a powerful resource to assess these associations. as most studies, for various reasons are limited to 50 or 100 patients, where it's really difficult. So I think we see this relatively strong association in the presence of, not controlled because they're not on statins, but in the absence of hyperlipidemia.
Mm-hmm.
So I think, this is firmly established as the role of inflammation. And otherwise, I think it might not be so difficult different from what we saw in Cantos about that these are really two separate avenues that contribute to cardiovascular risk in terms of hyperlipidemia and inflammation. I haven't seen data that would suggest that this is different in HIV than it is in non-HIV patients.
Wonderful. Thank you, Dr. Hoffman. I have a question here on the panel for Dr. Scher or Dr. Berger, but I think it was directed to Dr. Scher. Dr. Scher, can you please discuss the COVID-19 vaccination and whether or not there is any effect with anti-inflammatory medications?
Yeah, thanks, Nehal. We were talking offline with Michael. It's a very interesting question, right? Do people expect to mount an immune response to, in this case, for the most part in the US, mRNA, EUA vaccines? The answer we thought was going to be mixed. What we know from the data that's emerging is that, for example, anti-cytokines have no effect on at least humoral immune response. When it comes to anti-metabolites, and this is a broader observation that has derived from transplant patients, from our own data in immune-mediated inflammatory diseases and the IBD groups, is that medications such as methotrexate, for example, or Cellcept that affect T-cell immune responses have a challenge when it comes to mounting immunogenicity in general. We don't understand the mechanisms. We kind of expected some of that from methotrexate. There was data from a couple of years ago showing that flu vaccination or Hep B vaccination are hampered by methotrexate use in the chronic setting. And then the other one is, obviously anti-plasma cells medications such as rituximab. But beyond that, cytokine-specific biologics in this case do not seem to affect it. So Wonderful. It's intriguing and needs to be further discussed and studied.
Wonderful. Thank you, Dr. Scher. And I know that we also will be joined later by Dr. Gelfand, who has led a few task forces on this for the NPF as well as the AAD. So a lively discussion could follow. Dr. Berger, I have a question here on the board for, can you discuss COVID toes and platelets?
Sure.
Interesting.
So, yeah, no. I think early on, when there was a lot of realization that thrombosis was a big player in the disease, in COVID-19. And that's both micro and macro thrombosis. And I think that there was a lot of talk about COVID toes. It was being observed. I think the majority of people think that it is due to microthrombosis or to some immune complex deposition. I would remind everyone that immune complexes activate platelets. And that is definitely one of the mechanisms of why in the setting of lupus, patients are at higher risk for having a thrombotic event. So I think the COVID toes sort of makes sense because platelets are so activated, because there are immune complexes. I think that that's one of the potential mechanisms. I know, meaning, as I said, we have studied, but others have as well. Platelets are very active in this disease state. The NIH is now funding a very large trial on antiplatelet therapies. So I think we know that it's a problem, and we're now trying to figure out, how you can prevent this complication. And I would just say, stay tuned.
Thank you, Dr. Berger. We have time for a few more questions. So I will ask one that has also come up for Dr. Berger. Jeff, would you be able to comment on the pathophysiologic role of platelets in the primary disease of inflammation themselves? So for example, is there data that platelets drive the primary psoriatic phenotype? Is there data that the platelets may drive the rheumatoid arthritis or the lupus phenotype? And if you might be able to speculate on the role of the platelets in the primary disease activity.
Sure. So I think that gets to a really important question, and I think that applies to probably every disease state, right? Is it primarily coming from the platelet, or is the platelet being responsive to something circulating that then is, exacerbating? I will comment that I don't think it is something systemic that is having an effect on the platelet. I think we have proven that. I think others have proven that too, because platelets are really unique cells. They don't have nuclei. They don't have DNA. They can't make their own RNA, right? So everything that comes from the platelet comes from the megakaryocyte. That is not to say that, circulating cytokines or, this perturbed homeostasis, it can certainly affect the bone marrow or in the lung, right? Those are the two places, the two most common places where megakaryocytes are made, that can affect the megakaryocytes and then affect the platelets. I would say, I'm sure it's a combination of both. I don't think we have any firm idea that, or firm conclusion that it is only one versus the other. Although I will tell you, and I showed one of the papers that we recently published, when you remove platelets, a lot of these diseases get better. It's been shown in rheumatoid arthritis. It's been shown in in other disease states. We showed it with atherogenesis. So I think that platelets are playing a prominent role. I do, and I think it's our goal to sort of figure out how and to answer that fundamental question, which is it the primary process, or is it part of the disease process itself? And hopefully we will have that answer soon, at least partly.
That would be great, Jeff. Thank you so much for your answer. I have no more questions on the chat board. I wondered if anybody wanted to make any closing comments, our speakers, Dr. Hoffman, Dr. Scher, Dr. Berger. Michael, if there's any questions that came in through the other channels, let us know. But if not, I can certainly leave each of the speakers having some closing comments, because what I think we need to all remember is that the pathophysiology of these diseases is still being worked out in terms of unique contributions to cardiometabolic diseases. The more that we learn from each other, I think that Reprieve teaches us that large, simple trials are very important. Hopefully, we'll be able to do more of those in other disease states. I think the Target to Treat trial, Dr. Solomon's group is looking at in rheumatoid arthritis. Down the pike, we need to think big team science and learn from each other. So Drs. Berger, Scher, Hoffman, any closing words before we close the session?
I couldn't agree with you more. Sorry, Jeff.
Go.
No, what I was about to say is that a lot of the advances in autoimmune and rheumatic diseases came not from within our fields. The testament of the fact is, microbiology is describing the powerful effect of anti-TNF on our diseases. That's Jan Vilcek. And so I'm expecting, the unexpected, that some of what we learn will come from platelet biology or some other, serendipity finding. And I like the idea of going upstream and understand pathophysiology through a different lens. So big science is the way to go.
I would just add to that and just state, it's been a wonderful day. And it's really nice to see, cardiologists, rheumatologists, dermatologists, immunologists, the list goes on, all work together on this complex area so that we can, learn from each other and ultimately help patients get better.
Thank you, Dr. Berger.
Yeah, and perhaps one more sentence from here. I do think that many speakers have shown that phenotyping disease is very helpful in understanding all the biomarker work you're doing as a link between the biomarkers and the events. And I'm particularly, of course, looking forward to the results of REPRIEVE, which will have both elements, the plaque and the events. And I still think the answer will not to treat every patient, with statins, for example, because I do see a lot of similarities between what we're talking about and very established diseases like diabetes, namely that once you look at phenotypes, there's probably a third of patients who are not affected by their pro-inflammatory condition in a sense that they don't exhibit atherosclerosis. And in diabetes, at least, these patients do not have an increased event risk. So I think downgrading is as much a topic as upgrading of therapy, that we'll have to think about.
Udo, thank you. Appreciate the comment. So it's 3:09. It's 1 found minute of time. Our break is scheduled from 3:10 to 3:40. Please join us back for section 4, where we put it all together. It'll be moderated by Dr. Joel Gelfand, and speakers will include Drs. Garshick, myself, Dr. Eder, with a question and answer session to cap off a very exhilarating and exciting day. Thank you.
So I want to welcome you all back. I'm Dr. Joel Gelfand, and I have the privilege and honor of moderating this last section of the day. And we're going to start off with a combined talk by Dr. Michael Garshick and Dr. Nehal Mehta. Dr. Garshick is a assistant professor of medicine at NYU, and he's a cardiologist who runs the cardio-rheumatology program, and is really doing pioneering work in understanding the impact of platelet biology on atherosclerotic disease and cardiovascular disease in inflammatory disease conditions. And then Dr. Nehal Mehta is also a cardiologist. He's the inaugural Lasker Scholar at the National Institute of Health, the NHLBI, and has really truly been a pioneer in understanding deep imaging effects of our treatments and disease of psoriasis and other conditions on atherosclerotic diseases, as well as developing some new innovative ways of imaging these patients and some innovative findings of high-risk plaque features and things of that nature. And I would say, as a person who's been working in this field for quite some time, we're incredibly lucky to have these cardiologists, pursuing this type of work. It's really dramatically advancing our understanding of the biology of what's going on in our patients, and hopefully ultimately lead to better ways of preventing cardiovascular disease in patients with inflammatory conditions. So with that, I will turn over to Dr. Garshick, who will lead this session on the approach to cardiovascular risk stratifications in inflammatory conditions.
So thank you very much, Dr. Gelfand. It's really exciting to be presenting here once again and begin the section of putting it all together. So Dr. Mehta and I are going to take a generalized approach to cardiovascular risk stratification and how to provide a general framework of how to think about these autoimmune, autoinflammatory conditions. And this is going to encompass screening, diagnostics, and when thinking about possible interventions, we really talked at length about potential benefit of these anti-inflammatories. So I wanted to briefly talk about potential harms, and then Dr. Mehta is going to finish talking about, again, some potential benefits of statins. So this work was already brought up, but I think it's important to really hammer it home that these autoimmune, autoinflammatory conditions, most of them, have elevated rates of under-recognized and undertreated traditional cardiovascular risk factors. This is just one analysis of subjects enrolled in a psoriasis clinical trials, in this case an IL-12/23 trial. And at enrollment, at least 88% had at least one heart disease risk factor. And almost a third had greater than 3. And then when we looked at disease control, only 10% had optimal disease control, and only half, for example, only half had diabetes optimally managed. So cardiovascular risk stratification starts not only with recognition by the patient and the provider, but also by providing information. And this is kind of a lighthearted slide where this is actually an online survey sent to Creaky Joint members who had rheumatoid arthritis. So Creaky Joint is a patient advocacy group. And they sent out an email to all of their members with rheumatoid arthritis. So kind of an enriched population. I think I jumped one slide here. Hold on 1 second. There we go. So they got 825 responses, the majority of which were female. And when you look at the responses and what happened, only 26% had rheumatoid arthritis patients had ever been given told that they'd elevated cardiovascular risk, which is shocking given that our entire presentation here today was all about cardiovascular risk in these populations. That RA is one of the longest studied conditions that's been associated with cardiovascular disease. Fortunately, the majority of when they did hear it was from a rheumatologist. Only a third heard it from their primary care doctor. So really highlighting how much work we still have to do to get the information out to those who really matter, which are the patients. So in regards to screening, this is not a one and done, and this is SLE. And this is an older study, but I think actually pretty cool. They looked at systemic lupus erythematosus patients from 27 centers in 11 countries. And they put them into this cohort within 15 months of initial diagnosis of SLE, and data was collected at enrollment and annually. So what the authors showed was that if you look at the baseline rates of traditional cardiovascular risk factors, hypertension, hyperlipidemia, smoking, diabetes, they're present. But then after 3 years of just following these patients on a yearly basis, the risk factors go up dramatically, really indicating and suggesting that it's not just a one and done. That you get these patients, you get the traditional risk factors at baseline, and then at least on a yearly basis for early identification, early management of the traditional cardiovascular risk factors. So I would say also that the obvious stuff matters. And I know it sounds a bit trite, but this is smoking and HIV. Smoking, first of all, is a high prevalence in HIV. And we all know that smoking is bad. That's pretty obvious. But when you compare those who are active smokers in HIV with non-smokers, the mortality rate is approximately twofold. However, if you stop smoking over 4 years, that difference was essentially erased. And finally, there we go. So finally, there are also gender differences in autoimmunity that we have to keep in mind. So rheumatoid arthritis is twice as common in men than women. Systemic lupus erythematosus is 15 times more common. And again, it's not just these autoimmune, autoinflammatory diseases that are now in the guidelines as risk-enhancing features, but it's also that women sometimes can have some unique cardiovascular risk factors that have to be taken into account, such as history of premature menopause or pregnancy-associated conditions, such as preeclampsia. And of course, when we start talking about the incremental value of things like the inflammatory conditions with other types of cardiovascular risk-enhancing features, it's important to take a thorough history when assessing cardiovascular risk and possibly identifying those who would need more aggressive cardiovascular risk reduction strategies. So in summary, slide 10 here right now, it's these cardiovascular risk factors are highly prevalent, under-recognized and under-discussed, both by patients and providers. These ASCVD risk factors change over time, so continuous screening is important. And after you've recognized these traditional cardiovascular risk factors, the question then becomes, well, what diagnostic tools do we have to further refine risk even more? And we've talked about this at length, but I want to just highlight a few specific points. So first of all, we've all seen that the ACC/AHA guidelines now include these chronic inflammatory conditions as risk-enhancing features. We all know that. But just to keep in mind, as we discussed, elevated CRP matters, checking in Lp(a), ApoB, different other kind of incremental risk-enhancing features to determine who you should aggressively manage. And we do have a variety of risk scores, and they have a lot of downsides, but I think there are some things to focus on, and that maybe they can help guide you. So in the British system, we have the Q-Risk-3, one of the only risk scores that incorporates lupus, rheumatoid arthritis, and steroid usage. The NPF, the National Psoriasis Foundation, recommends a multiplier to those with moderate to severe disease. EULAR actually does not specify disease severity. They just say that any RA should multiply by 1.5. Dr. Solomon talks about his risk score calculator that incorporates disease activity, disease duration, quality of life, and steroid usage. And in HIV, we have the DAD study, which incorporates cumulative drug exposure, and some versions of it also include CD4 count and other inflammatory biomarkers. And while problems exist to these scores, I think they're important to mention because it at least helps you focus when seeing the patient on what can potentially matter in increased cardiovascular risk, such as steroids, disease activity. And so finally, how do interventions impact cardiovascular risk? And we've heard a lot about the benefits of anti-inflammatories, the benefits of aspirin, the benefits of statins, but there are some potential complications that we at least have to acknowledge. So for example, steroids and autoimmunity. So in lupus, steroids are associated with a high risk of cardiovascular event. So a certain doses of steroids is associated with upwards of a 5-fold risk of a cardiovascular disease. In rheumatoid arthritis, those who required steroids, there's a 2-fold higher risk of cardiovascular events. And finally, we all know that steroids in many cases can increase lipids. Steroids also have generalized problems as well, such as fluid retention, arrhythmias, hyperglycemia. And this isn't to say that steroids don't have a role that was brought up by, I think, Dr. Solomon and by Dr. Kaplan, but it's to understand that in those that require them, you should think about how to counsel differently your patients and potentially implementing other preventive strategies, because at the very least, this may be a manifestation of a more severe disease phenotype. Finally, IL-6 inhibition in rheumatoid arthritis and the lipid paradox. This is a pretty cool study I wanted to highlight. They took patients with active rheumatoid arthritis, and they gave an IL-6 inhibitor for a total of 10 weeks, only 11 patients. And what you see here is that from the pharmacokinetics, total cholesterol went up, LDL went up, HDL went up, triglycerides went up. Interestingly, LP little a, lipoprotein little a, went down. And when you looked at why this may be occurring, it was actually a reduction in a breakdown of LDL, reduced fractional catabolic rate, kind of getting at some mechanisms of how LDL and how lipids may be rising with the treatment with at least an IL-6 inhibitor. So finally, this is kind of a loaded topic, JAK inhibitors and psoriasis. JAK inhibitors are shown to increase LDL, HDL, and triglycerides. But probably there's been a lot of chatter right now about JAK inhibitors and cardiovascular outcomes. And there's been a potential concern for signal for harm. So essentially, there was some initial clinical trials came out a number of years ago, where it showed a slightly higher rate of venous thromboembolism in rheumatoid arthritis patients on JAK inhibitors. And that led to an FDA-mandated oral surveillance study. And this was a post-marketing surveillance study of 4,000 individuals, rheumatoid arthritis, greater than 50 years of age, with greater than 1 cardiovascular risk factor. And what happened was that when you compare all doses of tofacitinib to TNF-alpha inhibitors, they did not meet the non-inferiority endpoint compared to TNF-alpha inhibitors. So it was slightly concerning. And I don't think the data is fully out yet. And I don't think we've fully digested this. And this isn't to say that you should not use JAK inhibitors, but just to think about the implications now and in the future, especially in those in very, very high elevations of cardiovascular risk. So I think when in doubt about how to risk stratify these patients, as we spoke about, in vivo imaging can help. But just some nuances behind this as well. So the AHA prevention guidelines in 2019 actually discuss how clinicians should not necessarily downclassify risk in some patients who have a CAC score 0, and they actually say possibly chronic inflammatory conditions. And in these conditions, a CAC of 0 may not rule out increased non-calcified plaque or increased risk of thrombosis. So then I always think of studies like the Scott Hart trial. This was a pretty great study, or versions of this was a great study. It compared CT angiograms to standard care in stable chest pain patients, about 4,000. After 5 years, there was no difference in coronary revasc, but the aggressiveness of preventive therapies was 40% higher in those who obtained a CT angiogram compared to those who didn't, and the primary endpoint was overall lower in the CT angiogram than in the standard care. So with that, I'll turn it over to Dr. Mehta to take us home with more imaging metrics of cardiovascular risk.
Thank you, Michael. So I think the first thing that we need to take away is that there's no one size fits all. I think that what Michael has shown us is that we under-recognize, under-treat, and grossly sort of underestimate their cardiovascular risk overall. And what I'd like to do is remind folks that, you know, a picture worth 1,000 words, seeing is believing. There's all these catchphrases, but what Michael did bring up really alludes to image-guided therapy. So if you were unable to tune in earlier today, I provided 3 update slides from our last talk. And what we were showing here was that non-calcified coronary plaque burden improves following anti-psoriatic therapy. So that means that treating primary disease here, we're at an era where we have enough observational data that we do believe treating the primary skin disease is important. Also, we talked about how the lipid-rich necrotic core is important, and we heard from Udo Hoffmann about low attenuation plaque, and then Michael just brought up the Scott-Hart study. And if you think about what Scott-Hart showed us, it's that when you have this plaque, you have a nearly 4-fold elevation in risk of having a future MI. And shown here is a plaque on the left where the LAD has this lipid-rich necrotic core plaque in the proximal portion, which after a year of anti-psoriatic therapy goes away. And again, lipid-rich necrotic core has lipid. So the amount of bioavailable lipid in these patients with inflammation appears to be this ApoB shift. This is common among all our inflammatory states we discussed today. There's a triglyceridemia, there's a shift in LDL, it tends to stay around longer, become oxidized and smaller, and the LDL particle numbers uniformly go up in chronic inflammation. One thing that we must impart, and I brought this up today at the lunchtime talk with Monica, that these changes start early in life. So this is a paper from years back, 5 years back now, with Larry Eichenfeld and Winnis Tom's group. And this showed that when you looked at children between the ages of 8 and 17 with a mean age of 13, there was an incredible amount of insulin resistance, body mass index elevation, higher apolipoprotein B concentrations, which is LDL basically and triglyceride, as well as poor HDL function with lower HDL concentrations. We need to think about what can be done. And I think that we're at the point where moving the dial forward does involve considering their risk. We heard Dr. Ritger today say that, you know, he'd been arguing for 2 decades now that everybody should be on statins who have a CRP over 2 or 4. And these patients with chronic inflammatory diseases should be. So we're at an era now where we want to ask the question, can statins be applied broadly and safely to this population? And I'm talking about psoriasis. And the reason for it is that on the left, you'll see that statin therapy is very effective for decreasing apolipoprotein B concentration. And you'll see on the right, colleagues from my NHLBI intramural program showed that there are immune benefits of statins, namely on Tregs and other inflammatory cells that are important in psoriasis, begetting a disease-specific modification as well. So with that, you know, I think that I would like to end by saying that Michael has taken us through risk stratification of autoimmunity as well as chronic inflammation. And what I hopefully was able to impart on you is image-guided therapy may help. Starting a statin may be considered during the recent guidelines in 2018. And we'd be happy to discuss this further at our panel. Thank you.
Okay, so thank you, Nehal and Michael, for that excellent summary. And now I'm pleased to introduce Dr. Leahy Eder, who is a clinician scientist and rheumatologist at the Women's College Research Institute, and is also an assistant professor of medicine at the University of Toronto, Canada, where she directs the cardiorheumatology program. She has a broad background in rheumatology with specific training and expertise in clinical and genetic epidemiology of psoriatic arthritis and cardiovascular diseases in rheumatic disease patients. And her program and some of her findings have been very important and motivating to my own research. So I'm really delighted to have Leahy here. Leahy, take it away.
Thank you so much, Nehal, for the kind introduction, and thank you, Michael and Joel. Thank you for the kind introduction, Nehal and Michael, for the invitation and the excellent talks so far. So I was asked to put it all together and share some of the lessons that we've learned from our cardiorheumatology program that we established in 2017 in Toronto. And I thought, since it's the end of the day, I'm going to focus on three key lessons that we've learned from 3 cases that we've seen in our clinic that I'm going to share with you. So these are my disclosures. And why cardiorheumatology? I think the previous talks have set the scene to some of the reasons that led us to establish this combined program. And Joel has already mentioned this study that we've published a few years ago using the IPART network, which is a network of dermatologists and rheumatologists mostly in North America that see patients in their clinics, and as part of the study, all of these patients have their lipids and blood pressure checked. So we analyzed over 2,000 patients with psoriasis and psoriatic arthritis, and we were interested in investigating what are the gaps in care in terms of cardiovascular risk factors. So I think the first striking finding from this study was that almost 90% of the patients seen in these clinics had at least one modifiable cardiovascular risk factor. So the burden is huge in these patients. The second finding was that a significant proportion of the patients had underdiagnosed, especially dyslipidemia. Most of the patients with dyslipidemia were unaware of the fact that they had abnormal lipid profile, and certainly they were not treated appropriately. And also a significant proportion of the patients with hypertension were unaware of this condition, and many of them were undertreated. So this really triggered us to think and come up with this idea of combined cardiorheumatology program, which at that time was the first one in Canada. And with the aim to improve the management of cardiometabolic diseases in patients with rheumatic diseases. So our program has 3 arms, and I'm going to focus on the clinical arm that includes a primary prevention clinic. We also get referral of complex patients with complex cardiac involvement related to their rheumatic conditions. We also conduct research and do some educational activities to increase awareness of the existing gaps and some of the management of these patients. So we work together with our cardiology colleagues, and we utilize resources that are available in our rheumatology and cardiology divisions to perform risk stratification as well as manage some of these risk factors. We also work closely with our colleagues from vascular imaging to perform some of the studies that we do, as well as for the clinical management of these patients. So what do we actually do with the patients? So we refer all patients with inflammatory arthritis, so patients with rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis, who are above the age of 40 and have no history of cardiovascular diseases, to this combined clinic, where they see the cardiologist. History is taken, they have a physical examination done, and then we refer them to do a pretty extensive assessment of their vasculature system using imaging modalities, including coronary CT, carotid ultrasound, stress echocardiogram, as well as a bunch of cardiac biomarkers that are available in our laboratory, as well as a very extensive lipid profile. After they complete these tests, they see the cardiologist again, who reviews these results and make her recommendations in terms of the need to start initiated treatment or do further assessment of abnormalities identified. We also then invite the patients to return a year later for reassessment in order to reinforce some of the recommendations and assess adherence. And as part of an ongoing study, we plan to see these patients at the 5-year mark as well. So as I mentioned, I'm going to share with you 3 cases that illustrate some of the challenges related to the management of these patients. So this is the first patient, who is a 76-year-old woman with a long-standing rheumatoid arthritis, who's been stable on methotrexate. And she had multiple comorbidities. I think the most important one was an interstitial lung disease that has been managed by her respirologist. And interstitial lung disease is considered to be an extra-articular manifestation of rheumatoid arthritis. She didn't have really, other than borderline hypertension, did not have any other conventional cardiovascular risk factor. And when questioning, she reported a history of progressive shortness of breath after climbing 1 flight of stairs for the past 2 years. And going over her medical notes, this was considered to be secondary to her interstitial lung disease. Her physical exam was pretty unremarkable, and her calculated Framingham risk score was 7.8, which will put her in the intermediate to low risk category. Her cardiac enzymes or cardiac biomarkers were pretty normal, and her echocardiogram was also unrevealing. However, as I mentioned, we send all of our patients to do coronary calcifications, and her coronary artery calcium score was very high. To those of you who are not using this score regularly, a score of more than 100 is considered to be high. So this is very high. And given this result and her symptoms, she was referred for a coronary angiogram that showed 90% obstruction of the mid-right coronary artery and underwent stenting. She also started treatment with statins, aspirin, and underwent cardiac rehab. And in a follow-up visit, she reported an improvement in her symptoms. So I think this case really illustrates some of the difficulties of managing some of these patients with complex and multiple comorbidities. So I went over our data in preparation for this talk, and these are the numbers. 1 in 3 patients presenting to our primary prevention cardiorheumatology clinic reports chest pain, dyspnea, syncope, or palpitation that could be of cardiac origin, although less than a handful of patients really fall into the typical description of angina or heart failure related symptoms, similar to this patient whose symptoms were thought to be related mostly to her interstitial lung disease. And what might be some of the reasons for that? Well, I think Michael alluded to the disproportionately distribution of or sex between in patients with rheumatic diseases, and we know that females are more or rheumatoid arthritis is more common in females. 70% of the patients with RA are women, and 90% of the patients with lupus are women. And from the general population, we know that cardiac pain presents differently in women in terms of the type and the distribution of pain. Symptoms, because they are atypical, may be misinterpreted by care providers as well as by the patients. And this may lead to delays in seeking care and eventually worse outcomes. So I think it's important to keep that in mind. The other potential cause that complicates issues is the fact that there might be multiple sources of cardiac pain or potentially mimicking cardiac pain. Musculoskeletal pain due to synovitis or referred back pain might be confusing. Pulmonary involvement is pretty common in many rheumatic conditions and might cause dyspnea. Pain syndrome such as fibromyalgia is very common among our patients and can cause multiple symptoms that can confuse us. And deconditioning due to sedentary lifestyle that affect many of our rheumatic patients can lead to delay in occurrence of symptoms, but also low ability to perform exercises. And then there are these weird and wonderful cardiac manifestations that have been reported in rheumatic conditions such as myocarditis and vasculitis and pericardial effusion. And all of these can affect patients with RA or lupus predominantly. But I think it's important to keep in mind that atherosclerosis remains the #1 cause and source of cardiac involvement in rheumatic diseases, and it should be kept high in the list of differential diagnosis. I was looking for some literature that assessed whether there is any difference in the initial presentation of cardiovascular diseases in rheumatic patients and non-rheumatic patients, and I couldn't find anything. But this study from the Mayo Clinic suggests that there might be different presentation in patients. In this study, they compared patients with RA to age and sex matched non-RA patients. And they showed that the risk of developing silent MI and sudden cardiac death as an initial manifestation of the disease was much more common in RA patients compared to the comparators. In contrast, angina, surprisingly, was less common in RA patients compared to the general population. And this suggests that perhaps the clinical manifestations might be different in RA patients compared to non-RA patients, or that healthcare provider might misinterpret the initial manifestations, which then leads to the fact that the initial presentation might be more life-threatening, such as sudden cardiac death or silent MI. But this certainly needs more research. So the key message that I wanted to convey here is that think about abnormal presentation of more common diseases. Cardiovascular presentation may be atypical in rheumatic patients, but atherosclerosis remains the most common underlying mechanism of cardiac involvement in rheumatic patients. So it's important to keep that in the differential diagnosis. The second case I wanted to present is that of a 56-year-old man who was pretty active and completely asymptomatic. He had rheumatoid arthritis that was recently diagnosed and was stable on treatment with Plaquenil, methotrexate, and golimumab, which is a TNF inhibitor. Other than a positive family history of premature cardiovascular disease, he really didn't have any other cardiovascular risk factors, and his physical exam was unremarkable. His calculated risk was revealed an estimated 10 years risk of 2.5, which puts him at a low risk category. As part of our assessment, we send all of our patients to a CT of the coronaries, and this guy had a very high coronary calcium score. And again, we perform as part of our assessment exercise stress echo, and during his stress echo, he developed transient ST elevation. He was referred immediately to do a coronary angiogram and was found to have a culprit lesion in the mid-LAD, which was stented. He felt great before, and he's doing well now, but I think this one was really prevented something really bad from happening in the future in this guy. I think the message from this case is what has been mentioned over and over by the previous speakers, that clinical and conventional scoring system tend to underestimate cardiovascular risk in rheumatic patients. It has been shown in RA, and this is an example in a psoriatic arthritis population where the observed risk was higher than the predicted risk. This study was done by a group from the Mayo Clinic. And one of the reasons, of course, is that in many of these conventional risk scoring systems, rheumatic diseases are not considered as an independent risk factor or enhancer of the risk. Another reason might be the fact that this lipid paradox might change the relationship between the lipids and the estimated risk, because instead of that U-shaped relationship between lipids and cardiac risk that we see in the general population, where elevated lipids are associated with higher risk. This has been reported predominantly in RA, but also in PSA, where inflammation leads to increase in the levels of the lipids, but has also a beneficial effect, and therefore the result is flattening of this curve. So this leads to an abnormal relationship between the lipids and the estimated risk, as calculated by the conventional scoring systems that were developed for the general population. And as mentioned before, Euler suggested using this multiplication factor of 1.5 in patients with RA. No specific recommendations were given for other rheumatic populations. And the NPF recommended recently using the same multiplication factor in patients with psoriasis with severe disease. However, at least in RA, this approach of using multiplication factor was tested and was not found to really improve cardiovascular risk stratification. In this study, they've shown that it only reclassified a few patients above the treatment threshold. So it's really not clear whether this approach really improves our ability to identify patients that are at high cardiovascular risk. So what about imaging-guided cardiovascular risk stratification? And similar to Nehal, I'm a big fan of imaging. I do ultrasound, and ultrasound is used in rheumatology clinics quite frequently to assess inflammation in the joints. So what if we take the probe and place it on the neck? It's really the same probe and the same software. We can identify plaques in the carotid artery, and we know that there is a good correlation between the atherosclerotic burden in the carotid artery and what we can find in the coronary arteries. In our cardiorheumatology clinic, we found that 37% of the patients have carotid artery plaques. Remember, this is a primary prevention clinic, so none of these patients have a history of cardiovascular disease. Almost 50% of the patients had coronary calcifications, and 22% of the patients had high coronary calcium score. And if we look at the correlation between atherosclerosis either in the carotid or in the coronary and the Framingham risk score, we can see good correlation, but you can see that the patients in yellow are those with atherosclerosis in the carotid and in the coronary arteries. You can see that even in the intermediate risk categories, a significant proportion of the patients, more than 50% of the patients had atherosclerosis in their carotid or in the coronary arteries. So particularly in these risk categories, imaging might provide beneficial information beyond what clinical scoring systems provide. And more recently, we evaluated the ability of vascular imaging to improve cardiovascular risk stratification. We analyzed more than 500 patients with psoriasis and psoriatic arthritis that have been followed prospectively over time. 23 patients developed incident clinical cardiovascular events. And we found that the extent of atherosclerotic plaques predicted future clinical cardiovascular events independently of the Framingham risk score. And more importantly, we found that this improved risk reclassification of patients, suggesting that the assessment of atherosclerotic plaques using imaging could potentially improve cardiovascular risk stratification, at least in patients with psoriatic disease. And similar smaller studies have suggested the same thing in rheumatoid arthritis as well. What about cardiac biomarkers that are available to us in our hospital lab? 11% of the patients that we see in the clinic have elevated troponin T, and 25% of the patients that we see in our clinic have elevated NT-proBNP. These are two readily available tests. And more recently, Keith Colasso is a PhD student that is working with me, used a large cohort of psoriasis and psoriatic arthritis patients that we have in Toronto. And we analyzed 1,000 patients that have been seen over the past 20 years. We used samples from our biobank, and we measured the levels of NT-proBNP and troponin, and looked at the ability of these biomarkers to predict clinical events within 10 years period. So what we found is that both of these biomarkers predicted clinical cardiovascular events. Interestingly, the strength of association was higher in males than in females. And this association remains significant after controlling for the Framingham risk score. However, when looking at the ability of these biomarkers to improve prediction by adding them to the Framingham risk score, we didn't find any improvement in the area under the curve or in the metrics related to reclassification, suggesting that using the use of these biomarkers for primary prevention in patients who are asymptomatic is probably not beneficial. So the key point that I wanted to convey here is that conventional clinical cardiovascular scoring systems tend to underestimate cardiovascular risk. There is data to suggest that vascular imaging could improve, especially in patients with intermediate risk groups. So this should be strongly considered in this patient population. So this is the final case that I wanted to present. And this case is of a 79-year-old man with rheumatoid arthritis for 10 years. He has a history of hypertension that is treated by candesartan and hydrochlorothiazide. And he mentioned that he has had ephrodyspnea when he walks slowly. He has occasional palpitation, and he also noticed some swelling in his legs. On the physical exam, he had slightly elevated blood pressure, he had irregular heart rate, and he was found to have bilateral leg edema. His troponin was normal, and his coronary calcification showed only mildly elevated score, but his NT-proBNP was high, and on the ECG was found to have atrial fibrillation at a rate of 77. Echocardiogram showed asymmetric septal hypertrophy and a normal LV function. So he was diagnosed as having atrial fibrillation and heart failure with preserved ejection fraction, and was treated with an anticoagulation rate control approach, and was given Lasix to improve his symptoms. I think I briefly want to talk about heart failure because we've discussed a lot atherosclerotic cardiovascular diseases and only mentioned briefly heart failure. I'm sure many of you are aware of this classification of heart failure with reduced ejection fraction that has predominantly been associated with ischemic heart diseases and is more common in men. And the more recent research has focused on this heart failure with preserved ejection fraction that is predominantly seen in people with multimorbidities, has been associated with inflammation and metabolic syndrome, and is more common in females as well. Heart failure has been associated with rheumatic diseases, and it's been shown both in RA and PSA that the risk is between 20 to 40% higher. And there's been also some more recent studies looking at imaging, both structural and functional imaging studies that showed abnormalities such as abnormal strain, hypertrophy, cardiac MR showed increase in fibrosis and edema. So these are more common in rheumatic patients. Similarly, ischemic heart failure has been shown to be more common in men, similar to the general population, and non-ischemic heart failure has been shown to be more common in females with RA. And in general, seropositive RA has been associated with a higher risk compared to seronegative RA with respect to heart failure. We've recently published this paper in Arthritis Care and Research, where again, we evaluated a large cohort of psoriasis and psoriatic arthritis patients in Toronto. We analyzed almost 2,000 patients here. And we've found first, with respect to absolute numbers, 5.5% of the patients, the males in the cohort developed heart failure by the age of 70, and 2.5% of the females developed heart failure by the age of 70. So it's not an uncommon event in this patient population. We then used a very rich database to analyze risk factors for heart failure in this patient population. And not surprisingly, a history of ischemic heart disease was the strongest risk factor for heart failure. But even after adjusting for ischemic heart disease and other conventional risk factors, we found that disease activity matters. So we found that patients that had higher tender and swollen joint count, patients that had higher levels of inflammatory markers over time, and patients that had physical dysfunction were at a higher risk of developing heart failure. In contrast, we found that minimal disease activity states, so patients that were doing well with respect to their control of their disease activity, were at a lower risk of developing heart failure. So both conventional traditional risk factors as well as disease activity measures predict future heart failure in psoriatic disease. We also analyzed some imaging data that we had. So first, in this cohort, 41% of the patients that developed heart failure did not have a history of ischemic heart disease, so suggesting potentially an alternative mechanism or a direct effect that might lead to heart failure. 63% of the patients had preserved ejection fraction, and 22% of the patients had associated atrial fibrillation. That many times goes with heart failure with preserved ejection fraction, as was in the case of the patient that I've mentioned here. So I've shown you some recent data about heart failure, and similar to ischemic heart diseases, the risk of heart failure is increased in patients with rheumatic diseases, both ischemic and non-ischemic, suggesting a mechanism through cardiovascular diseases, but potentially also a mechanism that might have a direct effect on the myocard. Controlling of traditional risk factors, as well as controlling of disease activity, may lower risk, but of course we need more studies. And in summary, these are the messages that I was hoping to convey. I wanted to highlight the importance of keeping high level of suspicion for cardiovascular diseases in patients with rheumatic diseases as they may present in an atypical way. Use conventional scoring systems for cardiovascular risk stratification, but consider vascular imaging as it has been shown to improve cardiovascular risk stratification, and controlling inflammation suggests that we can potentially reduce cardiovascular risk. This is important. I wanted to thank our team from Toronto. Dr. Harvey and Dr. Akhtari are the two cardiologists that I work with, and I wanted to thank my research team and our funders and collaborators. And thank you for your attention.
Okay, that was great, Leahy. Thank you so much for that talk. And I'm really struck about how fortunate it is that you've established that clinic in Toronto. And we have had a similar clinic we've done, probably for over 10 years now at Penn. And there's just countless patients that we picked up, subclinical cardiovascular disease, and able to intervene to prevent events. So we're fortunate to have this type of opportunity. So we're going to go into a panel discussion now. I want to welcome two members to our panel. First, Stephanie Hopkins. Stephanie, if you can maybe raise your hand so we would know who you are. You're in the bottom right panel. There she is. All right. And Stephanie is a nurse practitioner at the Center for Prevention of Cardiovascular Disease. And among her busy clinical responsibilities, she conducts in-depth patient education on cardiovascular risk factor control and lifestyle modification in both the outpatient and inpatient setting. And then I'm also pleased to welcome Dr. Kristen Losico. Kristen, maybe you could raise your hand, wave away there. Here we go. Who's an associate professor of dermatology at NYU and director at the historic NYU Skin and Cancer Unit, where she attends and precepts dermatology residents in the phototherapy clinic. That's some special interest to me, as well as general and complex medical dermatology. She conducts clinical research on novel therapeutic and does novel therapeutic trials that focus on alopecia and complex medical dermatology. So happy to welcome you both to our panel. And I think I really want to start with our clinicians first. So, Kristen, from your perspective as a busy dermatologist, trying to get through a morning or afternoon with patients, and you see someone who's got moderate severe psoriasis, maybe they're in their 40s, they're a little overweight, they're slightly hypertensive based on the intake blood pressure. What do you talk to your patients about? How do you work in a discussion of cardiovascular risk when you're talking to a clinical patient?
Yeah, I think you can hear me okay, yeah?
Yeah, I hear you great.
So I think it's very challenging. Remember that the average dermatologist has about 10 to 15 minutes with any new patient. It's incredibly challenging. You see somebody for the first time, they might have moderate to severe disease. And not only do you need to evaluate their skin fully, but you need to have X, Y, and Z conversations, right? What are the therapies that are available to treat their psoriasis? And then what are the associated risk factors, and how do you mitigate those risk factors? Incredibly challenging to do in a 15-minute visit. How do I do this? Well, fortunately, I'm allotted a little bit more time with my patients, and so we sit down. We first, I think the one bias that we have as a tertiary care center is that we end up seeing a lot of the patients that have more moderate to severe disease that are referred by a lot of the private clinicians in the community. Because they are oftentimes more pressured for time, and so end up seeing a lot of the patients with more mild disease. And again, that's average. We determine what severity they have, and then we'll discuss risk factors. So I'm very big in mitigating any potential risk factors. So I'll talk about the cardiovascular risk factors. Many patients are very surprised to actually hear of the association between the risk of cardiovascular disease and psoriasis. It's often new to many patients, including those who have seen previous dermatologists as well. However, they are very receptive to preventative care. So if they don't already have a cardiologist, they're oftentimes open to seeing one, and we will do that. We will refer them to a cardiologist as well for preventative care as well. And not to mention as well that a lot of these patients already have other cardiovascular risk factors, like you said, someone who's overweight, I'm also very spoiled at a tertiary care center that there's a clinic for that. We can send them to nutrition. Smoking, tons of smokers as well, too. I also have that conversation, but it's very easy for me to stand here and in 2 minutes get on my soapbox and tell somebody to stop smoking. That's not going to do the trick. I ask them, are you really ready to quit? We would love if you are, and then we'll actually put a referral for them to go to our smoking cessation clinic as well. So it really does require multidisciplinary care. And dermatologists, remember, are oftentimes the first clinicians that see these patients. So it's our job, and I feel like it's a great opportunity for us as dermatologists to act as allies in the preventative care of these patients and to collaborate with other clinicians like cardiologists.
Chris, it's a great way to start us off here. And I think that, you're really exemplifying the standard of care that we would love to see, all of our colleagues give to our patients out there. So let's say, you've seen your patients, you've educated them about cardiovascular risk, and you're fortunate you're at NYU where you have Stephanie Hopkins you can refer the patient to. So Stephanie, give us a little bit of a sense of, what your perspective is in working with people with chronic inflammatory diseases. A lot of our patients, don't want to be on more medications because they're already on chronic meds for their underlying inflammatory disease. They may have some anxiety, depression that's related to their chronic skin disease or joint disease they've been dealing with. They may be adverse to some of the interventions we want to do. What's been your experience working with this patient population, and how do you approach them?
Great question. I'm the nurse practitioner for the prevention center at NYU, and my experience with these patients and really all of the patients at the prevention center is showing them the data and going over the science with them. I think that's really important. I know just as others have echoed, there's a lot of time constraints, but thankfully for me, with my clinical role, I do have more time to spend with patients talking about lifestyle and nutrition changes that they could make and exercise patterns that they should adopt. So I think that once you have a very honest and true conversation with folks, a lot of them are already motivated. That's why they're coming to see you. So I think that just showing them the science, going over it with them, answering their questions, talking to them about things maybe they've read online and disproving that is really important and often works.
And in terms of pharmacotherapy, using things like statins, things like that nature, patients tend to be open to those things. They hear about the risk of myalgias. It's often something that a lot of our patients are dealing with chronic pain as it is. How receptive are patients to statins and other prevention medications?
Yeah, it's very common that we take care of folks that have read numerous things online, and they come to us with already these symptoms that they think that side effects that they think they're already going to have. And I think that's important to tell them that we have plenty of medications to choose from. So if this medicine does not work for you, then we can try another statin. And there are plenty of them to choose from. And if statins aren't the drug that work for you, we have other agents that can help you with your cholesterol. So I try to be as positive as I can and telling them that we have plenty of medications to treat their cholesterol. And it's not just statins if it doesn't work out for them. Of course, we want that to be the drug that does work out, but we have to just meet folks where they're at and take care of the symptoms that they have and do our best at helping them.
Yeah, I think that's exactly right. Our ability to really give personalized care to patients, trying it, we know reproducibly they're going to lower their LDL, that there's a small percentage of population who has myalgias. It just goes away when you stop the drug, and you may have other options. So Leahy, let's come the conversation towards you. And someone in the audience has asked about whether or not you look at left ventricular strain as a way to predict heart failure in your patient population. And as an add-on to that question, I also want you to sort of address the issue of TNF inhibitors. There's a warning that they could induce congestive heart failure or aggravate congestive heart failure. How do you think of the use of TNF inhibitors in this patient population, in addition to the LV strain question?
So if I may just made a few comments in relation to what previous panelists had mentioned in terms of recommendations for patients. I think, in addition to or having the benefit of having a combined clinic, I think what we try, I think our role as rheumatologists is to make sure that patients are under control and make sure that all of the domains, especially in patients in psoriatic arthritis, for example, that the skin is under control as well. And I use actually the cardiovascular diseases as a sort of an excuse, and this often convinces patients with residual skin disease to see the dermatologist to manage these additional inflammatory activities. Specifically with respect to TNF inhibitors, I think I'm sure many of you are aware of the early trials in heart failure patients, very severe heart failure that failed trying to use TNF inhibitors as treatment for heart failure. But later on, observational studies in mostly rheumatoid arthritis didn't show any signal of worsening of heart failure. And I think certainly in patients with mild heart failure, and there are no concerns or significant concerns of using TNF inhibitors. And there's been also studies that show that it may also potentially reduce the risk, of course, with all the problems of observational studies that we've discussed in terms of potential biases that exist. I don't know that we can answer this question for certain, but again, there's been some signals looking at surrogate outcomes, imaging outcomes, that TNF inhibitors in rheumatoid arthritis could potentially improve some of these surrogate outcomes. So I'm not too concerned about heart failure in this context. Of course, if in patients with more severe disease, I would consult my cardiology colleagues to discuss this.
And we had a question about LV strain from the audience. If you see that on echo, does that change how you think about that person, how you think about TNF inhibitors, you're concerned about them developing heart failure, things of that nature?
Again, I'm not a cardiologist, I'm not specialist in echo, but and my understanding in terms of strain is that at this point is more, there is some data to suggest that it could potentially help, especially in patients with preserved ejection fraction, and identify early abnormalities in heart function. But at least in our center, I don't think they use cardiac strain as a routine measure to help them.
And Joel, I do think, excuse me, Lihi, and Joel, I do think that the audience might be getting at the fact that what Lihi, you just touched on at the end, in those with preserved ejection fraction, there are now data that, there's diastolic dysfunction, and strain may be a way of picking that up, and maybe perhaps understanding who is at risk for future development of heart failure. So
yeah,
thanks.
But Nehal or Michael, if you pick up LV strain, some signs of diastolic dysfunction on your cardiovascular workup on patients, do you think that there's a concern about using TNF inhibitors in that patient population, or it's too early, you're not particularly worried?
I think what I would look at, I would not do that, but what I would look at, Michael, and I wonder if you feel the same way, is that if you do see it, think that you haven't diagnosed hypertension. So the first thing I would do is look back for a second and say the patient's probably hypertensive, maybe growing a thicker LV. And then if it normalizes and everything looks okay, I don't think there's any reason not to use an anti-TNF. Michael, what do you think?
Right, so I have, going back to the prevention clinic, I have a very, very low threshold to get a 24-hour blood pressure monitor. So we don't routinely do strain here, but we've been talking about forever biomarkers, and since we're getting an echo, adding on strain is not so hard compared to many of the other things that we do. So any patient with any signs of LVH, any dilated left atrium, any hypertrophy or diastolic dysfunction, which isn't appropriate for age, I'll usually try to get a 24-hour blood pressure monitor, just because we know these patients are so underdiagnosed, and masked hypertension is a risk factor for cardiovascular disease, more so than white coat hypertension.
And and Michael, one thing I have to put the plug in there for the work that we're doing now, you and I, is that when you do look at the algorithms, the most potent risk factors are in fact dyslipidemia and hypertension in progressive vascular dysfunction. So whether you want to talk about the myocyte or the vascular endothelium, and then your data today very elegantly showed that LDL was related to vascular inflammation, and that statin treatment actually could revert that back to somewhat of a reduction. So sorry, I had to interject that hypertension, latent hypertension, is very dangerous in this population.
Yeah, I think we probably did hypertension a disservice this whole session by not giving enough credence to how much it can damage. Next year. But
I will say we see a ton of white coat hypertension in my clinic, and so I wonder if patients with inflammatory disease are more prone to that phenomenon, because we see so many patients who have elevated blood pressures, and they always say, "Oh, I have white coat hypertension," and I always explain to them, like, go to the local pharmacy, stick your arm in that thing. It should be 120/80. If it's not, you got to be in touch with your primary care doctor usually. So, Michael and Nehal, maybe we'll start with Michael first. I mean, I'm very fortunate. I get to work with people like you right next door. You're always an epic in-basket message away for me to get a patient in to be seen. But for those clinicians out there who are taking care of patients with inflammatory diseases, which of those patients should they be considering sending to a preventative cardiologist or a specialized preventative cardiology clinic, as opposed to saying, "Oh, go see your primary doctor"?
Right. So that's a really good question. And I think it kind of, you have to mesh what we're saying here, which is very, very aggressive care, which is the reality that you don't want to overburden the healthcare system by sending, every single patient. It would be great if we could, but I think there's a shortage of doctors, a shortage of primary care doctors, cardiologists, and everybody. So what we've actually done we've tried to do in the psoriatic arthritis clinic, and to some extent the psoriasis clinic too, is just kind of put up these very easy cutoffs, which may not be aggressive enough, but at least it allows something. So for example, if you do see a one-time blood pressure 140 over 80, send them to us. Check the hemoglobin A1C. If it's certainly over 6.5, send them to us. BMI over 30, send them to us. LDL over 130, send them to us. And probably that's not aggressive enough. As we've heard here today, I want to be very clear about that, but I think it's not a bad way to start. And the data from both you and Nehal show that you'll find plenty of those patients as is. So that's how we've tried to start.
That's right. Yeah. And Nehal, coming back to some of the work that you showed earlier about, cardiovascular risks and dyslipidemia is accumulating early, even in children with psoriasis. So what should we be doing when we talk to a person who's in their 20s, and they have psoriatic disease or they have rheumatic disease? Obviously, their risk of having a cardiovascular event in the next 10 years is essentially zero, but their lifetime risk is probably pretty substantial. How should we counsel those patients? And should those people be seeing specialty clinics?
So I think at the end of your question, you answered it, which is just addressing it. Really, I think Kristen brought this up early, that a lot of people are still surprised by the association. So what I've been doing down here at the cohort, where we have probably 50 to 60, 20 to 30-year-olds that we've been following now 4 to 5 years, the first thing I would say is that fat accumulates quickly in this disease, and I'm not sure why. It could be adiposity dysfunction due to inflammation. So watching their weight is very important. Educating them that they're definitely metabolizing food differently because of this disease. And what I tell my 20-year-olds is keep active. Exercise is possibly the best thing 5 days a week. And if your body can take it and you don't have psoriatic arthritis. The last thing, Joel, I think is really important for the 20-year-olds to hear is the importance of avoiding smoking tobacco, smoking marijuana, and then also limiting their alcohol intake. There's a good amount of literature now that binge drinking in this population is associated with bad outcomes, with hypertension especially. So the 20-year-olds, you got to kind of talk about that, because you're right. You look at a risk score and you look at their coronaries. A lot of them will get their coronary reports and be like, I'm clean, I'm good, I'm going to go crazy, but they don't understand that that's actually steepest in their 40 to 50s. So this starts early. I think, the paper that I showed, 8 to 13-year-olds, we actually keep a PDF photo of that in our recruitment packet, saying that if you know of friends and family who have psoriasis or kids with psoriasis, please let them, find a pediatric provider. We've shown this starts early. So Joel, I guess conferences like this might be another good venue to talk about that.
Yeah, these are really good pearls, I think, for those who are listening along here. Education about lifestyle issues and the connection in younger patients, they could make good lifestyle modifications. And then as people are getting older, screening for the A1Cs, looking at their blood pressures, if they have an elevated BMI or their HSCRP is elevated, these are people with prime candidates probably to go to cardiovascular risk prevention clinics beyond the sort of routine evaluation. So we're getting towards the end of our time together. I want to make sure we break plenty of time for happy hour, as we are on a Friday afternoon here, and socially distanced happy hour, Nehal. And I will just say, so Lee, I'm curious from your perspective. So we talk a lot about treating rheumatic diseases and psoriatic diseases and other inflammatory conditions to, aggressively to try and lower that cardiovascular risk. But what if we flip this idea and say, do you think treating cardiovascular risk factors, managing, using statins to treat atherosclerotic disease could improve rheumatic or other inflammatory conditions? I mean, we know when someone has atherosclerosis, they have elevated CRPs, which could be part of the inflammatory milieu that aggravates an inflammatory condition. What's sort of your thinking on this?
I think it's an excellent question. I think there is some data to suggest that maybe there is a mild effect, anti-inflammatory effect for statins especially in rheumatoid arthritis. It's been shown, but more recently, I think I kind of became more interested in these lifestyle changes, especially exercise and weight loss or changes in diet. I think this has huge potential, and many patients don't like to take more medications, right? So I think this is an area that we know is beneficial, and I think we need to find ways of implementing these recommendations and convince our patients to start moving, eat better, stop smoking. These lifestyle changes carry, I think, more potential effect to improve both cardiovascular as well as the inflammatory milieu and benefit the skin and the joints as well. There's been some strong data in psoriasis, actually, that weight loss can improve skin disease.
Right. I think it's one of the sort of advantages of trying to prevent cardiovascular disease in people with inflammatory conditions, in that sometimes some of the things we do to lower cardiovascular risk may make the patient feel better or have their skin be clearer. And, traditionally, cardiovascular risk factors are asymptomatic. You lower their LDL, they feel the same, or you lower their blood pressure, they feel the same. And in this case, there may be additional benefits that really allow patients to feel, that positive feedback of the changes they're making. So we are close to the end of our session. Yes, Kristen, I was going to ask you now for your clinical pearls. So give us some clinical pearls, because you're going to help us wrap up. We're going to go to Stephanie, and then we're going to go to Michael and Nehal to close us out.
Oh, sure. So I wanted to just add one other thing about statins as well. So we know that most dermatologists are at least peripherally aware that statins improve cardiovascular risk in patients with psoriasis, but a lot of them are not aware of the meta-analyses of the randomized controlled trial showing that statins may actually also improve psoriasis itself, especially in patients with severe disease. So that's number one, is bridge the gap for knowledge. Number two is bridging the gap and having dermatologists be comfortable as the ones prescribing the statins as well. The average dermatologist is not. Perhaps it's because we're biased that we end up seeing a lot of the cutaneous side effects of medications, including statins as well, or including photosensitivity as well. So if I have a patient in our phototherapy unit who is newly on a statin, we end up decreasing their narrowband UVB dose by 10%. Go ahead.
No, I'm sorry, I didn't even interrupt you. Go on.
What was another thing that I was going to say too? I had all of these things in my head as I was listening to everybody else speak as well. Other important thing too, when we see patients with scalp disease for psoriasis and with nail disease as well, we also have the conversation with them to say, you might have psoriasis on your skin right now too, but having involvement in these areas increases your risk of developing psoriatic arthritis throughout your lifetime as well. So you need to pay attention to those symptoms as well. And if they do, then we send them to rheumatology. We also have the advantage of having the wonderful NYU rheumatologists come to the subspecialty clinic and a rheum derm clinic at least once a month, focused on psoriasis specifically.
Yeah, that a holistic approach really makes a big difference in the lives of our patients, no question about it. And I know always my patients always really appreciate it. And it's gratifying as a clinician to pick these things up. When you identify psoriatic arthritis and either put them on a treatment that helps them feel better or get into the right rheumatologist, they really are appreciative of that, of course. Or when you identify cardiovascular risk factors and send them to Nehal or my colleagues at Penn, and all of a sudden they do an image and they realize they got a blockage in the LAD, and people are like, you saved my life. And it's really a gratifying thing to do as a clinician. Stephanie, what final thoughts do you have for us that we should keep in mind?
I think that the talk has been fantastic today. I mean, from everyone that has given a lecture, this has been a fantastic talk. So Dr. Garshick, Dr. Mehta, congratulations. This is a wonderful, wonderful symposium. For the patients that are listening, I think that it's extremely important to have somebody on your team, to have a provider that's also a good coach and to help you on this journey, because this is easier said than done, right? We're talking a lot about lifestyle changes, and a lot of these things, you may have been doing since a child. A lot of your relationship with food is cultural and it's emotional. So it's really important to have a good coach and someone on your team that is going to be with you each step of the way and really help you transition to a better lifestyle. So, following up with your doctor periodically, making sure that you have a very comfortable and good relationship with that provider is extremely important. And baby steps, taking each day as a win if you make a healthy choice with food. And every minute that you exercise is a minute closer to good health. So just keeping that in mind and finding a provider that you click with, that you feel comfortable with, and is a good coach.
That's beautifully said, Stephanie. And I'm definitely being mindful of the fact that I've been sitting in my chair all day listening to this great conference. I will be in my gym as soon as this thing is over. So, all right. So let me turn it over to Michael and Nehal to close us out. I want to thank you all for a great panel discussion. And I want to thank Nehal and Michael for really a terrific conference today.
Joel, thank you. Michael, go ahead.
I'll be very, very brief. It's been a very long day. Thank you all for coming. It's been wonderful. And we really hope to see you next year. And if you have any questions or any concerns or any comments, please email me, email Nehal, email our prevention center. And thank you for sticking with us towards the end. We still actually have a lot of people signed on, so that's fantastic. So thanks.
Nice job. Joel, thanks for moderating. Leahy, thank you for an informative talk as always. I really appreciate it. Kristen and Stephanie, a great session, a great way to end the day. I feel like, it's important we all realize that we are moving the dial together. We will get statin prescription into the hands of derms and rheums, and remind your patients a healthy lifestyle actually matters with primary cutaneous skin disease coming from the cardiologist. So have a great afternoon, everybody. Thank you.
Thanks, everyone.
Thank you all.